workshop has various components as we have planned. The initial half day would all be devoted to video workshop, where we intend to see and learn from some of the common and not so commonly performed endocrine surgical procedures, mostly from our, I mean, from various experts from across the country and some abroad. And then in the afternoon, we would have a microwave ablation workshop and kind of mini workshops on intraoperative neuromonitoring and use of immunofluorescence in endocrine surgery. Uh, the purpose or the reason why we thought we should have these workshops is, I'm sure all of you would agree, as endocrine surgeons, we need to keep abreast with whatever new technologies come in and whatever newer procedures and strategies are evolving. We must evaluate them, adopt them in our clinical practices, eventually care better for or treat better our patients. So the purpose of this workshop is exactly that, to provide some glimpses into what is contemporary and what the future holds for all of us. Essentially, we all must not be left behind in this race. So I all participants and the faculty. We have some eminent faculty. Let's learn from them and not miss out any tricks and tips they will share during the day. And that will also be appropriate, respectful tribute to them today on this Teachers' Day. I would also remind all of my guests and colleagues that we organize these courses entirely in-house. The organization is all done by my faculty colleagues and the residents in the department and the staff. And we do not have a professional event manager. So there would be shortcomings. I hope you will be able to accommodate and overlook these imperfections and shortcomings. But what I can assure you all is there will be no dearth of efforts from any one of us to give you the best possible experience today and over next 2 days. So welcome all again, and we start today with the workshop, and then at any given time, anytime if you have any suggestions to us, feel free to walk up to me or message me. We must also have an eye on the time. And everybody's interest at the time must equally have, I'm sure, adequate time for interaction with the audience. And with I welcome. Thank you.
I would like to invite coordinator for today's session, Professor Gyan Chand, to briefly describe about today's workshop. Thank you.
Morning, everyone. A warm welcome to all of you for this video workshop. So this is the aim of this workshop is to state some cases by expertise and describe the techniques, describe the tips and tricks for the management of this operation. And you have to be more interactive, ask the questions, clear the doubts, and learn together. So we start with the video workshop. Thank you very much.
Thank you, sir. To begin with, I invite our chairpersons for the session, Dr. Kushag Gaurav and Dr. Navneet Tripathi. Kindly take their seats on the dais. Our first presentation will be by Dr. Chitresh Kumar on open thyroidectomy.
I would request everyone to please be on time because our screens will go blank after the completion of the due time. Thank you.
Good morning, respected teachers, my colleagues. As I'm presenting a video on the total thyroidectomy is a basic procedure we all endocrine surgeon must learn. And perhaps it is the first surgery we have performed under the guidance of our teachers. So doing a thyroidectomy is easier than creating a collecting a video and recording a video. And representing your own video is far more difficult. It's like collecting video evidences against your own surgical skills. So I cleverly omitted this and I borrowed one of my junior, Dr. Chandan. So this video is belongs to him. So I am presenting it. So it was a 63 years male presented with sternal swelling. And during evaluation, we found that he's also having a thyroid nodule. So clinical diagnosis is very obvious: thyroid swelling with skeletal mets or external mets is a follicular thyroid cancer. And on evaluation with CT scan, clinical examination, it was a 8 into 8 centimeter from pulsatile mass arising from the sternum. In thyroid examination, there was a bulky thyroid, but no definite nodules was palpated. CT scan proved that he is having the thyroid nodule along with the sternal mass. So biopsy was taken from the sternal mass, and it was proven that it is a metastatic follicular thyroid carcinoma. And the management plan is very clear for these kind of patients: total thyroidectomy first, followed by the radioactive iodine ablation. Slides, sir, please put it on slides, sir. So there are basic steps in the open thyroidectomy. First and foremost important thing is the incision, planning an incision. So incision is a classical collar incision extending from the anterior border of the sternocleidomastoid both sides, then raising a flap. Flap can be raised with the cautery or the knife or scissors, and then tackling the anterior jugular veins. You can tie the anterior jugular veins if you think that you have to cut the strap muscles horizontally or the large thyroid mass is there. Otherwise, you can omit that step. And then if thyroid mass is larger, you want to separate the strap muscles with the sternocleidomastoid. Then flushing the sternocleidomastoid, you have to create a plane between the sternocleidomastoid and the strap muscles. And you have to retract the strap muscles laterally. Then when you separate the strap muscles, and when you are retracting laterally, you will find the omohyoid and you have to cut the omohyoid tendon. Then you will find the middle thyroid vein. It is a very thin structure draining in the interjugular vein. So you have to carefully ligate the middle thyroid vein. In this particular patient, there was a tumor thrombus in the middle thyroid vein. So when you tackle the middle thyroid vein, then you have to open the strap muscles in the midline at the linea alba. If you are not intended to cut these strap muscles. So if thyroid mass is large, and if you surgeon think that there will be difficulty in delivering the lobe, then we can cut the strap muscles horizontally also. So in this case, the strap muscles was cut horizontally. Then the strap muscles are dissecting off from the thyroid plane in the thyroid gland, and then the thyroid will be exposed. This is the most crucial point, because when you approach the upper pole, you have to pull down and outward the upper pole. Then you will reach in the space of rib. So where you find the external branch of the superior laryngeal nerve. This is the most crucial step in safeguarding the external branch of the superior laryngeal nerve. Then the superior pole vessels should be ligated individually, and after tackling the superior pole, you have to do the capsular dissection. Capsular dissection is must, because you will safeguard the parathyroid. If you are in the capsule, just over the capsule, in the loose areolar tissue, if you are dissecting, then your parathyroid will be safeguarded and the vascular supply will be intact. And after safeguarding the parathyroids, this is the tubercle of Jacob Pendle the surgeon is trying to palpate. So the nerve is medial and posterior to the tubercle of Zucker candle, and the superior parathyroid is also around the tubercle of Zucker candle. So when you palpate the tubercle of Zucker candle, try to lift it and rotate the thyroid lobe medially. And this is the Berry's ligament. When you go upward and medially, you will find a dense condensation in the posterior surface of the thyroid. And you have to dissect it carefully. You can ligate it, or you can use the bipolar or vessel sealer, whatever you want. And then you have to lift the thyroid from the trachea. Inferior pole, we can approach or tackle at this time or after safeguarding the recurrent laryngeal nerve. So this is the inferior pole. It was not sutured, it was ligated with and cut with the harmonic. Then we have to lift the entire thyroid gland above the trachea. This is the opposite side. The same steps should be repeated on the opposite side. And the care should be taken when you are dissecting of the median portion of the thyroid, because there is a pyramidal lobe. If you are dealing with the malignancy especially, you have to dissect the pyramidal lobe along with both the lobes, because otherwise in the post-operative radioactivity scan, there will be a uptake in the thyroid bed or in the midline. And then after removing the entire thyroid gland, you have to check for the hemostasis. In this case, particularly drain was not put. Drain is not essential if you are sure that the hemostasis is good. Then the strap muscles are closed. The platysma you may omit, or you can suture it in intermittent manner. Then the skin in subpedicular fashion. So because the time was less, I intentionally keep the video for 5 minutes so that we can discuss the important points in videos over, please.
So excellent presentation, Dr. Chitresh. What strategies you follow to consistently find the RLN for beginners? Like
In the literature, there are, I think, 10 or 12 pointers, spaces, and the triangles have been demonstrated. But the most common thing is, don't be confused with the names. The nerve and the inferior thyroid artery will always cross each other. So do not try to cut the inferior thyroid artery at first. You just identify the inferior thyroid artery and try to look below the inferior thyroid artery in the Simon's triangle between the carotid artery or the inferior jugular vein in between the tracheoesophageal group. So it is a triangle. It's called Simon triangle. So try to find the nerve in that group. And then you follow the nerve upward till the Berry's ligament or Entry's point, where the Wang's point is there. It is a consistent point where the inferior horn of the thyroid cartilage 1 centimeter below that point. So you'll follow till that point, and do not try to use monopolar the nerve. Try to use the bipolar or as much as the electrocautery or the vessel sealing devices.
yeah, agree.
And sometimes
I-
also even doing some maneuvers, you're not finding the RLN. If you're sure that you have not hurt it, you have not damaged it, do not try to explore more and more, especially if you're not going to do the central compartment dissection. By exploring more and more, you may harm indeed in the later part of dissection.
Yeah, correct. Also, for beginners, how do you balance the length of the incision with respect to the safety of the surgery? So that's a very crucial decision we have to think about.
The classical teaching is the incision should be from the anterior border of the one sternocleidoid to that. If you think that the thyroid mass is large, you have to increase it. There's no harm, or there should be no sigh in increasing the incision from posterior border to the opposite posterior border.
Yeah. So any questions from the forum? Thank you, Dr. Chitresh.
Yes. Sir, it starts from the pre-op period. If we think that patient is a vitamin D deficient and there's no urgency in the surgery, we should try to I mean, to correct the vitamin D deficiency if it is not the urgent surgery. And then sometimes some people are following the prophylactic oral calcium and vitamin D supplements in the post-op, even sometimes in the pre-op. And during the surgery, the most of the time it's a temporary hypoparathyroidism because of the vascular insufficiency. So if we should wearing a loop, if magnifying loop, and we are preserving the vessels, the feeding vessels for the parathyroid, we're not directly touching the parathyroid. And after the dissection is over, we are carefully looking for the parathyroid if it is for its color. So then we can, reduce the chances of temporary hypoparathyroidism. And even in the post-op period, we should be the threshold for the diagnosis to be very, very low. If you think that patient is having symptoms or T sign is positive, or there were some factors like Graves' disease, elderly patient, female patient, she's having some other kind of diseases, she is taking things that are causing osteoporosis. So then we can use the prophylactic post-operative calcium and vitamin D supplementation in the post-op period. So all these strategies will reduce the chances of the post-operative hypocalcemia. Yes, ma'am.
Drains.
Ma'am, most of the time we put the drain, but drain is not essential if we have a good. It's the surgeon's choice. Most of the time, most of us are not put for small surgeries, and surgical bed if it is clear.
So if there are no more questions from the house, I thank you, Dr. Chitresh, for a very nice video and informative session. Congratulations. Now I invite Dr. Chandan Kumar Jha. He's a consultant endocrine surgeon and a GPGI alumni. He will be demonstrating his video on selective lateral neck dissection.
Very good morning to all of you and happy Teachers' Day. So I will be briefly discussing selective lymph node dissection for DTC, and then it will be followed by a video. So going by the definitions, selective lymph node dissection is when we remove one or more levels of the neck, and that levels of the neck are decided by the patterns of spread of the malignancy we are dealing with. R&D removes level 1 to 5 along with the three structures, sternocleidomastoid, IJV, and accessory nerve. And MRND removes level 1 to 5 but preserves at least one of these structures. And the pattern of the neck has been studied in thyroid cancers. And as we know, most of the thyroid cancer metastasize to level 3, 4, and to some extent to 2A and 5B. The involvement of level 2B and 5A is really uncommon, and level 1 is rarely involved. So basically, for most of the thyroid cancers that are not extensively involving the neck, we need to dissect level 2A, 3, and 4, also 5B. The approach of selective lymph node dissection has been primarily accepted because when we dissect more, we create more complications. Injury of the spinal accessory nerve is much more common than we assume it to be. In one of the reviews, MRND was thought to lead to 33% recurrent rate of spinal accessory nerve injury, SLND to about 28%. And the prevalence of a spinal accessory nerve injury was more common when level 5 and level 2 was dissected. The removal of the cervical plexus of the second to fourth nerve also leads to injury of the spinal accessory nerve. Coming to the video proper, we start with a collar incision most of the time. That is what we do for thyroidectomy. And level 2, 3, 4, 5B and 2A, most of these can be accessed through the same incision. If we have a long neck, we may prolong the incision in a J-shaped manner. Dissection usually starts by dissecting the fascia of the sternocleidomastoid like we done over here. The aim is to maintain that packet of lymph node which is incisions by this fascia over the SCM, both posteriorly and anteriorly. The fascia is dissected all along up to the mastoid process. If you intend to do a level 2 or dissection as well, 2B dissection as well, followed by dissection of the fascia of the lateral aspect of the SCM. You need to identify the spinal accessory nerve in the floor of the level 5 if you want to carry a dissection of the 5A and 5B both compartments. Now, the first goal, usually we start from above downward. So the first structure that should be identified and preserved critically is spinal accessory nerve. You usually find it upwards. If you start from downwards, usually you will get to the cervical rootlets, the C2, C3, C4 rootlets, and you might confuse yourself with the spinal accessory nerve. Once the spinal accessory nerve has been identified and it is followed to the IJV, the spinal accessory nerve usually rests between the digastric and the IJV. But sometimes IJV can be, but at least in 1/3 cases, not sometimes, the IJV lies anterior to the nerve, and that in that case, one should be careful not to damage the IJV there. Once you have identified the nerve, dissect all the tissue lateral to the IJV and between the spinal accessory nerve. If you do not intend to do a level 2B dissection, you can stop there, or otherwise the 2A specimen is pulled down below there you can see the spinal accessory nerve. There was minimal involvement, no level 2A involvement on imaging. So we are doing only a dissection of the 2A, and 2B we have left it as such. At this point, one should be careful not to go too deep to avoid breaching the prevertebral fascia. But because once you go deep to the prevertebral fascia, you might injure the phrenic nerve, sometimes even the brachial plexus. Now, after this onwards, our goal should always be to stay above the prevertebral fascia. All the tissue is dissected away from the internal jugular vein. And now we are reaching another critical step where we should attempt to avoid injury to the thoracic duct, or if we injure it by mistake, we should actively look for the injury and clip it on both sides to avoid any tile leak in the fossa. Another trick to avoid entering deep to the prevertebral fascia is try to preserve the transverse cervical vessels. Transverse cervical vessels, these are also the lower limit of our neck dissection of level 4. Once you preserve it, it acts as a landmark. If you do not divide it and go posterior to it, you will most likely preserve the prevertebral fascia and avoid damage to phrenic nerve and the brachial plexus. Following that, all the tissue is swept off the prevertebral fascia, dissected with fluent and sharp dissection, and this specimen can be taken. These are the cervical rootlets, but attempt should be made to preserve it. Of course, many a times we get very bad cancers with a lot of lymph nodes, extensive lymph node involvement, and one or more of these might be divided. But as we said, some of the motor contribution to spinal accessory nerve comes from these nerves. Should try to preserve it. get started. Detected level 5, but part of it. One link node, but yes, there were one of the those was positive for testing. There you can see the spanning out. Clearly, the threads are visible. One of them, I think, was divided. That is the vagus nerve. Sometimes vagus nerve pulled very strongly and it may get injured. So that is a phrenic nerve. One should always perform a Valsalva to check for any postoperative guide leak, especially when dissecting on the left side, but doing it on the right side also wide leak from minor leakages. Take home message would be that start by elevating the sternocleidomastoid fascia and try to preserve it. It acts as an envelope. Do not miss the accessory nerve. Do not go deep below the prevertebral fascia. Preserve the deep cervical fascia. Preserve the transverse cervical vessels. Identify the brachial plexus, phrenic nerve, and vagus nerve, and preserve them carefully. Identify and clip all the lymphatic leaks after dissecting left or right. Level 4 compartment and dissect compartments 2B and 5 selectively. Especially with today's imaging, we have very good imaging modalities. And if there are no lymph nodes, these levels can be spared for most of the patient with low volume lymph node metastasis to lateral. Thank you.
Thank you, Dr. Chandan, for this wonderful presentation. I think dissecting with bipolar is a very great idea because it really eases your dissection, makes it faster and relatively quite bloodless actually. How do you decide which levels you are going to remove?
Most of the metastasis, as I said, from the thyroid cancer goes to level 3 and 4, followed by 2A and 5B. But so these levels will usually be removed irrespective of the type of, irrespective of the station of the metastasis. These has to be removed once we decide to go for a selective lymph node dissection. Beyond this, if there is no involvement of level 2B or 5A, then only I would dissect those levels. Level 1, I have never seen being involved until now. But of course, if it is involved, we have to remove. That is what I do.
Have you ever tried sending intraoperative frozen section to actually see the involvement of lymph nodes?
No, because most of the lymph nodes that I would miss without sending up, without actively looking for them and sending for frozen section would anyway will be dealt by radio. That is my thinking. I have started practicing that. So basically, at most, I would miss lymph nodes that are maybe 2 mm, 3 mm. I am not bothered about those nodes.
So one challenge is when bulky nodes are at 2B and you don't have a palpable nodule on the thyroid. So how do you incision to be able to access it properly and safely?
Actually,
Do you modify your incisions or what's the strategy?
Yeah, of course. If the lymph nodes are patient quite high in the neck, it is almost impossible to reach there through a small collar, especially in patients who have long neck. So in that case, either you make a apron shaped incision where both limbs of the both horizontal limbs are extended upwards, or you can, if you have to do a unilateral dissection, you can just increase it in a J-shaped fashion. You elongate the incision to the highest point where the disease is there, because there is no point in creating complications just to avoid the length of the incision.
Actually, in my experience, I think starting from level 5, going laterally and starting with the prevertebral fascia and then coming medially. I think most of the surgical oncologists follow that approach.
Yes.
It makes the things relatively easy. I think I've done both approaches. If anybody from the house has an opinion. Yes, as soon as you go above the prevertebral fascia, it becomes very easy.
Well, when I plan to do a dissection from level 2 to 5, I would also, but for most of those cases, the videos, they won't be presentable videos. If I have to show all those structures, I needed a case where there are lymph node metastasis is manageable. So that is why this video, and here I didn't plan to do extensive level 5 dissection. So that is why this video. That is the key.
That's the foremost, yeah. Anjali.
Performing thyroidectomy, you don't have to tie the same vessel twice at least near middle thyroid.
Actually, yeah.
And then I had a comment on this. Chandel's he said he tried to avoid transverse cervical vessel, but actually it happens many a time if you are not tying those, you miss the nodes which are situated posterior at level 4. So we need to be a bit careful about that.
And many a times, the type of disease we see, these structures are very difficult to identify. When many a time you will cause breach of the prevertebral fascia and then just realize, okay, I have breached it. So you have to come back again to restart.
So thank you, Dr. Chandan.
Yes.
Rest will catch you in the tea break.
Now, I invite Dr. Sanjay to present on endoscopic thyroid surgery.
So, good morning, everyone. A very warm greetings from Jabalpur. Today, I will be speaking on transoral endoscopic thyroid surgery. And as surgeons, we all wear many hats, teacher, innovator, editors, reviewers. But the hat which I like personally most is the hat of a learner. Because in surgery, the moment we stop learning, we start lagging behind. So minimally invasive thyroid surgery is one such thing. I think we all should try to learn. Because we may debate it, we may resist it, but the truth is it is going to stay. So as we often, we may know that when laparoscopic cholecystectomy was started, people used to say that real surgeons make real incisions. But now we know that is kind of history. So that is why if history of surgery teaches us one thing, it is that evolution does not wait for consensus. So now let us dive in to the world of totally endoscopic thyroid surgery. And this has been cosmetically demanding by the patients. That is why it pushed the surgeons to perform thyroid surgery using endoscope, having excellent magnified view, safe procedure in trained hands, and excellent cosmetic outcomes. So for the beginners and those who want to start Tohetova services, I have 10 commandments of endoscopic thyroid surgery. So first commandment is, thou shalt master open thyroid surgery first. Tohetova is an art, but open surgery is foundation. As the great man Theodore Billroth said, only a man who is familiar with the art and science of the past is competent to aid in its progress in the future. Not only Bilroth, our own scriptures say, Yatha Mulam Tatha Shakha, Yatha Bijam Tatha Phalam. So if the root is strong, the branches will flourish. So scarless surgery has secret entry points. So thou shalt choose patients and technique wisely. That is the second commandment. So there are myriads of techniques and which will be there in presentation in subsequent presentations. So I will not be going into detail of the various approaches, their indications and contraindications. But what I want you to know about the third commandment, it is that thou shalt respect the learning curve. There are no shortcuts to mastery even for surgeons. And apart from this learning curve, there are two other curves. One is in the smile of the surgeon when the surgery is successful, and another one is frowning on the forehead when it is not successful. So we should always strive for the first one. Now, after these three commandments, there are 7 actual commandments for performing endoscopic thyroid surgery. So they are creating sufficient working space, searching for midline and dividing isthmus, separating straps, identifying middle thyroid vein, identifying EBSLN and superior pole vessels, identifying recurrent laryngeal nerve, and then completion. So these are consecutive 7 steps, and we should proceed to next step only when we have satisfactorily achieved the previous step. So coming to, okay, so this patient has a right-sided thyroid nodule and it was benign on both USG and FNAC. So we planned transoral. So this is something which we do, a pre-operative ultrasound guided hydrodissection before actually performing TOA. This is after port placement. So now we are creating the subplatysmal working space. So this initial step is best done with an L-hook pottery. And this is very important to have a good working space because it is not like abdominal cavity where you have natural working space. And once we have achieved satisfactory working space, we may take down the anterior jugular veins with the help of a bipolar sealer or harmonic, whatever device we have. After that, we identify the midline. You see that midline is visible now. So we will divide the midline and then we identify trachea just below the isthmus and above the isthmus. Unlike in open thyroid surgery where we divide isthmus as the last step, here we divide it first. So it is very important to identify trachea so we can prevent any injury to trachea. While dividing isthmus, the trachea should always be in the view. A little bit of dissection towards the strap muscle. And that is the advantage of hydrodissection. You can see I don't have to do much for separating the nodule from the strap. Now we are dividing the isthmus. After this, our focus shifts towards the superior pole. Now we are trying to deliver the superior pole from the thyroid bed. There are few tiny vessels which we can take down with harmonic or bipolar sealer device. And This nodule was actually right sitting at the top of the superior pole. By taking down the attachments around it, we can deliver the superior pole. Now the superior pole is out from the thyroid bed, and we will be able to identify the superior pole vessels. Then this is another one of low-cost muscle retractors, our own technique, which we use to retract the strap muscles. So outer view is from another patient which I recorded recently. Now this is the in this patient. So this is how it retracts the strap muscle and helps us in dividing superior pole vessels. Now you can see the superior thyroid artery is visible there. So we will take down artery and vein. Now next, we'll focus our attention to preservation of superior parathyroid and recurrent laryngeal nerve. So for that, we use what is called, what we call critical view of safety, which is bounded medially by cricothyroid Berry's ligament and laterally by medial surface of thyroid, strap muscles, and superior parathyroid. So we create a tunnel between these two boundaries, and the recurrent laryngeal nerve can be seen traversing through the floor of this critical view of safety. So this is early exposure of recurrent laryngeal nerve for transoral endoscopic thyroid surgery. You can see that recurrent laryngeal nerve is visible there. So we will separate it from the posterior surface of thyroid nodule in whole of its length. Then only we will do any lateral dissection. Now we will dissect the lateral part, preserving the superior parathyroid and lower attachments, and the surgery will be complete. So we'll take out the specimen. Sometimes if a specimen is big, we have to morcellate it, and it will be followed by closure of the strap muscles. Usually we do not use any drain. So, ultrasound hydrodissection makes easier for us to separate the strap, and this is a low-cost muscle retractor. So this is cosmetic outcome. We have also evaluated quality of life. So short-term quality of life is slightly better in endoscopic group, but ultimately at long-term quality of life is almost equal in both groups. So there are no extra complications, but only extra palpitations in the early cases for surgeons. Obviously, it takes much more operative time, and but patient satisfaction is definitely higher. So upgrading is not optional. So a task, when discussed thoroughly and decided by reason, leads to successful action when executed together. So teamwork is key here. Thank you.
Thank you, Dr. Sanjay. That was really lovely presentation, and you have so many publications. You are one of the pioneers amongst us to do this procedure. Could you please explain us more about hydrodissection, because this looks really interesting. And another thing that I want to ask you is, do you really get a TPO antibody routinely? Because sometimes when there's an element of thyroiditis, it becomes really difficult even in open surgeries. Then how do you manage them?
Yes, thank you, ma'am. So, USG guided hydrodissection is same which we do for microwave ablation. And I have tried this thing from there only after learning a hydrodissection for microwave ablation, and it decreases our operative time by 5-6 minutes or 10 minutes maybe. Regarding thyroiditis, no, we do not do TPO antibodies routinely. And yes, it becomes challenging if there is associated thyroiditis.
And could you inform the residents about port positioning a bit?
Yeah, so we use one 10 mm port and two 5 mm port in the vestibule. And obviously the distance there is not much. So each ports are, I use 3 different ports, which we have learned from here only as the PGI. And during my initial learning days, Gyan sir was of much help. He used to guide me in initial cases. So few people use single incision, curvilinear incision, to put all the 3 ports.
And as far as residents are concerned, I think it's very important to, if you want to do an endoscopic thyroidectomy, you have to do open thyroidectomy from different views. Stand at the top and do it, stand at the side and do it, so that you get an idea how to do it from various positions. And this is something that Chitresh had put up in the last workshop. And that was really learning for all of us as well. So thank you. Thank you, Dr. Sanjay.
Thank you. Yes, definitely. So that is why I skipped the indications and contraindications portion, patient selection. But obviously, it will be very challenging to do it in short neck patients. For them, transaxillary or BABA approach is more apt.
Thank you.
Okay.
So now I invite Dr. Anita Dhar to present on robotic thyroidectomy by BABA approach.
Start with wishing you all happy Teachers' Day. There are many people, juniors, seniors, say, from everyone, I have learned a lot. Good morning. I should say, rather use this platform to give a special thanks to Dr. Gyan, who initiated and helped. Dr. Gyan, thanks a lot for the endoscopic version of thyroidectomy when we started. And subsequently, it's now many years, almost 10 years, we have been doing endoscopic, both BABA and vestibular approach. From November last year, now we have a robot in the Department of Surgery. So we stepped up, and as we are all as surgeons, we want to take every bite from new technology and all. So we started doing robotic. After having an experience from the BABA, so it was not a very big challenge to except for learning the technical part of how to use the robot. I present here the details of a case. She is young, 38 years, who had already a major surgery, dual valve replacement in 2024 for the RHD, and she was on anticoagulants. And during one of the CTs, follow-up CTs, they instantly found a nodule or some lesion in the thyroid. That's how she was further investigated and found that she had an oval shaped hypoechoic nodule 27, 13, 16 millimeter posterior aspect of the upper pole. As it is, she already had a major surgery and all. She didn't want further surgeries on the neck. She was trying to avoid it. And we did counsel her, and finally she agreed for this approach. So she had lesion only on one side. Since she was already a high-risk case, so we decided to have a total thyroidectomy at the beginning itself. We took her consent, and this is how we usually place the patients. That's a position of the patient. Sorry for too many markings, but these are the basic markings that are used for the Baba approach. And we don't make dissection under open vision. That is the rabbit, which is another procedure. And one more technique is the posterior auricular. And this is the one that we use extra port as the laparoscopic port, in addition to the 4 robotic ports that help us to create the whole dissection and the space under vision without making any trocar dissection and blunt dissection. So this is the first port, anterior axillary line, and we make a small straight artery dissection into the space. And then we place the first robotic port, insufflate it, and then we have a small 5 mm laparoscopic port just behind the anterior axillary line below the first robotic port. That helps us to create a pocket of air and small dissection under direct vision. And then as we go on, we place the second port. Our scope gets transferred to the second robotic port, and we make a straight entry into from the first port for the dissection under direct vision. I'll show the video how it happens. So all the dissection is finally done under vision. This is placement of the third robotic port. And this is final view, how the trocars look from outside. This view is from other patient that should give an overview of the placement of trocars. And then the robot docking takes place. So this is the initial view of the small pocket that we create. And we use energy device, either harmonic or ligashore. And the second robotic port under vision, and then further down to the opposite side, and all rest ports are placed under direct vision. So we don't target usually because all the ports are in a semicircular type of fashion. So the robot doesn't take it. So we do it without just positioning of the camera, which is in the third port. This is opening of the first the midline, and then the right lobe lateral dissection, inferior polar dissection. We use the scissors and fenestrate it, and plus a progress for lifting and having the retraction. This is the inferior vessel, and taking utmost care to preserve the parathyroid at the same time. And with the bipolar, we take down the vessels. We can burn them with the bipolar and cut them with the scissors and preserve the parathyroid. Going to the superior pole, since it's for malignancy, we have to be careful that you take the whole gland complete without leaving any tissue behind. So this is the superior polar dissection and dissecting it. That's how the right lobe was dissected, and now we take it off from the trachea with sharp dissection using scissors and the energy source along with it. And you can see clearly the right laryngeal nerve and the parathyroid, it's preserved on the right side. And now we dissect. There was a small pyramidal extension that was completely detached. This is complete separation from the trachea. And now we move, we don't divide it. We keep the whole gland in total. And this helps in retraction actually. Move to the opposite side, and the inferior pole of the left gland or the lobe. This is the parathyroid and the vessels that are preserved. The big difference that we found from endoscopic versus the robotic, the vision, the magnification, it goes sharply 12 times. And the magnification of seeing the vessels and parathyroid is actually an experience in itself. It helps a lot. For the completion, we further take the left lobe away, going up to the superior pole, completing the lateral dissection there. And this is the recurrent nerve of the opposite side and parathyroid, preserving it and lifting the whole gland away. The superior polar vessels. So we keep away from it as close to superior pole as possible, protecting the nerve parathyroid. We have made no attempt actually to see the superior nerve here. This is the completion of the thyroidectomy. The glove bag we use for this, it's quite soft and manageable. And the retrieval, we close the midline and place a drain for completion of the procedure. This is the specimen, and the histopath confirmed it. There was no lymphovascular invasion, the capsule was intact, and opposite lobe had no tumor. Post-operatively, she was quite comfortable, and calcium levels were 8.5 milligram per deciliter, no voice changes. And since she had to be put back on the anticoagulants, so we retained the drain for a little extra time. And you can see the movements of this patient's neck. And she's being followed now. Thyroid scan has been done and already ablated. There was less than 1% of the residue that has been ablated. This is the first case here, demonstrable. Yeah, I just finished. The outcome of this patient, follow-up. And there's one more lady, who young girl, very thin. We were a little skeptical about what will happen to the flap raising and all. Hardly any fat to her, but it worked well. So I'll not go in discussion now. Time's already up. There is meta-analysis where it's agreeable now that there are better outcomes with use of robot as compared to endoscopic. But long-term results are almost the same then, but visibility of the nerve and the parathyroid makes the difference actually. So the take-home message is it's a safe procedure. With improved precision, we can preserve the parathyroid and see the nerve, and therefore the complications are maintained. There's increased dexterity, the suturing and maneuverability inside is possible. We can use this procedure for little larger size thyroids also. And of course, with better cosmetic satisfaction and early recovery. Thank you so much.
Thank you so much, ma'am, for this presentation. We have a few questions. We are very new to robotics. What is the learning curve? What is your comment on the learning curve as far as robotic thyroidectomy is concerned?
Actually, we have been doing endoscopic surgery for last almost 10 years now. Maybe that was an element that helped us to transit little faster. The only limitation for us was the use of the robot, the technicality of that. Once you master that, I should not use the word master, but when you get familiar with it and you know how to drive your instruments, choose your instruments, and plus the experience of doing the Baba approach and you know the steps. It's almost the same procedure, but you're doing it with a different set of instruments. So the way the scissors is used, it's a beautiful instrument, but it can harm and as well as be really a boon when you're doing it. And you have to really understand the holding of the instruments. The feel is not there. The next generation will bring us the feel, but at present we don't have the tissue feel. So we have to actually sensitize ourselves, not to crush it too much. So you should know how much to hold. And structures like thyroid, where we know too much of handling, it starts bleeding, oozing, and the capsular breach, especially when you're doing malignancy. So that element, you have to be really careful and learn how much to handle and what to do. That is the instrumentation part. The procedure part is more or less the same.
And do you have any particular selection criteria as far as in the initial learning curve at least?
Initially, we did half, like hemithyroidectomies, to get used to the environment, the tools, and later on, once we were familiar with the space, we standardize our steps, the use of space creation and all, when to bring in the robot. And once the steps were all standardized, I'm talking about myself, then we stepped up to do total thyroidectomy and little bigger size also.
And how do you charge? How does your institute charge for the robot?
We don't have, it's free for them.
It's free.
That's the beauty. We're
Every
just
arm is
enjoying.
charged.
We're enjoying it now.
They're using 4 lucky people.
No, we are not using it. In this case 4, but robot vestibular, it's 3.
Thank you. Thank you, ma'am.
Yes, please. We know that robot has the facility for seeing through ICG also, but we don't use it. We can always do that. You have the access.
Thank you, ma'am.
Yes.
Any more questions?
Ma'am, any experience with central compartment dissection in robotic thyroid?
I have done one case, so not too much experience, but I have done one case.
That's, the basic approach is from the breast and axilla, and while we do it open, we pull the larynx into above, and then we try to clear the supraintestinal as well when we do the central compartment dissection. So how do we overcome these things in robotic? We have any?
See, actually what happens that the instruments are far off the entry point, but you're right there. You could see the view. You could see the superior pole very clearly. You could see the trachea very clearly. So that's the area where you have to be. You have to be on to both sides of the trachea. So when you could see that view here, the trachea and the 2 sides. It's the same thing. So only that you have to be careful with the fine dissection and the way.
Thank you.
Thank you, ma'am.
Thank
you. Now I invite Dr. Thalabi Sundaram to speak on the complications of robotic thyroidectomy.
respected chairpersons, respected senior professors and senior faculties. Good morning to one and all. It is indeed a great honor to be back in this podium. I'd like to thank the faculty of SGBGI for giving me this opportunity. And what better tribute having this conference on the Teachers' Day. No matter what we have achieved in coming back to and presenting in front of our teachers would really make them happy. I think it is a tribute to our teachers also for all the teaching they have done. So we've just had a good video session on robotic thyroidectomy. I have come here to speak on the complications in robotic surgery. There might be many approaches, but what matters is the safety of the patient. So what we have encountered, we are just trying to highlight. So greetings from our institution. It is Tamil Nadu Government Multi-Super Specialty Hospital. It is in line with SGBJ, which is a pure super specialty hospital. And we were the first state government owned institution to procure a Da Vinci XI. So we are doing quite a lot now. So coming to the complications in thyroidectomy. So we follow the rabbit approach. I think it is just a minor modification of BABA where the flap changes are different. The flap, we have encountered quite a lot of problems with the flap. I think more than the robotic thyroidectomy, raising the flap is a challenge. As you know, the second and third intercostal space perforators are quite troublesome. You get troublesome bleeding. And the next hidden one is the thoracoacromial artery. So that also is a problem where we've faced significant bleeding. So this is a video highlighting bleeding from the thoracoacromial artery. Field is literally pulled. We couldn't do anything. I think in this situation, with the good old teaching of compression, we had to deflate, remove the CO2, remove the pores, compress the chest for 10 to 15 minutes. After that, went in again and found the vessel at the thoracoacromial artery perforator. So once we identify that, that will be better. So it is always better not to panic and buzz everything in a hurry. I think the good old teaching of compression will definitely help. In this case, it really helped. We compressed, stabilized the vitals of the patient, and then we went in and identified the bleeder and coagulated it. And ultimately, patient was good, and the outcome also was better, and we could complete the case with robotic. So this is one problem with rapid. The bleeding, we'll have to be very careful. But of course, under vision, so you'll have better. So now coming to the next challenges we faced in raising the subplatysmal neck flap robotically. So once you raise the chest flap laparoscopically, then we go in for the robotic neck flap raising. You can do it even laparoscopically, but robotic is more convenient and comfortable for the surgeon. So this marking is very important. This is going to be the flap marking. So this marking has to be very important because this stays as a roadmap for us. So because see, Da Vinci, most of the head and neck procedures are done using Da Vinci, which is a closed console, and we are immersed in that console. We don't know what is happening on the patient side, and then you have the arms covering the patient. So the patient side assistant has to guide us if we tend to deviate from these markings, because if once you deviate, you don't know the difference because you don't have the tactile feedback. It is merely haptic feedback. So this is very important. So this one case, what happened is we tend to deviate. So I thought this is the midline, and I started raising the flap routinely, like how we do in open also subplatysmal neck flap. But what happened, it tend to be more lateral that we cannot ascertain from sitting inside the console with 3D vision. So we went laterally, the same sternal heads. We think the sternal heads, we don't know whether it's the two sternal heads we are going through, or is it within the clavicular head or the sternal head of the same side. So you see, this is also one sternal head, and this is also one sternal. So I thought these are the two sternal heads, right and left, but it turned out to be the right side cervical and sternal head of sternocleidomastoid. So we tend to deviate. So once we went in, we almost reached the brachial plexus. So we had to come out thinking that what is the reason? There is no goiter there. Then the assistant had to palpate and show us the midline, and then we deviate. So that small marking definitely makes a big difference. That's why Madam also was very specific. She's sorry for the lot of markings. I think that is very important roadmap. Now, next coming to the post-operative collection. This is also a bit of a challenge. We've had, especially in old age and obese ladies with pendulous. do tend to dissolve over a period of time, but majority needs aspiration. So this is another problem with rabbit. Next, coming to the peculiar, this one was actually very rare. Even my counterpart, the original surgeon who had consumptualized rabbit, Dr. Sandeep Naik, has never had this issue, but I tend to have it, and he used to take this as another thing per video to project. So this patient underwent a robotic rabbit total thyroidectomy comfortably and went home. After 3 weeks, she came back. Tracheal necrosis. So we were planning for a muscle patch. Yes, it tends to close. We were lucky with this patient, so she did not have a scar because I don't have experience to go robotically and close the trachea. It would have been landed up in the open procedure, leading to the failure of the primary procedure. So, thank you, sir, state-of-the-art robotic theater. I thank you very much for this opportunity. And all these videos are not to discourage you. I'm just telling it to you, my experience, so that you can be even more. Because this tracheal necrosis, even the person who had conceptualized never had seen it. I had kept on bugging him every day saying that, sir, what to do, what to do. He said, don't worry, we'll wait for 2 weeks since the patient is stable clinically and she's able to have a normal routine. We wait. Luckily, she escaped and we need not do a thing. So all these things are minor things and you can definitely overcome, considering robotic surgery has become a fashion now. Every patient wants it, whether it is in a government setup or a private setup. And of course, cost does matter, but nowadays private, because they have a lot of competition, they've come down with the costing, the open costing along with the consumable. One case consumable works out around 90,000. I think Geetika madam had asked. 90,000 is the consumable cost for one case of robotic thyroidectomy. And since most of the corporate hospitals are pushed to have a robotic system, they have come to such a state that they will charge the patient for the open, normally what they charge for the open thyroidectomy. In addition to that, they will charge around 90,000 to 1 lakh just to promote the robotic system. I think with that, many people have started doing, and I have officially become a proctor for Da Vinci, and I have started helping surgeons all over, mainly in South India, to start this program. Thank you again for this opportunity. Any questions?
Excellent talk, Dr. Talavi. Any questions? Dr. Ramya?
Yeah, sir, wonderful presentation. You actually scared me.
That's why it was very specific.
Yeah, so my question is, why do we get so much bleeding if we are in the subcutaneous plane? I think we have to not go below the fascia, right? Pectoralis fascia. I mean, the video that you showed, the muscle is looking bare. So I think, isn't it too deep? Like the other thing that you mentioned, thoracoacromial vessels. Why will we, I mean,
see,
the branches of those?
Intercostal perforators come to the breast, right?
Yeah, yeah, but those would be
same way.
subcutaneous.
Thoracoacromial artery, it supplies the skin also.
Yeah, yeah.
You don't have to hit the main trunk. It is the perforator.
No, I'm not talking about the trunk.
Yeah.
The vessels that we expect to be in subcutaneous plane are not so big, right? So
you never know.
Okay.
That is patient dependent. It depends on the breast size. It depends on the volume of the patient.
Okay.
It is not standard for all. So that just a point saying that these are the possibilities.
So it can happen even if we are in
Yeah,
subcutaneous.
totally.
Thank you.
Ma'am.
Actually, it's a comment, and I would really congratulate and commend Talavi for showing us all these videos.
Thank
So
you.
just to this thing, not to overemphasize the importance of training and getting acclimatize ourselves with new technique. So thank you again for that wonderful presentation. Thank you.
Thank you.
Thank you very much.
So thank you, everyone. With this, we would end the session. But at the end of it, we would like to thank our teachers. On this Teachers' Day, we take this opportunity to thank all the teachers who are here for teaching us and mentoring us and still going continuing to mentor us. We learn a lot from you. Thank you all so much.
Happy Teachers' Day to all of us. Thank you.
Thank you, chairpersons. We now break for tea. Please enjoy the refreshments and reassemble here by 11 a.m. sharp. And I would like also to request the presenters to kindly deposit your presentations with the AV team, and also request the delegates to pin the posters outside. Thank you.
Yes.
Hello, hello, hello. Hi, Dr. E. Hello.
Hi.
Hello, Dr. E.
Hi.
Yeah, he is there.
Yeah,
Yes.
can you hear?
Are you ready?
Yes, can you hear me?
आवाज वहां दो. आवाज, audio. Hello. Yes, please speak something.
Yes.
Hi. Yeah, please speak. Dr. E. Hello, Dr. E.
Hi.
बोल तो रहे कुछ. Hello,
Hi.
Dr. E.
Hi.
Your voice is not coming.
Come again?
Voice connect करो. Hello, Dr. E.
Hi.
Yes. Now your voice is there. Yeah, please. Are you ready, Dr. E?
Yes.
Yeah. So please wait. We are just going to start at 11. It's 5 minutes. After
Okay.
5 minutes, take a coffee break and then we will start.
Okay, thank you.
Thank you. Thank you very much. So happy to see you here.
It's nice to meet you here.
And your videos are very nice and everyone is waiting for that, your presentation. So, okay, have you finished your surgery?
Yes, already finished 2 surgeries and 1 surgery is left.
Great. So you have to spend 15 to 20 minutes more.
Yes.
So after 5 minutes, we will start.
Okay.
So take a coffee break and then whenever we start, so please stay here and continue with
Yes.
coffee. Okay?
Please send me Indian coffee.
Yes. Yes. Okay. Minimize करो.
Attention all poster presenters. Our posters which will be judged by our international faculty, and the presentation time will be for 1 minute only. I welcome you all back. The workshop will resume with a keynote video lecture by Dr. Jin Woo Yi. He will be joining us via Zoom. May I invite the chairpersons, Dr. Anita Dhar, Dr. Farhanul Huda, and Dr. Anand Mishra sir to join us on the stage.
Very good morning. It's a pleasure to introduce the speaker, Dr. Jin Book. He is Associate Professor, Department of Surgery, Chief of Robotic Surgery Center, Inha University Hospital, College of Medicine in Incheon, Republic of Korea. His area of interest are BABA and TOBETA, endoscopic and robotic thyroid surgery, single port robotic areolar thyroidectomy, SPRA technique, and thyroid cancer research. His achievements are Best Investigator Award, Korean Surgical Society, second winner of the Fujimoto Prize in the 16th AES, Best Research Award, Korean Association of Thyroid and Endocrine Surgeon, Best Basic Medical Research Award, Korean Thyroid Association, International Live Surgery Workshop, Tutor of India, Georgia, and Philippines, and many publications in the peer-reviewed high-impact journals. I welcome you, Dr. Jin Wook, and present to you, Dr. Jin.
Thank you for your kind introduction about me, and it's very honor from me to participate this great conference. As always, I want to join there, but in these days I moved to my hospital from university to some new clinic, so I'm really sorry to not join in person, but I will make a lecture in my best, and I will show about my recent skills of the single port robotic thyroid surgeries. This is numbers of my robotic surgical cases. I started robotic thyroid surgery from the 2016, and I completed more than 1,500 cases. And it was originally started from the BABA approach using the XI system initially. But in the year of 2022, my hospital adapted to the Da Vinci single port system. So I developed new method of the name as Supra method, and I started SP robotic thyroidectomy from the 2022, and from the 2024, numbers of the single port robotic surgery overcome from the XI system. And these days, most of my robotic surgery are conducted by the single port robotic thyroid surgery. As you all know, the BABA approach was started from the 2008 from the Seoul National University when I was trained. And it has a great advantage that it provides symmetrical view of the both thyroid gland and lateral leg easily. So it can do the both thyroid gland lobectomy and total thyroidectomy, and also it can easily perform the neck dissection without changing the robotic position. But it has a little disadvantage that it has a huge amount of the subcutaneous flap is required. So in terms of the minimal invasive, it is not such a minimal invasive surgery. And also it is very difficult to learn the flap dissection, and the docking of the four robotic arm is sometimes very difficult to the novice centers. So it has a little bit disadvantages. So I developed the evolved method from the BABA surgery using the Da Vinci SP system. So this is the name suprathyroid surgery. It was started 2022, the day of the Christmas Eve. So it provides the same vision with the BABA. Also, it has the same advantage of the BABA surgery that it can easily access to the both thyroid gland, and also it can do the MRND without changing the trocar port of the right and left side either, and don't need to change robotic docking, same as the BABA. And compared to the BABA, it only required this kind of straightforward flap dissection from the right areola. So it is really minimal invasive compared to the other previous method. And also, it don't need to the separate equipment such as a axillary retractor in the transaxillary surgery. And also, it don't need to additional surgeon assistant. Only I can use the robotic system and it's done. And also, it don't have unusual complications such as when the transoral surgery, we should aware of the mental nerve injury or the infection. But in this method, it only take the breast approach, so there's no suspected complications from this method. This is the flap design, and this is post-operative state wound. And only I need the 3 centimeter incision over the right areolar area. It is same when I do the right lobectomy or left lobectomy, or right MRND or left MRND. I only use the right areola. But some patient has a right breast problem, and it will be changed to the left areola also. This is the vision of the thyroidectomy view. This is the right thyroidectomy area. You can see the nerve and the parathyroid gland very clearly, and is the left thyroid area. Also, after surgery, the nerve is very easily visible, and parathyroid gland is very easily seen. And this is the MRND view. This is the right level 4, and clearly see the transverse cervical arteries for thoracic duct and the nerves from the sensory and the SCM muscle. And when we go up to the level 3, clearly find the phrenic nerve and spinal accessory nerves. And going up to the level 2A, 2B, it can be easily accessed to the level 2B area and level 2 area. It is a very uppermost area. We can find the digastric muscle and submandibular gland and carotid bulb also. This is the comparative analysis during the 1-year surgery of the MRND. So it has only MRND patient and has I performed the 17 open and 14 BABA and 11 supra method, and operation time is shorter than the supra method compared to BABA, and the same similar in the open, and the drain amount of after surgery is BABA is most highest, but the supra method is less than open surgery. And also the post-operative thyroglobulin level is very low, and retrieved lymph node is more than 25, so it is very good lymph retrieval rate. And vocal cord palsy rate is 0 in the supra method, and post-operative parathyroid hormone level is acceptable after surgery. And I also made 4 publications using the supra method. This is the first experience, and this is how I do it article. And this 1-year experience, more than 150 cases. And this is the latest publication about the MRND supra surgeries. And this is my journey from the robotic surgery. I started XI and evolved to the adrenal also and parathyroid gland using ICG and supra method developing. And also I can make a telepresence. This is the Professor Gian Chan, and I make the telepresence surgery. And this is the supra MRND article. And I finally got the international approval from the Intuitive Surgical as an epicenter surgeon. So please turn on my video and I will introduce the detailed procedure. Turn on the video your side. Okay. Initially, make a 3 centimeter areolar incision, and this is the axillary port to make a elevator flap, and insert the saline epinephrine solution to hydrodissection. Also inject the saline more to the neck area It is basically same as the BABA surgery and make a 3 centimeter periareolar incision along the areolar side and little bit bleeding control and inject the saline epinephrine solution more to make a more hydrodissection and step by step insert the subcutaneous dissection and also insert the blunt trocar to make a dissection from the areolar area to neck, and we use the 15 millimeter trocar insertion because SP camera size is a little bit large, so 15 millimeter trocar is needed, and also add the axillary 5 millimeter incision and insert the advanced bipolar energy device and elevator flap. It only needs to the anterior chest area flap dissection, not goes to the bilateral axillary area. Only we need to the subcutaneous area from the camera insertion to the anterior neck. We should clear the insertion of the robotic trocars. And this is the SCM, right SCM muscle. And also you can see the left SCM further and going up to the strap muscle side. You can also clearly see the strap muscle and the midline of strap muscle. This is very basically the same, but difference is the not going to the axillary area. Only I go to the neck area from the left axilla. And after little flap dissection and insertion of the Da Vinci single port trocar to the right breast area and CO2 gas inflation. This is the name of entry guide. It is the docking of the robot. And after docking of robot, I only use the bilateral robotic bipolar device because the SP system don't have a harmonic or the advanced bipolar device. So only I can use the bipolar. You see the pretracheal lymph node already removed and find the isthmus, cut the isthmus first. Right thyroid gland with mobilization. And this patient has a right thyroid cancer with a right lymph node metastasis. So you can see the tumor is attached to the strap muscle and neuromonitoring system is connected to the directly to the bipolar devices, and you can change it from the neuromonitor and the bipolar, and you see the right recurrent laryngeal lobe there. And before going up to the thyroid thyroidectomy, we will approach to the right level 6 area, right level 6 lymph node removed. And after removing to the lymph node, is going up to along the recurrent laryngeal nerve and dissect the area of the Paris ligament. And also it provides the ICG Firefly system. We can check the blood supply to the parasite gland like this. After surgery, this patient has no hypoparathyroidism or permanent hypoparathyroidism because the vessels and parasite gland are safe. And this right thyroidectomy after the superior pole division. SP system can going up to the superior part easily compared to the exercise system. So thyroidectomy is achieved every direction from the superior or inferior. And this is the left thyroidectomy. Also find the left recurrent nerve very easy using the neuromonitoring. And saving the right lower parasite gland and the right recurrent laryngeal nerve. And level 6 lymph node. And very ligament dissection is achieved. And then going up to the left superior pole and left superior parasite gland is seen. Also double check the parasite gland flow using the firefly. You can see the vessels and the parasite gland. And left thyroidectomy is done. After thyroidectomy, directly proceed to the right MRND. At first, dissection between the stem muscle and SCM muscle. And omohyoid muscle should be divided to the easily access to the internal jugular vein. Beneath the omohyoid muscle, the internal jugular vein is identified and some part of jugular lymph node removed. Going up the flap to the submandibular area. The submandibular gland is identified, and also digastric muscle is identified. This is the uppermost border of the level 2, and division of the SCM posterior part, and we should save the sensory nerve from the August point. With little nerve fiber lead apart from the SCM muscle, it can easily save the sensory nerves. And after dissection of some soft tissue beneath the SCM muscle, SCM muscle is pulling opposite side like this using the rubber band, and internal jugular vein identification, and level 4 lymph node is removed. As a dissection of lymph node level 4. Some part of the thoracic duct identified, and ligate can be ligated by the clips. It's a robotic clip. And going up to the level 3 simultaneously. Also, the thoracic duct branch is ligated. And going up to the level 3, transverse cervical artery identified. And dissect some part of the level 5 lymph nodes simultaneously. And going up to the level 3, we can also see some phrenic nerve fiber and spinal accessory nerve. This area is level 5 and level 3. And level phrenic nerve is identified. It's a phrenic nerve. And level 4 and level 3 and level 5 lymph nodes dissection completed. And we should insert one suture to the lateral side to approach the level 2 area. For this patient also has a level 2B metastatic lymph node, so I go into the level 2B lymph node dissection like this. It is safe to pulling the jugular vein directly using the progress forceps. Level 2 lymph node dissection is achieved. Always do not miss some lymph node just beneath from the SCM muscle. And after removing the level 2B area, going to the level 2A, anterior part of the jugular vein bifurcation. Then also common carotid artery bulb is identification, because sometimes it is very difficult to distinguish the lymph node and the carotid artery area. So just take care. And double check the posterior aspect of the jugular vein. Sometimes the surgeon leave the metastatic lymph node around there. So always double check the right level 2 area. After surgery, the hemostatic agent is applied and make irrigation, and drain is inserted. And midline suture. Anti-adhesive agent and drain placement, and surgery is completed.
Da Vinci surgical system is the US FDA approved robotic surgical system, and XI is the latest fourth generation surgical robot. It is the latest surgical.
Thank you for your attention. And if you have any question, please ask me. Thank you.
Excellent demonstration of this technique. In India, we're yet to start this, and it was really a new technique for us, and you demonstrated it so well. And what's the size of the trocar you're placing?
Our trocar size is 3 centimeters in the robotic surgery.
Okay.
SP robotic surgery has a 3 centimeter diameter, and but the camera is the 12 or 13 centimeters, so we need to the 15 diameter trocar when in the endoscopy period.
So you're using endoscopic trocar only for raising the flap?
Yes.
Yes.
But don't need endoscope, another endoscope, just to use the robotic scope itself.
Okay. Good.
Have you ever thought of have you ever wondered there's overcrowding of instruments with a single port?
It the initial period, beginning period, it has a kind of the collision between the single port trocars, but after some experience, more than 10 or 20 cases, it is overcome. Then Da Vinci SP system provide the 3D map of the robotic trocar position. So it is very important to see the robotic trocar position and itself in the monitor, and it is very helpful to prevent the collision. But if you have experienced more than 10 or 20 cases, it is not some big problem.
Thank you. And apart from overcrowding of instruments, do you think is there any other limitation to this technique?
For me, there is kind of no limitation. If it is the same indication of the BABA, there is no difference between the XI and SP. Only the difference is the single port and multi-port.
So we are interested to know, since this instrument is new to us, the flexibility at the rear end. How do we maneuver it? If you have to make more curve in the instrument.
Yes, the instrument.
How do you handle it?
Yes, the camera is provided to the 30-degree flexion, so you surgeon can change the camera angle from the 0 to 30 degree. And also the robotic arms provide the 70 degrees of the angle, so it will be flexed and extends to the 70 degrees and 360 degrees of rotation. So it is very, has a large area of the flexibility compared to the XI trocars.
Right. And we also notice the tip of the instruments were a little smaller length than
Yes.
we use in.
Yes, the tip of the instrument is much smaller than the XI system.
So that must be helping in to accommodate the instrument.
Yes, very So the instrument is very small, around the 3 or 4 millimeter size. So it is very helpful to the fine dissection compared to the XI system.
I'm keen to know what is the largest size of the malignant tumors that you are removing.
Around the 4 centimeters. There's no.
We recently, I had an interaction with one of the Korean surgeon. He said maximum is 8 millimeter
No.
in his series.
Yes. Well, I can do the or around the 4 centimeter cancer is no problem.
Thank you so much.
So any comments and questions from the floor? Yes, doctor. Okay.
Okay.
So the question is, any preference for the right areolar incision or side?
Why that specific right areola? Why not the left areola? Any
There's
robot
no
position?
there's no difference because generally in the BABA surgery, the right breast camera approach is very accustomed to the BABA surgeon. So that's why I prefer to the right breast approach. But sometimes it can change to the left side, left breast access, but there's no difference. So if someone prefer, you can try to the left breast.
Actually, this right-hand surgeons have this right Maryland on the right side. So I guess it is easier for the surgeons who are operating from the right hand. So that's why the right areola is good. And one question from Dr. E. What is the learning experience from XI to SP? Hello?
Come again? I'm sorry.
What is the learning experience from XI to SP?
Maybe if you have a prolonged experience of the BABA, it is very easily to adopt the SP surgery. Like Dr. Gian Chand, if you started, maybe 5 or 10 surgeries is learning curve. But the surgeon is not experienced about the XI BABA surgery, and it will need more than 20 or 30 cases. In Korea, there's many BABA surgeons, so I teach them about this supra method, and they only need to just 10 cases learning curve.
Asking about the haptic feedback. Is it there in SP system?
Come again, I cannot hear you.
Haptic feedback, tactile sensation.
Tactile sense. There's no tactile sense yet, but the new generation, 5th generation Da Vinci system, they have a tactile sensation, but the SP system does not provide a tactile sensation.
Hello. Hello, Chris O'Neill, endocrine surgeon from Australia. I wanted to congratulate you for presenting your work. You're really pioneering the world on this.
Thank you.
No one else in the world is doing as much of this. My question is, how do you choose which technique for which patient?
It depends on the surgery, depends on the operation theater situation. So generally, I recommend to the most patient to the single port robotic surgery. But sometimes the tumor is relatively very big, like 10 centimeter, or extensive metastasis, like such as jugular vein involvement. So in this kind of big surgery expected, I recommend to the BABA, but in generally, I recommend to the supra method.
So
I'm keen to know, we usually in BABA remove the specimen through axillary port.
Yes.
We never touch breast port for removal.
Yes. So
What's
specimen
your
will be,
experience?
specimen is packed in the plastic bag, and it can remove easily to the 3 centimeter diameter robotic trocar. So remove the robot, Da Vinci single port robot, and pull through the 3 centimeter diameter trocars. Very easy compared to the
Okay.
BABA.
Okay, thank you.
So if there are no more questions.
Yes, thank you very much.
Thank you, Dr. Zain.
the
Yes.
excellent demonstration of this technique. Thank you. Thank you for
Bye.
connecting with us.
Thank you, Dr. Jinwuki, for that excellent presentation. And thank you, chairpersons. We now proceed with the next session of video operative workshop. May I invite the chairpersons for this session, Dr. Adarsh Raghavan and Dr. Priyanka, to the dais.
So we'll start our video operative workshop, and now I'll invite Dr. Munir Wani sir from Shere Kashmir Institute of Medical Science, Professor of Breast and Endocrine Surgeon. Please welcome you, sir.
Very good morning. So today I am talking about focused parathyroidectomy. Before we will show our video presentation at the end for 5-6 minutes, I want to go through the background of this parathyroidectomy. So from century ago, when Mendel and Meko and then George, they started parathyroidectomy. The gold standard was bilateral neck exploration with limited resources, preoperative localization. That was the gold standard. This is today's theme, advancing precision in endocrine surgery. Everything evolved in a century. Now it is exactly a century ago when Mendel first performed the surgery of parathyroidectomy. And what evolved on all fronts. First is the exploration part, when no minimal localization was available. We don't have armaments to localize these things. Then the only thing was the experienced surgeon. They were looking for experienced surgeon. But with the technology, with the preoperative localization, we are able to do focused work. So with this background, from there to reach it to focused, what is focused parathyroidectomy? Let us define it. It is a minimal invasive procedure or a technique, surgical technique, to remove do a single diseased parathyroid without doing much dissection or unnecessary dissection. That is the aim. So there are advantages of this surgery. What advantages we have focused parathyroidectomy? Focused parathyroidectomy is minimal dissection, cosmetic, time is less, improves reduces hospital city, every advantage, and even it can be done under local anesthesia. So we will discuss in subsequent slides. Consideration of performing focused parathyroidectomy is the patient selection. So the ideal patient should have evidence to suggest presence of a single parathyroid adenoma. Key elements or key components for doing parathyroidectomy, focused parathyroidectomy is one of the most is the biochemical proof of PhD. You should be diagnosed, which is the diagnosis is only biochemical and clinical. Preoperative imaging that highly suggestive of single adenoma, that accurate pinpoint the adenoma is the key to plan surgery focused parathyroidectomy. Without this thing, it is not possible to do focused parathyroidectomy. It should be very accurate and pinpoint localization, so you can go. And of course, you should have an experienced parathyroid surgeon. So what are the contraindications of? Contraindications are foreglandular, multiglandular disease, such as familial hyperparathyroidism or Mann syndrome. In certain cases, you can even still go for focused parathyroidectomy. If you have a concurrent thyroid pathology to dealt, you can add if there is a discordant preoperative imaging. Relative, you may have some cervical disease, anticoagulation. They are quite relative. Known contralateral nerve palsy, previous ipsilateral nerve injury or lithium use. These are relative contraindications. Preoperative imaging and localization. This is one of the most important thing to do focused parathyroidectomy. Preoperative imaging is critical to successful focused parathyroidectomy. Provide surgeon the roadmap by providing precise location of gland and adenoma. Modalities, you know all, we have many high-resolution ultrasound with color Doppler, system B scan, SPECT, 4D CT, and choline. Mainly we do ultrasound in our center and high-resolution and system B scan. Sometimes you need 4D CT and choline PET. So operative preparation and techniques are anesthesia considerations. Type of anesthesia depends upon the surgical fitness of the patient, comorbidities, body habitus, location of the adenoma, and experience of the anesthesia team and the surgeon as well. The operative checklists are, you ensure the necessary components of the safety checklists are addressed, review the documentation, confirm biochemical proof of disease and the preoperative imaging in operative room. Anesthesiologists have to be notified about the need for and anticipate the timing of peripheral venous sampling if needed. So patient position and preparation, a natural sick increase incision made on the patient's neck in a sitting position. After intubation, patient is placed in supine position with neck slightly extended with support of beneath the shoulders. Packing the arms improve the ergonomics and avoid the retracting of angles, including the chin and sternum in draping surgical field effort easy. So we have in focused parathyroidectomy, front door technique and back door technique. So front we do as we do in thyroid small 2 centimeter incision, 2 to 2.5 centimeter incision in the midline, and then after raising slightly short flaps, then we straight we go to the divide the median raphe and retract the muscles and so familiarity of all surgeons with this anatomical, this is the advantage of front door or anterior in this midline approach, excellent cosmesis and ability to convert bilateral neck spleen if necessary. So sit-ups are, we decide 2 to 2.5 centimeter incision, then strap muscles are after raising the flaps, short flaps, and then muscles are separated longitudinally in the median raphe and thyroid mobilization and dissection of parathyroid. The care should be taken, adenoma should never be grasped or fractured. The tissue around it is alveolar tissue or fat should be hold, grasp fatty tissues and vessels to the adenoma to be divided or ligated, whatever is visualize the recurrent linear, assure that it is not grasped or divided. So backdoor technique is nothing else, it is same, but you go focused to the incision is given laterally 2 centimeter incision, and you go lateral to the strap muscles after raising the sternocleidomastoid. So after removing parathyroid gland, wound is irrigated Valsalva maneuver with patient internal workers to assess the hemostasis, strap muscle and palatus muscle if needed. Put 1 or 2 absorber sutures. Skin is closed with absorber subcuticle. So here I want to emphasize that is adjuvant necessary in while you are doing focused. Many centers, including our center, we don't do routinely adjuvant intraoperative parathyroid hormone assessment or measurement or frozen section. But when need arises, we are able to do and doing it, but we didn't find much benefit from. We have a literature backup with certain, I am showing. So now I am presenting video before, after doing all this checklist and positioning of patient, we first confirm with the localized again in OT parathyroid with Doppler and color time Doppler. Features are hypoechoic nodule separated from the thyroid and have a polar vessel. Once we confirm, then we start procedure. So next. This is a video of can somebody help me to play? So this is a middle-aged young female with the right inferior parathyroid adenoma. We first did ultrasound, localize. Thank you. Okay, first we mark the landmarks. Okay, hold. So we mark, landmarks are marked, and then small 2 centimeter incision made. Exactly 2 to 2.5 centimeter incision given. Little bit of flaps raised superior and inferior flaps. With after doing we so after the same setups which I described before in the slides, we just divide this mid and rapid. Just 1 or 2. So second, then after this, we identified the parathyroid. We hold the fat around the parathyroid, and then we definitely dissect it out, blunt dissection through avascular. After seeing the polar vessel, we coagulated it with bipolar. This is the parathyroid adenoma. We are holding tissue around the parathyroid and vessel and nerve identified. Vessel taken with bipolar of this is the parathyroid in view. We don't have proper recording system in our center. Was not working. We usually record these videos with our mobile phones. So that is a little bit, I'm sorry, shaking in between. But we do what I described in slides. You just appreciate the parathyroid in coming in view. Never fracture or hold parathyroid so tightly so that is the trick, that is, and lost a bit of, so we have exactly almost 3 centimeter, more than 2.5 centimeter adenoma. in intestinal long axis. After doing Valsalva and irrigation, complete hemostasis achieved. Wound close it back with 1 or 2 sutures in the median raphe to trap muscles back with their own. Okay, thank you. Just wait.
Thank you, sir, for such a beautiful demonstration of this important surgery. I have a few questions to you. Okay, sir. We'll move to the next. So our next presenter is Dr. V. Sinu sir, Director of and Professor in the Department of Breast and Endocrine Surgery, Medanta Med City, Noida. Welcome you, sir.
Thank you very much. At the outset, I take this opportunity to thank the organizing committee and the faculty of SGPGI, Breast and Endocrine Surgery, for inviting me. So this is a patient who had MEN1 syndrome with pituitary prolactinoma, insulinoma of the pancreas, and primary hyperparathyroidism. As she was being evaluated, she was found to have hypercalcemia, and functional maybe showed a left superior parathyroid adenoma, and anatomical 4D CT showed a left superior and inferior. What is important is that one particular imaging may not demonstrate all the glands, the adenomas, which you need to excise. So this patient was, after workup, was planned for a bilateral neck exploration and subtotal parathyroidectomy and cervical thymectomy under general anesthesia. Now it is of paramount importance that the position should be good so that you have adequate exposure to all the fields where you have to look for the parathyroids, both entopic and ectopic. And it is also important to use magnification because that aids in identifying vital structures. And also important to make the markings, the landmarks which have been discussed previously. I give an incision about 2 centimeters above the suprasternal notch, extending from anterior border of one sternomastoid to the other sternomastoid. What is important is that meticulous hemostasis and careful dissection is essential in all surgery related to thyroid and the parathyroid, and raise adequate flaps as described classically up to the thyroid notch superiorly, the suprasternal notch inferiorly, laterally up to the sternomastoids. Then identify the midline and open. And if you deviate from the midline, again, like you do a gentle dissection, you will be able to ultimately find the midline and go to it. So don't get hassled unnecessarily. Again, it is very important to open the midline adequately from the superior to the inferior aspect. And then identify the strap muscles and release them. Strap muscles, they are in 2 different planes, the superficial and the deep. So you have to know that, and then you have to stay close to the strap muscles and then lift them right up to the anatomical landmark superiorly and inferiorly. Like as you can see here that one layer of strap muscles is in one plane and the other layer in the other plane. And again, after this, stay close to the strap muscles and lift it to the entire anatomical field which you want to dissect. And do it slowly. There are many ways to do it. The best is if you're beginning, then use some right angle or something, lift layer by layer, do it slowly. And you can use both blunt dissection, sharp dissection, everything together, as long as you realize that adequate hemostasis and lifting small amounts of tissue and cauterizing and then cutting is important. Now you need to retract the thyroid gland. Again, many ways to do it. Normally I use it with finger, but for demonstration, I used it that you can also dissect with taking a suture. And you could see that the parathyroid gland with the surrounding fat is exposed. Most of the time, the parathyroid is never found lying superficially or It is always surrounded by some fat. And you can do this palpation method, which is called as the slip sign. That also helps you in identifying the parathyroid very easily. And the other important thing is, as you do the dissection, if you are in the right plane and you just put your artery forceps at right angle, the parathyroid just pops out. And the second important thing which Dr. Vani was also telling was never grasp the parathyroid gland. Always try to take some fat around it, hold that fat, lift it up, and then be in the right plane, and just the parathyroid just flops out. So this is one of the parathyroid glands, which was seen on both the imagings. And this is again the inferior parathyroid. Again, most of the time, this inferior parathyroid is in the inferior horn of the thymus. So again, there are many ways of taking out the thymus. You can take out two horns separately. You can take out the entire thymus together, or you can take it out piecemeal. But most important is that you have to remove all of the cervical thymus, and you can even put a retraction and take out a little bit of the thoracic thymus also through the neck. Again, dissection can be any ways. You can see here the parathyroid, which is popping out of the fat which is surrounding it. And it was actually in the left cervical horn. Again, never hold the parathyroid gland, adenoma directly. Now, these were the two adenomas which were seen on both sides. And since you have to, other places you have to look for an ectopic is have a good exposure of the tracheoesophageal groove. Again, that makes life very easy. Now you move to the other side. None of both the images didn't show this. And again, meticulous dissection, gentle dissection, little by little tissue, cauterizing at every step, hemostasis, for which you can use any of the energy devices. Again, expose the entire area of the thyroid, right from the superior lobe to the inferior aspect. And try to palpate and see here. I thought that there is some slip sign close to the tubercle of the Zucker candle. So I tried to dissect into it to see whether there is any parathyroid gland there. And then I realized that this was actually the part of the tubercle of the Zucker candle. So I just left it there, and then I came to the lower aspect and I looked for the inferior parathyroid, which, as I told you before, it was found in the inferior, the cervical horn of the right side of the thymus. One of the tricks is anything which runs longitudinally, never cut it unless you confirm that this is not a recurrent laryngeal. This is one of the tricks, and rest of all the landmarks, the relationship with the inferior thyroid artery, close to the Zucker candle, close to the superior parathyroid. All these landmarks are important, but it is very important that any structure which runs longitudinally, never transect it unless you identify the parathyroid and identify the recurrent. Here I was still not comfortable, so I removed that part of the Zucker candle and sent it for frozen section. And here, as you can see the right recurrent laryngeal now. So I didn't find the superior parathyroid. So now I look for it in ectopic locations. So again, look for it carefully in the tracheoesophageal groove. And if you do not find it, explore in the retroesophageal area. How do you do it is, always put a nasogastric tube in the esophagus whenever you are doing whether thyroid or parathyroid surgery. It helps you to identify these. So here the carotid sheath is open. Again, you have to open in the whole length, right from wherever possible from the lower margin of the mandible right up to the suprasternal notch. Lift it with either the vascular slings or anything. You can identify the vagus nerve behind it. You have to look for an gland. Never search for a ectopic parathyroid normal anatomic gland. It is not essential. So after this, then you do the closure after securing adequate hemostasis. So the frozen section showed the parathyroid adeno, left superior, left inferior, right inferior. Thymus tissue showed thymus, no parathyroid inside it. The thyroid tissue from Zucker candle showed thyroid tissue. And intraop IPTH following the surgery fell down more than 50%. So day one, there was no symptoms or signs of hypocalcemia. Voice was normal, tolerating oral diet. She was started on tablet Shelcal, which is our routine policy. She was discharged on post-work day 2. So this was the histopathology which showed what we had found on the frozen section. So the take-home message is, what I can tell is that you can broadly classify bilateral neck exploration into primary parathyroid survey and a secondary parathyroid survey. Primary parathyroid survey aids by your preoperative investigations, which is at least two investigations, one functional, one anatomical. And the other important thing is the entopic, that is the normally situated parathyroid glands. If you find one in a particular place, just look for in the same site at the opposite side, which makes your exploration very swift. If you do not find this in any of the known anatomical locations, then you do something called as a secondary parathyroid survey. Mind you, this is done only for a pathologic gland. Never go hunting for a normal ectopic parathyroid. And excision of cervical zones of thymus, either separately or en bloc, part of the treatment. Most important is meticulous dissection and hemostasis at every step is key for successful outcomes. Thank you very much.
Thank you very much, sir, for a lovely video demonstration of bilateral neck exploration parathyroidectomy. One question, sir. This we had localized. You are still choosing the anterior approach, sir, than a backdoor approach. Could we have tried a backdoor approach and avoided placing a drain? That's one question, sir. And the final HP, all three were adenomas, sir? Or was it a hyperplasia? All triple adenoma were noted. Okay.
See, going by the lateral approach, like bilateral lateral approach, I do not prefer. If it is focused parathyroidectomy, yes, I always prefer lateral approach. But bilateral neck exploration from the midline, you get both sides so easily. So why should I make another plane that side? So normally I do not do.
Any questions from the floor, please?
Sir, excellent presentation. One query from my side. So in case of subtotal parathyroidectomy, how to select the gland which you want to preserve?
I think very challenging question. I think some people from even the some faculty from there also had. I look for the most normal looking parathyroids. Okay, in size, in terms of color and whatever it is, and just I leave behind half of that. Otherwise, no particular. Definitely not the bigger ones. Bigger ones, I will never leave them behind. But if I identify one which probably looks as normal as I think it is, then only I choose that gland. Maybe Gaurav can add. Yeah.
That subtotal doesn't always have to be 3.5. It
Correct.
can even be 3.
Anita, you want to add something? Yes. Yeah. Yes.
All agree with whatever was being
Then
said.
what is
The most normal looking, as you told that.
Yeah.
If it is enlarged, then you have to be left behind about the normal tissue.
Yeah. See, basic thing is, So these are the things which cannot be put on in words as to this is the way to do it. You look for the gland which is as anatomical as possible in terms of size as well as the look, and then just leave behind half of that.
And before leaving the tissue, you have to confirm that you are.
Yes, that is absolutely essential, that you leave behind half of a lymph node which is having malignancy that is not appropriate. Always when you do it, you do send it for frozen. In fact, that's why I do not have a picture of all the three, because as soon as we remove it, we send it for frozen. Otherwise, the surgery gets.
Thank you so much.
Thank you very much.
So next I will invite Dr. Dhaval Bansal sir, Senior Consultant Breast and Endocrine Surgeon, Fortis Hospital, Mohali, for presenting topic on robotic parathyroidectomy.
Thank you, my teachers, for giving me this opportunity to present my work over here. When we talk about parathyroid surgery, it's not like a thyroid surgery where we are actually looking for anatomical, just taking out of the gland. Here, what we as an endocrine surgeon are looking for a biochemical cure rather than just taking out the gland. So as an endocrine surgeon, we always fear that we should not fail. But that is the bitter truth of parathyroid surgery. Even a expert endocrine surgeon can also fail. So there may be many techniques of doing parathyroidectomy. You can take the parathyroid from a transoral, transvestibular, transaxillary. There's lots of techniques. But as a endocrine surgery surgeon, what I emphasize that you should know which technique you are mastering, because at the end of the day, you are answerable to the patient and you want your patient to be safe. What I strongly feel for a parathyroid surgery, I still feels the open surgery is the standard of care. But like Sanjay mentioned in morning slide, we cannot run away from the technology. So we need to learn how to do, take the advantage of robotic or a endoscopic or any other technology. So just coming to the video case presentation, this my lady is a 40-year-old female who has screen detected hyperparathyroidism. It was well localized. It was confirmed to be left inferior parathyroid adenoma. Patient was initially consulted for open parathyroidectomy because it is a very small incision, like Dr. Muneen has shown. But patient these days in a tertiary care institute, we are seeing a lot of patients coming to us who don't want any neck scar. So for those patients, we are doing robotic parathyroidectomy. This is a Baba technique. What I'm going to show is a rabbit technique. So how the Baba and rabbit is different. In a Baba technique, what I feel for an endoscopic or robotic, I feel the flap raising is less. But when you're going for a robotic, the area of flap raising become more. So again, in a rabbit technique also, we are using 4 ports. I'll say 5 ports, 2 in the breast areola region, 2 in the axillary fold, and 1 is the port for the assistant between the 2 ports. So this is a video I'm going to show. So how I usually do it. First, I'll put around 1 centimeter of incision in the axillary fold. I usually do it with the open technique. Unless in the Baba technique, we are usually putting the port in a blind manner. This is an open technique. We go till the pectoral fascia, create an artificial space with the finger. You can see the rest of the ports are put under guidance. Your finger guides where the actually port should land. So 3 ports on the side of this section. Robotic ports are 8 mm ports, 1 in the breast region, 1 in the axilla, and third port is a 5 mm port. So this is the assembly looks like. Initially, we work with the 2 working arms. One is the camera port and second is the monopolar Caesar. The point, then we start raising our flap. The point here, what endocrine surgeon should take care, we need to be very meticulous. Any small vessel, whatever small vessel we feel, we should cauterize it, because if there is a bleeding, difficult to control in a post-operative setting, because we are dissecting lot of area and we cannot, it's not like a open technique where we usually reopen and take care of the hematoma. So once the dissection of the flap is raised, we place another 2 ports. I usually follow the midline approach. So just like a standard thyroidectomy, so you can see the midline has been being opened up. I am using 3 arms. One is progress, one is the bipolar, and this is a monopolar seizure. The monopolar seizure in a robotic arm work really well, and if you mastered with the monopolar seizure, actually it replicates your finger dissection. So just after opening the midline, you can see this is a lobe of the this is the left lobe of thyroid. This is the inferior cell, which I am just coagulating just to have some space and medialize the thyroid tissue. So in the parathyroid surgery, like I mentioned, it's not like a routine thyroid surgery. The disadvantage, what I feel, there is no tactile sensation. Before venturing into these sorts of endoscopic or robotic surgery, you should be very thorough with the anatomy of the parathyroid. Once we medialize the thyroid lobe, you can see this is the parathyroid which has been popped up. The parathyroid is out. I usually do intraoperative PTHSA. What I feel, because in a robotic parathyroidectomy, it's not like a focused parathyroidectomy where we are actually entering into small area. There is a lot of tissue violation. So usually what I usually So this is a superior parathyroid. So this is all. Sorry. Sorry. Once the parathyroid, I've seen the superior parathyroid, I'm just retrieving the specimen with the finger glove. At any point, I don't breach the capsule of the parathyroid. I'm just suturing the strap muscle, which I have already cut. So this is all in the robotic. This is a specimen photograph. Again, 1 centimeter parathyroid. This is a final outcome, 4 small cuts in the chest. The take-home message. So what as a endocrine surgeon doing a robotic cases, what I feel cost message is great. The section is extensive as compared to the open or the standard procedures. Pain in the post-operative period is more as compared to the open surgeries. Outcome is similar if we follow the principle of a standard parathyroidectomy. And there is always learning curve. Like in the morning, someone asks how much cases actually someone should do for a overcome the learning. Whatever the most of says is the 10 cases of robotic thyroid or parathyroid surgery, which you should do to overcome this learning challenge. Just a small take-home message to my younger colleagues who are a budding endocrine surgeon: never violate the principle of a parathyroid surgery. Working in a private institute for more than 10 years, operated many cases. I never take a parathyroid lightly, because one single day you can actually fail. So that should be the take-home message. Thank you so much.
Thank you, sir, for such a beautiful demonstration of the surgery. I have a question to you. I mean, do you have any selection criteria, or it is just a patient wish when patient demands you do the robotic parathyroidectomy?
Ma'am, what patient in which I usually feel there is a localization, enough of localization that I cannot uh, miss the parathyroid, I usually operate those patients as a robotic or a endoscopic parathyroidectomy. Because what is the problem with the robot? There is no tactile sensation. If there is a ectopic parathyroid sitting in the retroesophageal or any other location, you cannot actually feel. If the parathyroid is deep down, the robotic arm actually don't bend so much. So when there is a clear-cut localization, I usually choose that patient for a robotic or a whatever minimal invasive surgery. So that's my selection criteria.
Have you used any time ICG or any autofluorescence which is available in robotic system which helps? Does it help?
Ma'am, like ICG has just come up in last 2 or 3 years, what I feel. I am practicing, majority of my teachers actually trained just by seeing the normal parathyroids. So as an endocrine surgeon, we are not actually much dependent on these technologies. As an endocrine surgeon, we actually can see this is a parathyroid or not. So that's a message from my presentation. Before you start venturing on these minimally invasive surgery, you should be mastered in open surgery.
Hi, Naval. Excellent presentation as usual. I just want to understand, for the sake of so many surgeons, those who are here, who are interested in robotic surgery, but there are cost constraints always. So what is the approximate cost that the patient has to bear at your center?
This is the last question. This was a question you have already asked in the last conference, if I still remember. So in our center, we are charging 1.5 lakhs extra over and above the open surgery. But again, it varies from institute to institute. Like some centers are charging around 1 lakh. The newer centers which are just start promoting their robotic surgery, they are charging of 25 to 50. Again, it depends on your expertise, your institute reputation. Patient don't mind paying till the time you're doing good work, your reputation is good, your institute is good. So that's my I'll say in insurances, if you want to ask, ma'am, for benign cases, so because parathyroid is a benign disorder, so majority of insurances don't cover benign cases as of now. But again, it depends on the insurance to insurance company. Some give, some don't give. But if the patient really wants to go for he or she has to pay 1.5 or whatever the insured charge. Yes, ma'am. Ma'am, that's a standard of Baba technique where we are actually making the space with the instruments. Here, this is a rabbit technique where actually we are going open way. So one side of dissection, I'll say 5 to 10 centimeter, we are usually doing with the help of our finger, or there is some illuminating retractors which we don't have, but I usually take the help of my finger just to create a plane over the pectoral fascia, and finger really works well. It's a 1 centimeter incision. So you can actually dissect out around 5 to 10 centimeters space.
Sir, excellent
Yes.
presentation. I have two quick questions. So one, you said that you prefer to do robotic parathyroidectomy only in a patient whom you are very sure that it's a single gland, preferably.
Yes.
So you are sure that you want to localize it. So localization, I want to know whether you use only ultrasound and maybe, or you do a cross-sectional imaging as well, CT or colon PET. The second question is, if you know that you are going to do only single gland, preferably, would you approach from the axilla alone, or you would always prefer a Baba technique or a rabbit?
So I'll answer both the questions. First, like a year back, we were just doing ultrasound as well as BB scan. So that's why our standard localization technique. But what over the period of time, what I have realized, ultrasound is a totally operator dependent. So sometimes there were a few cases actually which was wrongly picked up or misdiagnosed. So we started doing 4D CT because you can get a 4D CT done, but to read that 4D CT, you need a good radiologist. To be very honest, I'm not very much confident in reading 4D CT. So last 1 year, we started doing 4D CT. We usually don't do a colon PET. If there is a known localization on these conventional approaches, we usually do colon PET. Coming to the second question, whether sorry, what was the question? I'll prefer the
Would you
Baba.
still prefer Baba or Rabbit if you know
Yes.
that it's a single site? Because you are anyways, you want to explore the superior. So you
Yes.
can might as well go from the lateral approach.
Usually, the first case I did, it was a infraclavicular approach where we usually, or you can say one-sided approach, what you mean to ask. In that case, we usually went between the two heads of the sternocleidomastoid. The disadvantage, what I feel, because sometimes it's even though with the good localization, you end up doing a bilateral neck exploration. For that, you need a fourth port also. Because fourth port, 8 mm incision actually doesn't matter much in a long run. But the retraction with the progress with the fourth instrument actually adds lots to the surgeon's I'll say luxury. So doing just a unilateral approach and at the same time you need to explore the other side, it's become slightly difficult. My experience is only of around 30-35 cases. I'm not that experienced surgeon, but this is my own say. I'll usually prefer a Baba technique. As I become more wiser or I'll become more expert, may start doing this unilateral approach.
Thank you, sir. I think we are crossing our time limit. Thank you so much. And now we'll welcome our next presenter, Dr. Sai Vishnupriya, consultant endocrine surgeon in Apollo Hospital, Chennai. Welcome you, ma'am. And ma'am is presenting on topic VATS parathyroidectomy.
Yeah, good afternoon, everybody. And at the outset, I would like to thank the whole SGPGI team, Anjali Madam, Gyan Sir, Kaurav Sir, Sabha, and everybody for giving me this wonderful opportunity to talk at the 16th postgraduate course in endocrine surgery. So I thought I will take this up. This is one of the easiest surgeries to perform when it comes to mediastinal parathyroids. This is the video assisted laparoscopic parathyroidectomy. So going on to it, this was actually referred to me by a general physician. So I think it was one of the master health checkups that she had. It was a 43-year-old female who presented with gastritis and bony pain. So usually you take it up as like one of the perimenopausal features. But then when investigated, her calcium was high. So then the PTH was done. And repeatedly again, the other one was also high. So then she was sent over to me. And yeah, I did a cystoscopy and a SPECT, which showed an ectopic. Her parathyroids in the neck were normal, and the thyroid was also normal. There was an ectopic functioning parathyroid tissue in the mediastinum on the right lateral aspect of the ascending thoracic aorta. It was around 1 into 0.5 into 0.3 centimeters. So that's the cystoscopy, which you can see, which very well shows you. There's even a delayed uptake there, a nice picture. And that's the SPECT CT as well, which shows you that the site where it's around like T4, T5, T6, something around. So it was like just close to the ascending aorta. So I've done 3 to 4 cases now in the private setup. And the initial case I did with the help of a cardiothoracic surgeon. So I would say it's one of the easiest to perform in the sense that you can avoid sternotomy and of course the robotic. This is one of the easiest and cost effective, and also like the morbidity is very less. So going on, so before that, I don't have the opening picture, but I will tell you, we put the patient on left lateral, and the fifth intercostal space is the ideal place for a thoracoscopy because you can go up or down. You go, and it's very, very easy when you go into the intercostal space, you go right in, and it's a uniportal incision, a 3.5 centimeter. I know 3.5 is big, but when it's in the mid-axillary line, you really don't know, because when you do, it's like you do a very skin, the wound like thing, it really doesn't show. And then you can just put the camera, you can put your instruments also all in the same foot and finish it. I think it hardly took 20 minutes or 30 minutes for the whole procedure. So initially, so after painting, we put in a wound ring. So this is the, how do I do it? So yes, this is the going in. And once we go in, and only you you can see that we had a retractor for the, and we had to deflate also. We had asked the anesthetist to deflate the right lung, and we could just we used retractor, not a retractor, thing to just retract the lung, and you're directly into it. It's just the suction there, which is holding, you're just holding it, and you're using the harmonic to dissect. And there, right there, you can see that there's that is there a pointer? Okay. So do you have a pointer, please? Okay, that's okay. I think you can see it there. It's obvious. You just go inside and it's there. That's it. So once you retract that lung, you just see that there is that grayish tissue. Okay, so there you can see that grayish thing over there. So right there, and you start dissecting out, it's like just comes out in your hand. So that was embedded in the thymus. And once we opened the capsule of the thymus and we dissected a little bit, and you can see that the heart is down. You can also see the SVC. And yeah, that's the SVC, and the heart is right down here. So we are just on it, okay? It's pretty, the view is very clear. Once you pull the right lung, the view is pretty clear. So we're just dissecting that. Okay. It's just a 5 minutes video. So because I've just got one case, the video of one case, the parathyroid has already come. Oh, I'm sorry. How do it's forwarded? Keep it. Okay. That's what did it. But, yeah. So there, parathyroid is already there, and we're just using that holder there to show the lung holding forceps, and with the harmonic just dissecting out. Sorry, I think I'll leave it alone. I think it'll finish anyways. So that's the nice one. So you just go round and get out. So since it's you are using just two instruments, that 3.5 centimeters is more than enough. You're doing right under vision. And that's it. Parathyroid is it's just going to come out. So you can avoid your sternotomy. You can even avoid your robotic if necessary. And that's again, yeah. So that's the little difference. Yes, I need to. So yes, And since it's like a 3 centimeter, you can take it out through that. You can put the ICD through that. So everything is over with that. You don't need anything extra. And you can put the ICD under vision itself, like you use so that it goes right under the lung. So it's out. Absolutely. Yeah, that's the vision. And then we're just securing hemo, so there's nothing there. So then we will need to put an ICD there. Whenever you're opening the cracks. So under like you can put the ICD, you can put the camera, you see that it's right under the lung. That's the yeah, now we are just putting the ICD there. And we removed it in 2 days. And the wound closure is also very easy. Absolutely nothing. You're going the intercostal space. So just, the muscle and then the skin. That's it. You put a nice proline skin, you're done with. So that's over. And then by this way, we did also the intraoperative PTH monitoring, and it showed fall. It was actually, it came up 25 to 8. Frozen section also did, and it actually showed an adenoma itself. Nice one. Histopathology confirmed. Postoperatively was 28 and calcium was 8.4. The patient is still on follow-up. And yes, I'm done with it. Thank you. So I would advise this. Basically, it's less cumbersome, less comorbid for the patient, easier to learn. Cost-wise, it's much lesser than doing a sternotomy. So easier to learn as well. Thank you.
Thank you very much for that wonderful presentation, madam. Any questions from the floor?
And also the magnification is like 20 plus. So you're like, yeah, it's good. It's good magnification as well.
Yeah, thank you very much.
Ma'am,
one question, sir.
Yeah, wonderful presentation. Ma'am, I have a small doubt. So have you had experience with using a normal ports rather than just 3.5 centimeter, like what's proper when we use 110 millimeter?
Yeah, you can.
5 millimeter, which would be less. And
No, this we wanted a uniport because instead of 2-3 ports, like one to put here, one for the forceps, one thing and mid-axillary line.
Because anyways, only 2 instruments are.
Yeah, it's only 2 instruments.
So
But
2.5 mm would also be.
yeah, you can, but this, I found this very easy. Just one, go in, take it out. Everything is over. Put the ICD, everything is.
Because we don't have to close those ports also. It's just the skin which we.
Yeah, you can.
That's what I had. Thank you.
Thank you very much, ma'am. Thank you. Thank you. Next up, I would like to call the next speaker, Dr. Vivek Agarwal, sir, for his video demonstration of laparoscopic adrenalectomy. Welcome you, sir. Sir is the consultant endocrine and breast surgeon and associated with Grassen Hospital, Punjabi Bagh and BLK Max Hospital. We welcome you, sir.
So a bit of correction, it's Maharaja Agarsen Hospital. Good afternoon, everybody. Today my job is to show you a standard conventional laparoscopic adrenalectomy. So coming straight to the slides, forward will you come? So this is a case of 8-year female who presented with changing body habitus and hypertension for a few years, and you can see the very obvious changes noticed by the parents, for which she was evaluated and found to have ACTH independent Cushing syndrome. CT scan showed bilateral adrenal hyperplasia. She also had on evaluation incidentally detected pituitary adenoma, non-functional, and no other evidence of syndromic association. So we planned for a bilateral adrenalectomy for this girl, and it was through a conventional standard laparoscopic transperitoneal approach. positions our lateral decubitus position for both sides, left and one side left up, then we change the position for the other side. And standard precautions like anticoagulants and ensuring all IV lines were followed. So coming straight to the video, first I'll show the left laparoscopic adenectomy. We used 3 ports initially, subcostal ports in mid-clavicular, anterior axillary and posterior axillary line. So first we basically use an open book technique wherein first we mobilize the splenorenal and splenocolic flexure, and then we enter the avascular plane to medialize the descending column. So all flimsy peritoneal adhesions are removed to medialize the mesocolon. So we have to be careful that we don't go beyond the on the posterior aspect of the kidney during this dissection. Sometimes this is a common mistake. So in this case, the challenge was because of Cushing's, it was all full of fat, the mesentery as well as the perirenal fat was full of fat. So identifying adrenal was a challenge. No, this is avascular plane of tall PD. Cut it to further, push the colon down and reach the medial aspect of the renal and adrenal hilum. So now there will be 2 ways to, reach adrenal gland. Either you first trace the gonadal vessels and renal vein. In this case, because of a lot of fat and all, we first thought to sort of identify the adrenal gland first. And for this, we first open the Zerota's fascia. So now we'll show the step of opening the Zerota's fascia. And then we try to identify the superior pole of the kidney first so that we have a fair idea of where the adrenal is. And if we look at the CT picture, it was more, placed medially. So instead of doing a lot of dissection more laterally and posteriorly, so this is the upper pole of the kidney, just to use as a landmark so that we don't, you're not lost in the fat. So then adrenal gland is identified, and then luckily we could also see the adrenal vein. I think if you can appreciate, this is the adrenal vein. So not a conventional way. We would rather first like to have a identification of renal vein and then adrenal vein entering into it. But here, since we could identify this, we thought we'll isolate this directly. We can very well see this is draining the adrenal gland. So one has to be very gentle dissecting this. So we had to use another fourth port to sort of, give a little bit of traction, as the adrenal was quite deep. So adrenal vein was then, hemostasis was ensured using Liga clips. Sorry, hemo clips. So we use two clips towards the towards the draining side and one towards the adrenal. I think half of our job is done once we have ensured hemostasis, ligation of adrenal vein. So then adrenal is gradually lifted off the surrounding structures. Most of the dissection was done using harmonic. This could be another, accessory vein or the inferior adrenal arteries. Just thought of clipping this also. So the problem with Cushing's disease syndrome is that there's a lot of surrounding fat, which makes dissection level difficult. So then the specimen was delivered through indigenous endo bag, and then these ports were closed, and then we shifted the patient right up position for a right adrenalectomy. So we just quickly go through the right also. Meanwhile, if we have questions, we can take that. So right side, the problem was a huge liver, which was lifted using one of the separate fourth port put through epigastrium. Then we cauterize the duodenum and ascending column and hepatic flexure was medialized. Identify the IVC, just maybe 3-4 more minutes. The organizers permit. Very difficult to squeeze a 2 hours surgery into 10 minutes. So here we then identify the IVC. The peritoneal fold is that we try to look for the renal vein and adrenal gland. So we could just find one accessory polar vein which we isolated but didn't do anything, and we moved more cranial to identify the adrenal gland. So this is the adrenal. It was quite deep, covered by large shining liver. So when we have isolated the adrenal vein, I think we can appreciate this. You have to be really very gentle here, because if you happen to tear adrenal vein, then controlling it is a nightmare. So we doubly clip this. So rest of the dissection is then easy, isolating the gland from the, dissecting the gland from the surrounding structures is not that a big task. Some tissue you can see was left behind, but I think that won't be of much problem.
Don't have any queries, so they can ask in between. Otherwise, after finishing this, we are running more time. So,
I suppose I've got a comment more than a query. I'm probably the person in the room who has the most experience in operating in really fat people with adrenal surgery. We encounter very fatty adrenals, very fatty problems all the time, very fatty livers that are difficult to pull up. I'm interested that you took a direct approach to the adrenal, and that's something I've never done, and might try it sometime if I've got a smaller one. But for big fatty lesions, I find a big exposure necessary to make safe operating. On the left, that includes mobilizing the spleen and the tail of the pancreas. And on the right, that includes mobilizing the triangular ligament right the way across, so that you can actually pull that fatty liver vaguely out of the way. Sometimes it involves additional ports. I've used up to 6 ports in a laparoscopic anterior adrenalectomy just to help me push fat out of the way. So well done in these cases. Clearly that was very challenging, but maybe something else to add to the discussion.
Thank you for your comments.
Thank you very much, sir, for a lovely video demonstration of bilateral laparoscopic adrenalectomy. For want of time, we'll go to the next speaker, sir. Next up, I'd like to call Dr. Sudhi Agarwal, madam, who's going to have a video demonstration of posterior retroperitoneoscopic adrenalectomy. She is the director and CEO of the Ben Super Specialty Clinic, Meerut, and consultant and head of Department of Breast and Endocrine Surgery at Newtema Hospital, Meerut, and is affiliated to the Newtema Hospital and Ben Super Specialty Clinic, Meerut. Thank you, ma'am.
Right. Thank you very much. And indeed, it's a great pleasure. It's always like coming back home. And I'm very thankful to the organizers to let me wish on this auspicious day of Teachers' Day to all my teachers who are instrumental in what I am today. And to my friend Sabah on his birthday, he's really a teacher of teachers. And also would like to say thanks before I start my presentation to Dr. Martin Walls, who is a pioneer and has a very great name in doing retroperitoneoscopic adrenalectomy. And I had an opportunity to interact with him in person in 2016, and would just devote this presentation to him. So adrenalectomy, lot of things we have talked till now, and we all know that we can do it open, we can do it endoscopy. In this era of minimally invasive surgery, now endoscopic surgeries are the norm. We have 2 options, transperitoneal, which Vivek sir has already demonstrated. Now we will be talking about retroperitoneoscopic approach, and I am sure this presentation is going to be very crisp and brief. And I believe at the end of the presentation, most of the surgeons are going to love this technique and will definitely try to switch their techniques from transperitoneal to retroperitoneoscopic. And there's the major differences between these two, like the orientation is absolutely different in both these techniques. And after the start of this minimally invasive techniques in 1992, first time Higashira in Japan and Gagner in Canada, they first reported doing retroperitoneoscopic adrenalectomy, as what the literature says. So what are the various advantages? First of all, you bypass handling all the abdominal viscera like the liver, spleen, pancreas, the gut, and everything is just bypassed. It's a very, very direct approach. Therefore, it has a very less operating time. It reduces the morbidity because we do very limited dissection in this technique, and it has a very early post-operative recovery. There is no chances of abdominal hernia. And what the things which I have not mentioned here is it has a very, very less pain compared to the transabdominal surgeries. And also, whenever you are doing a bilateral adrenalectomy, you don't have to change the position of the patient. In the same position, you can perform both the surgeries together, right? So with this, we have a happy patient and as a happy surgeon. So now just going on to the position, how should we position? This is the exact position. So important things that we have to remember is the spine should be straight. These are the tips and tricks also. And the abdominal wall must have a free movement. So we can apply some bolsters like in this image, or otherwise the neurosurgeons, they often use this instrument like in the roti. I don't remember the name, but this is very, very helpful. And this is what I have applied in my patient. So the knees and head should be supported, and we must ensure that there is the respiration is going on. There's no anesthesia related issues. and operating side should be flush with the table edge. So if we are operating on the right side should be at the table edge. If we are on the left side, it should be on the edge of the page. Because like if we don't do, then there will be some cluttering of instrument, and it will increase some operating time and inconvenience to the surgeon. So now about the incision, where should we place the trocars? So it is usually a 3-port technique. So the first and the primary port we put just below the tip of the 12th costal cartilage, and we mark the ribs and accordingly. Now, when we put the incision, I'll be showing you the detailed video, but here I'm giving you some orientation. So when we put the first trocar, this is under finger guidance. We go directly into the retroperitoneal space where we feel the gyrotose fascia and we can feel the kidney. And then under finger guidance, we put the second trocar, that is just cranial to the tip of the 11th rib. And just cranial, why? Because so that there is no cluttering or minimal cluttering of instrument, because this is a very close space. And preferably the third port is placed midway, just lateral to the paravertebral muscles, in between the first trocar and the lateral margin of paravertebral, in line with the first incision. And this should preferably be done under vision, but if not, you can do under finger guidance also. The aim is to avoid injury to the subcostal nerve. So this is how we put this is the second port that I am putting, and this is how all the ports are being put here. So we usually take 10 mm 30-degree telescope, and apart from that, we use a 10 mm port on the medial aspect, because later on we switch on the camera there and we use the first port to retrieve the specimen, and a 5 mm port as a working port. And we put a 20 millimeter of mercury of carbon dioxide pressure, depending upon the area that you want to create. So this is the video. Right. Take a full set. From polythene bag, we just take it out. And this is the specimen. This is our team, and this was the patient. I'm sorry. Right, but this was the patient. On the first post-operative day, he was sitting like this and he was walking, and we just allowed him orally. And the next day he was discharged. We just checked his blood pressures, no fluctuations, discharged him with a happy patient and myself being a happy surgeon. So before I conclude, there are a few important practical tips, right? There should be an optimal angle between the spine and hip. So it should be at 90 degrees. Just make sure, like, it should be at 90 degrees. So the space between the iliac crest and the costal margin is open. Placement of trocars is very important. If you place the trocars too close, most of the time there is a cluttering, especially for a new surgeon who is new to this technique, it may create some problem. Identify the upper pole of the kidney first. So our most important dread in this type of surgery is the renal injury, right? So it is very important, like we identify the nerve and then we proceed with the dissection. Please identify the kidney, the upper pole, superior pole, and gradually, because it is a relatively avascular plane. So just identify the structure and go ahead with your dissection. Inferolateral to superomedial dissection, right? So just take care. On both the side, it is applicable the same. In your early learning curve, do not approach for big tumors or challenging cases because the space is limited. So if you just go for a big size tumor, there will be some manipulation issues that you may find. And a large BMI, as such, it is very good for a large BMI patient because you bypass so many and you are directly into the space, but they may have some respiratory compromise. So just making them prone may cause some problem, so that you have to decide on a case-to-case basis. And that's it. And with that, I would like to thank you all for your patient hearing. And I hope I'm able to convey the technical details, which I really want to. Thank you.
Thank you very much, ma'am, for that detailed video. You made it seem very simple. Is there actually a learning curve for this, ma'am? Yeah. How many cases did it take for you to become this good?
The learning curve is much better in this technique because, like, you don't have to handle the major viscera. Like, suppose for liver. So we were struggling hard when we were doing transabdominal surgery because liver lobe always tend to hang down. Then we have to just retract the liver. So we need good assistant for that. Here we don't need any assistant. There were 3 ports only, two my working ports. One was camera port. Nothing else. No 4th port. So I think this is a promising technique, and I'm really feeling good while I do this, and easy also. Yeah.
And while addressing the adrenal vein, it was again with only the energy source. There is no necessity for
abdominal surgery. We find the cases where the adrenal veins are too high. There are multiple adrenal veins. Some of them are like very inaccessible position. Here, because you are going through the posterior approach, so adrenal veins are quite accessible. Even the very non-accessible adrenal veins becomes accessible in this technique. And you don't have to retract the liver because liver is already supported in this part of the body. So the adrenal veins are quite in front of you, and it is more easy to handle the adrenal vein, especially on the right side. Left side also, the things are quite straightforward because the adrenal vein is into the renal. You just have to make sure that you identify this anatomy of renal vein and adrenal vein. And by chance, you just don't clip the renal vein.
But you can do it without clipping, even with an energy source, you were able to completely ligate them, or do you routinely have to clip them?
I routinely clip them. In that particular case, I think vein was not that much and I was comfortable. Otherwise, I routinely clip. With either 400 like a clip or with this Hemalock. Yeah.
Ma'am, what is the maximum size of adrenal tumor you have removed through the retroperitoneoscopic approach?
I think it was around 3 to 4 centimeter tumor. Because once I do the dissection and during retrieval, if I find any problem, either we morcellate the lesion. That's just something like what we do for transabdominal surgery. We just increase 1 centimeter, 2 centimeter, and just few maneuvers, we retrieve the lesion. So that's not a big issue.
Yeah. So size, if it is more than 4 centimeter, is it a limitation for doing this retroperitoneoscopy, or you do still?
So this is a relative contraindication. What I said, because the space is relatively limited, if the surgeon feels that because that surgeon is comfortable doing that, I don't think there is any contraindication that you must not go ahead. But when you are suspecting cancer or some difficult surgery, or if you are not that comfortable, then you can go for, and especially I think we should see for the adrenal veins, the position of adrenal, with the help of radiologist, how accessible these adrenal veins on. If we feel that they are less accessible, I think retroperitoneoscopy is a better approach.
Thank you, ma'am. Any question from the
Yeah.
floor, sir, please?
So just 2 comments. Like in old times, no, all these patients of Cushing syndrome in whom we used to have wound complications. This was the approach we used to follow. We used to call it as a bilateral lumbotomy approach. The approach is exactly same, small incisions you can approach. Very, very impressive video, and I'm really encouraged that by my experience of lumbotomy and your enthusiasm, I should start doing retroperitoneoscopic.
Thank you.
The other thing is, you said, can we take the adrenal vein by energy device? Yes, but never take it at one place. Set the put the settings of your like ultrasonic machine at 1 and 5. The coagulation should be at 1, not at 5. And do it at 3 places. Like it makes sound, no? Allow it to make 4 sounds, stop there, then do it at another place and do it in the center. And the center one, you continue to cut at 5 coagulation, and it is possible to do it. Thank you.
Thank you very much.
Thank you, ma'am, for such a beautiful presentation. Now I invite our next speaker, Dr. Pushkar Sharma, Assistant Professor, Breast and Endocrine Surgery Department from Christian Medical College, Vellore. So he'll be talking on laparoscopic surgery for pancreatic neuroendocrine tumor.
Good afternoon, everyone. I'm here to replace Dr. Paul, who will join us tomorrow morning. So I'll be talking about the lateral laparoscopic approach to pancreatic tail insulinomas. I bring greetings from clear blue skies of Vellore. So when we talk about the pancreatic insulinomas conventional supine approach, you use a 5-port approach commonly, and you approach the pancreas through the lesser sac via the gastrocolic omentum. This also requires a continuous cephalad retraction of the stomach. So what we are going to describe is the lateral approach, which we are quite familiar with when we do the adrenalectomy. So the patient is in the right lateral position with the kidney bridge. This approach is suitable for distal body and tail lesions, and the medial retraction of the spleen is assisted by gravity. So this is the patient positioned as for a left adrenalectomy in the right lateral position. So the approach is going to be first mobilize the spleen and the colon, and then approach the pancreatic tail from this plane. So our patient is a 25-year-old gentleman who unfortunately presented with symptoms of permanent neurological damage due to a missed recurrent hypoglycemia. So at presentation, he had symptoms of cerebellar ataxia and slurring of speech since 5 years. There was no significant family history. On biochemical evaluation, his fasting blood sugar was as low as 16 mg/% with an elevated C-peptide and insulin levels, making a diagnosis of insulinoma. He also had prolactinoma with elevated prolactin levels and mild asymptomatic hyperparathyroidism. So he was clinically diagnosed to have MEN1 syndrome. We proceeded with localization studies. We usually use triple modalities. We do a contrast enhanced CT of the abdomen with additional MR cuts and use endoscopic ultrasound. So for this case, we localized 2 lesions in the tail, and there was no lesion seen in the head. So even though he's MEN1 and traditional approach would include a laparotomy and thorough exploration, because of his comorbid condition, we had decided to go the minimally invasive route. So now I'll switch to the video. For the port placement, first we mark the subcostal region and the iliac crest. The camera port will be placed along the midclavicular line, midway between the umbilicus and the anterior ASIS. That's the camera port, a 10 mm port, and 2 working ports, one 5 mm and one 10 mm. and a 5 mm port laterally for retraction. So now the ports are being placed. After port placement, the first step would be the mobilization of colon and spleen. This is the same way as we do for the adrenal, the open book approach. As we mobilize this, we can see we have to divide the ligaments that hold the spleen. So to facilitate the medial retraction of the spleen, and that's the kidney in vision. So this is the splenic hilum that now we can see after mobilization of the spleen. Here, as we open this fascia along the inferior aspect of the pancreas, the tail of the pancreas is in vision. There we can see one lesion. By virtue of the biology of the disease, insulinomas have a lot of fibrosis and tend to be firm to hard and can be felt on palpation. This is the port for retraction. So as we continue to open that fascia, there we can see the second lesion. Those are the two lesions. The fascia over the lesion is open. Now we prepare to enucleate the lesion with the help of bipolar and harmonic shears. The first lesion is enucleated. We can see this lesion was closely related to the splenic vein. The another thing to aid the dissection here is we've taken a stitch through the lesion for traction. And using harmonic shears, the lesion was enucleated. The tumor bed hemostasis was secured using bipolar, and we placed the surgery cell on the bed. The retraction of the specimen using endo bag. Postoperative, on day 3, he had accidental exteriorization of the drain, and following which he did have a peripancreatic collection with evidence of sepsis. We had to do a CT guided aspiration for this collection, and he was started on higher antibiotics. His post-op, otherwise recovery subsequent this event was uneventful. We went on and did the subtotal parathyroidectomy 3 years later, and he's recurrence-free 14 years from now. Thank you.
Thank you, Pushkar, for a wonderful demonstration of 2 enucleations done on that same patient. Any questions from the floor? Yes.
Thank you. Excellently done surgery, excellently handled patient, and very good video. Do you use laparoscopic ultrasound?
So our department doesn't have. Department of HPB does have laparoscopic ultrasound. So far, the patient selection has been very meticulous using preoperative localization. So because we do all 3 modalities, CT, MRI, and endoscopic ultrasound, we've not had to use endoscopic ultrasound per se. And luckily, we don't choose patients with deep-seated lesions. So those which are closer to the surface of pancreas, if seen on imaging, are the patients we've chosen for this approach.
Yeah, good. But thing is, it's always good to use laparoscopic ultrasound whenever you do neuroendocrine tumors of pancreas. One, to see the relation with the pancreatic duct. Like your second lesion, no, maybe seemingly looking superficial, but it normally these lesions, no, they spread to the same distance as you see it outside. Suppose it is 2 centimeters outside, usually it will extend 2 centimeters inside. And it is not uncommon that at surgery, when you do the ultrasound, you find that it is very close to the duct. The second thing is, whenever we do neuroendocrine tumors, we always like to open the entire gastrocolic omentum. And we usually do it in supine position with a sandbag on the left side, which gives effectively same as lateral position. Now, the advantage of opening up is that it is not uncommon to find an extra tumor, especially when you use laparoscopic ultrasound. And also the relation with the pancreatic duct is better. Like what you're telling your patient at postoperative pancreatitis, that could be because of a little bit of pancreatic leak and which could have subsequently got infected. So laparoscopic ultrasound is a good armamentarium if you want to do neuroendocrine tumors of pancreas laparoscopically. Thank you.
I agree with that, sir.
Thank you, Pushkar.
That concludes our morning session of the surgical videos. Thank you all the speakers and chairpersons for your contribution. We would be starting the poster walk. So all the poster presentees, please stand beside your poster presentation. Please join us for the lunch outside. Thank you.
We will reconvene at 2 p.m. So please be on time to the hall. Sharp at 2 o'clock.
For centuries, santoor has been played in the valley of Kashmir. In a typical style of music, known as Sufyana Musiqi, it has been played as an accompanying instrument with the vocalist and sometimes as solo also. It was originally known as Shatatantri Veena, which means 100-stringed lute. The name santoor was given by the Persians. Similar instruments are found all over the world, like santoor in Iran, yangqin in China, cymbalum in Hungary and Romania, santuri in Greece, hackbrett in Germany, hammered dulcimer in certain European countries and America. Santoor is played with a pair of curved sticks made out of walnut wood. It
गरज 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 आज मेघ खनन खनन छायो रे
check one. Hello, hello, check. Hello. हेलो ऑडियो आई थी एक आपको बात हुआ क्या क्या है तो सब देख रही हैं कहाँ कर देखो चेक बाय मुनीर check one. Hello, check one. Hello, hello, check one. Hello, 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 check one. Hello, check ठीक आ रही ना हेलो हेलो अरे हम वहां से बढ़ा देंगे कोई दिक्कत नहीं हाँ एक अब फिक्स कर दीजिए ठीक माइक ये किसका कैच कर रहा है माइक माइक वहीं से हो रहा है हेलो चेक वन हेलो चेक वन हेलो ठीक हेलो हेलो चेक
Good afternoon. Welcome back. We hope you enjoyed a hearty lunch and are energized for the upcoming sessions. Next in line is the workshop on thyroid ultrasonography and microwave ablation. The session will be coordinated by Dr. Anjali Mishra. I invite you, ma'am, to the stage. I would also like to invite to the dais our distinguished chairpersons for this session, Dr. Nikhil Singh, Dr. Chandan Jha, Dr. Siddharth, Dr. Sanjay, over to you, ma'am.
So good afternoon. Welcome to this section of workshop. And we have planned to have a session on microwave ablation of thyroid nodules. And what we planned was that we would be giving a brief appraisal followed by expert videos by Dr. Siddharth Chakravarti and Dr. Sanjay Kumar Yadav, who had been practicing this modality on regular basis, and they have considerable experience in this thing. And our department is right now in the process of establishing this modality. So I have no conflict of interest to declare except for the fact that department is in process of establishing microwave ablation modality. So just to put the things in perspective, like nowadays, wherever you go, whichever thyroid meeting, so you always hear this word thyroid nodule ablation, and it is kind of becoming a buzzword. But if we are starting any facility, let's first reflect on the basics. So as we all know that thyroid nodule is a very common problem. In fact, we could have incidence or prevalence as high as 70% depending on the age, sex, geographical area, iodine nutrition, and imaging modality by which it is being detected. I'm sure that if we put probe on our neck, at least the people who are in my age range, 50% of us would be having thyroid nodule. So that may not be clinically evident, but it still is a thyroid nodule. But the good news is that majority of these we all know are asymptomatic and majority are benign. And as has been the age-old teaching, the majority of these nodules do not warrant any treatment. And observation has been the time-tested modality, so much so that we are now offering observation to papillary microthyroid carcinoma, which are being put on surveillance. Thanks to Dr. Miyauchi for that. That world is now adopting that technique. And whenever the nodule is asymptomatic, then the standard of care has been hemithyroidectomy. Maybe previously it was open. Now I don't know whether you could call that a standard of care is endoscopic or robotic. I'm still not sure about that. However, of late, as we are seeing, there is emergence of various thermal ablation techniques. The oldest of these had been ethanol injection that we also had been hearing since our residency days. And that was quickly followed by radiofrequency ablations, laser ablation, high intensity focus ultrasound, and last but not the least, microwave ablation, about which we are going to talk today. So since these modalities have been there for last couple of decades, but it is still important to remember that there is no consensus or set guidelines about these techniques, and the consensus is still evolving. So I would just briefly touch upon the topic. So here is the consensus statement by ATA, American Thyroid Association, which has been endorsed by other societies as well. So what they say is that if there is a symptomatic nodule and patient is desirous of treatment, if it is cystic, then maybe ethanol injection is the modality of choice. And if it is mixed, then we could consider any of the thermal ablation technique. And the criteria, what they say is, I would start with absolute contraindication if the nodule is indeterminate on cytology, and if it is positive on molecular testing, then it is big no. Any malignancy more than 1.5 centimeter, again, no. Then if it is symptomatic, benign, low or intermediate risk on ultrasound, and patient understand what are the implication, then yes, in between there would be relative contraindication and the consensus is still evolving. Then there is one guideline, and that is from European Thyroid Association. So it is more or less same. I have just highlighted they have given 17 recommendation, but just focus on the recommendation 12 and 15, 16, 17. They usually don't recommend HIFU because of the costs and low efficacy. And for AFTN, autonomously functioning thyroid nodule also, because there are two concerns, not only volume reduction, but functionality as well. And there is only 70% chance that a patient would become euthyroid. So, and they have given a comparison. And since the microwave is not much used in Europe, so they have not given any kind of concurrent or consolidated statement about that. So I would just summarize that whenever this thing we are using this facility, or for that matter, any new modality or technique we are proposing to establish, so we have to be very clear about indication, patient selection, and since it is still not a standard of care, if a patient is desirous of any ablation technique, then there has to be shared decision making. The patient should be very much understanding what are the implications, what to expect, and what are the side effects and costs, of course. And there has to be defined goal, whether the goal is to size reduction, disappearance, or achieving euthyroidism. And that goal could change with or evolve with time. And needless to say that we need proper training regarding how to set up this facility, how to perform procedure, peri-procedural care, follow-up, and at the last, though among us, Dr. Sanjay and Dr. Siddharth had considerable experience, Sanjay has also published about his experience. So we hope as a society, we would be compiling this data and publishing in future, and we would be coming up with own Indian Association of Endocrine Surgery Society guidelines. So with that, I would set the ball rolling, and one by one, our team would be touching upon these aspects, and that would be followed by expert video demonstration by Dr. Sanjay and Dr. Siddharth. Thereafter, we have set up stalls in the foyer area, and the participants could enroll at that stall, and in group of 10, they could have hands-on experience as well. So thank you very much, and over to Dr. Madhu, because needless to say that all these are targeted image-guided procedure. So first, we have to be very clear about ultrasonography, anatomy of the thyroid. So over to you, Dr. Madhu.
Thank you, ma'am. Good afternoon, everyone. I'll take on thyroid ultrasonography. I'll discuss ultrasound technique, normal thyroid structure, pre and post-operative ultrasonographic consideration. So surgeons should know basic understanding of ultrasonography. So why? Because this is a statement of an American Thyroid Association statement 2022, and it is said that ideally the operators should always perform their own ultrasonographic examination to assess nodule characteristics and confirm
procedural candidacy as well as the absence of other lesions that may necessitate surgery rather than ablation. So this is the characteristics of ultrasonography, high resolution, real time, and images will be shown in a shades of gray and a high frequency. And we use in neck ultrasonography linear array transducers. And so what is linear array transducer? Actually, there are three transducers: linear array, curvilinear array, and phased array transducers. In ultrasound of a thyroid gland, we are using the linear array. So linear array is actually the piezoelectric substance arranged in a straight line, and sequential firing results in uniform beam density that provide rectangular field of view with precision, with high precision on silo imaging. So how to hold the probe? For a surgeon, it is very necessary to hold the probe properly. In transverse view, if we want to keep the probe transversely over the neck, we have to hold like one of our alumni, Dr. Sanjay sir, has provided these images just only yesterday. And I would like to thank him for this contribution. So he is holding the probe. This is the shaft of probe, and holding the way thumb is on the anterior surface while index finger, middle, and ring finger on the posterior aspect of the shaft of probe. And little finger should touch the neck surface. So, and wrist should be in neutral position to provide tremor-free and long, consistent, continuous, consistent images on the of ultrasonography. And also, he keep one side of this probe free for the intervention. If we want to keep the probe longitudinally, then we have to hold on the lesser dimension of the probe shaft with thumb and index and middle finger on opposite side, and we have to hold so that so that the palmar aspect of our hand should touch the neck. So these are the normal parameters of thyroid gland. And this is the normal structure that we will see in the image of ultrasonography. And this is the gray images of the normal neck ultrasonography. This image taken by the linear array transducer. And these are the skin and subcutaneous structure. This hypoechoic ellipsoid structure is the strap muscles. Anteriorly, this one is the sternohyoid, and this is the sternothyroid muscle. There is one more hypoechoic triangular structure. This is the sternocleidomastoid muscle. And then on either side, and this is the carotid artery, common carotid artery, and somewhere here is the internal jugular vein. This is the butterfly shape, smooth with consistent texture. This is the thyroid gland with a well-defined anterior border as well as posterior border. And this is the part, this part is the isthmus, and on either side, this is the thyroid lobe, right lobe, and this is the left lobe. And posteriorly, we can appreciate this is the anterior surface of prevertebral muscles, longus colli and all posteriorly. And on the left side, we can appreciate this is the esophagus on the posterior aspect of the left lobe of thyroid gland. And detailed structure we will see later on. So ultrasound evaluation and consideration adopted by multidisciplinary consensus statement 2022, and preoperative postoperative ultrasonography is required for nodule dimension and volume to compare with subsequent follow-up examination. So we have to calculate the volume of the thyroid lobe, and that can be calculated by ellipsoid formula with a correction factor of 0.52 for each lobe, and normal value of thyroid lobe volume as 18.6 plus minus 4.5 ml. In 3D, which is a modern and advanced ultrasonographic technology, where all the three dimensions simultaneously taken and a volume can be derived automatically. Another considerations, the proportion of solid and cystic component that will determine the optimal ablation technique. This flow chart is taken from an American Thyroid Association statement 2023 that already explained by Anjali ma'am, but I'm just going in short. If there is an ultrasonography, if we found pure cyst that can be aspirated, cystic fluid can be aspirated, and technique will be ethanol ablation. While if it is a complex cyst, then predominantly solid, then we'll go for thermal ablation. However, if it is predominantly cystic, then we'll go for first aspirate the cystic fluid and then ethanol ablation either alone or in combination with the thermal ablation of solid part followed by ethanol ablation. Another consideration is vascularity that also determines the technique, ablative technique, either microwave ablation or radiofrequency ablation. So as we all know, the color Doppler that determines the vascularity of the thyroid gland and mean diameter of normal thyroid gland vascularity is 1 to 2 millimeter arteries, while if 8 millimeter up to 8 millimeter veins considered as normal. But in case of hypervascular nodule with a prominent feeding artery, or a marginal venous ablation that having enlarged or tortuous draining veins, in that condition, we will go for artery first ablation technique to avoid heat sink effect and also to reduce bleeding and improve the effectiveness of the procedure. Last but most important ultrasonographic consideration for us, for like surgeon like us, are the anatomic important posteriorly placed anatomic landmarks like the danger triangle and all that we will see in this image. We all know these structures. This is the anterior jugular vein, and we should avoid puncturing of these vessels while we are inserting the probe or giving during the local anesthesia. This is the sternocleidomastoid. This is a sternocleidomastoid muscle, strap muscles. This is a butterfly shape hyperechoic thyroid gland. And now we'll see from lateral to the medial side. Somewhere here is this is the internal jugular vein. This is common carotid artery, which is in close proximity with the posterolateral aspect of the thyroid lobe on either side. And posteriorly, this is the prevertebral fascia, and on the left side, this is the prevertebral fascia, longus colli muscle, one of the prevertebral muscles. One important thing to consider here and to know is the danger triangle. Danger triangle is not actually a discrete finding in ultrasonography. However, this is the conceptual area, and in between, this is the conceptual area, the area where we would expect a recurrent laryngeal nerve, and boundary would be the medially trachea and posterior medial aspect of thyroid lobe, and posteriorly this is the esophagus and wall of the esophagus. So we have to be careful during ablation of any nodule which is in close proximity with this danger triangle. On this boundary in the left side. However, in the right side, this conceptual area is actually in between posterior medial aspect of right thyroid lobe and prevertebral fascia and medially in the trachea. This area is actually the conceptual danger triangle where we would expect right recurrent laryngeal nerve. Thank you. Now I would like to invite
Thank you, Dr. Madhu. It was a wonderful presentation.
Thank you, sir.
Especially for us surgeons. Have you ever thought of microvascular Doppler in these lesions, and does it help us, the surgeons, to intervene?
Sir, actually, microablation is more resistant with the heat sink effect. So, in case of microvascularity, if it is high, so if already we are doing a microwave ablation, this is the best modality for ablation in case of hypervascular gland. But if we are doing a RFA, in that situation, we would like to go for first for the artery, and will do the radio frequency ablation near the arterial vessels, and followed by the rest of the structure of the nodule.
Thank you.
Thank you, sir.
Thank you, Dr. Madhu. I think that was a very good presentation.
Thank you, sir.
Very well explained. Thank you. So we can have the next speaker, Dr. Spandana. She'll be speaking on indication of MWA in thyroid and case selection.
Thank you, sir. So I'll be briefly talking about the indications of microwave ablation in thyroid nodules and how to properly select cases. The use of minimally invasive ablation techniques is expanding, but the use of minimally invasive ablative techniques is expanding, but the real challenge is in identifying the right patient for these procedures. I shall try to answer these questions. The question of the ideal candidate for microwave ablation amongst benign, indeterminate, and in malignant thyroid nodules. This talk will integrate recommendations from major societies like the European Thyroid Association, International Multidisciplinary Consensus Statement, and the American Thyroid Association. Coming firstly to benign thyroid nodule. For benign nodules, ablation should be limited to symptomatic lesions, those causing compressive symptoms or cosmetic concerns. The essential prerequisite is that there should be a firm diagnosis of benignity. This is usually established with ultrasound and FNAC. Ultrasound features of very low or low suspicion or intermediate suspicion of malignancy are good candidates. However, pure or predominantly cystic nodules are not ideal for microwave ablation because they respond better to either aspiration or ethanol injection rather than thermal ablation. Most guidelines also recommend 2 benign cytology reports to reduce the risk of inadvertently treating a malignant lesion. However, nodules having very low sonographic suspicion of malignancy like ACR TIRADS 1, 2, 3, and in autonomous functioning thyroid nodules, again with low suspicion of malignancy, can have a single biopsy or a cytology report to undergo microwave ablation. The size of the nodule is also important, but however, there is no maximum size or the size threshold that has been established because the size threshold would depend on where exactly the nodule is situated within the thyroid, the BMI of the patient, and the neck circumference. However, it should be noted that the bigger the nodules, especially nodules more than 20 to 30 ml, would often require either stage procedures or repeated sessions for adequate response. In multinodular goiter, ablation is generally limited to ablating a dominant nodule in patients who are otherwise unfit for surgery. Again, they would require stage procedures, and very large goiters which are causing tracheal compression or are retrosternal are unsuitable. For autonomously functioning nodules, the ideal candidates are those with volumes less than 10 to 20 milliliters. Graves' disease and toxic MNG remain unsuitable, and medical or surgical therapy is preferable in these cases. So microwave ablation for benign thyroid nodules should be used to treat symptomatic nodules after proving that they are benign, and usually we need to avoid cyst or cyst predominant lesions. Moving on to indeterminate thyroid nodules, thermal ablation is not recommended for cytologically indeterminate nodules due to lack of histological confirmation. The concern is that ablation does not prevent progression or the metastatic spread in these malignancies, which are misclassified as indeterminate. Surgical excision remains a standard management in this category of thyroid nodules. However, after thorough discussion of the risks and the benefit of both surgery and microwave ablation, some patients who are unfit for surgery may still be offered microwave ablation. Moving on to malignant thyroid nodules, the role of ablation in treating primary thyroid carcinoma is limited and it still remains under investigation. After thorough discussion of the risks and the benefit of both surgery and microwave ablation, some patients may still opt for microwave ablation to prevent the potential complications of surgery. And favorable candidates are those who have either unifocal or intrathyroidal papillary microcarcinoma, PTC with classical histology, cytology, no evidence of metastatic lymphadenopathy, and patients who are either high risk, ineligible, or who decline surgery. In recurrent papillary thyroid carcinoma, ablation has a recognized role. With curative intent, it can be considered for lesions less than 3 in number, confined to the neck, each measuring less than 1.5 to 2 centimeter in size. And larger or multiple recurrences may be approached with palliative intent, which is aimed at local disease control and symptom relief, thereby reducing the morbidity associated with having to do a repeat surgery. However, pre-ablation evaluation is mandatory and it should include confirmation of malignancy, either by a fine needle aspiration cytology or by doing core-needle biopsy. Anatomical imaging is necessary in the form of neck ultrasound, axial imaging, and functional imaging if needed. Biochemical evaluation in the form of TSH, TG, and ATG are also required. So surgical excision remains the standard management for malignant thyroid nodules. However, it should be the microwave ablation should be reserved for low risk papillary thyroid carcinomas, recurrent thyroid cancers, and for palliation. Pre-procedure evaluation includes benign thyroid function and baseline thyroid function and ultrasound evaluation. Laryngeal assessment is not mandatory for all cases. However, it is indicated if the patient has abnormal voice, a prior thyroid or neck surgery, or we are planning a contralateral ablation after having done an ipsilateral ablation. Flexible laryngoscopy or ultrasound of the laryngeal apparatus are the recommended modalities. The European Thyroid Association also endorses that calcitonin should be considered along with TSH in biochemical evaluation of all thyroid nodules. However, no other societies endorse the same. As with any surgical procedure, patient suitability for ablation must be established. An inquiry on the medical condition, their comorbidity, the medication that they're taking also need to be noted. Most procedures are performed under local anesthesia. However, some factors might require deep sedation, including extreme anxiety, chronic opiate dependence, fibromyalgia, cognitive disabilities, and patients who have shown prior poor tolerance to procedures like fine needle aspiration. Peri-procedural anticoagulant management is also very important, as this minimizes the risk of hemorrhagic complications without compromising cardiovascular protection. Antiplatelets like aspirin and clopidogrel need to be stopped 7 to 10 days prior to procedure. Warfarin should be stopped 5 days prior to procedure. And direct oral coagulants need to be stopped 24 to 36 hours. And all of them can be safely resumed 24 hours after completing the procedure. Obtaining an informed consent is of paramount importance before performing microwave ablation. And it should be ensured that patients understand the procedure, the benefits, risks, and alternatives. They also need to be made aware of the necessary compliance that would be required during the procedure, the expected decrease in nodule size after the procedure, the possible regrowth over time, the need for multiple sittings or surgery after this, and the need of long-term follow-up. Shown here is a sample informed consent that was published by the International Multidisciplinary Consensus Statement, detailing all the things that we have just discussed. On the left, we have a pre-procedural checklist published by the same society. And on the right is an ablation safety checklist that was published by the American Thyroid Association. It is to emphasize that prior to taking any patient for these ablative procedures, one needs to make sure that we have properly selected these patients. We have proved that they are benign, and we have taken informed consent, done the necessary investigations, and the patient understands the procedure and the risks associated with it. As Anjali ma'am has already talked about this is a summary of the criteria for microwave ablation of benign thyroid nodules as published in the American Thyroid Association. We've already discussed most of it. And I would like to draw your attention on what is maybe the most important criteria of all, and that is that the patient need to have a clear comprehension and realistic expectation of these ablative procedures, expected outcomes, potential complications, and alternatives. Though pregnancy and the presence of pacemaker or an implantable cardiac defibrillator are considered relative contraindications of other modalities of thermal ablation, microwave ablation is generally considered safe in these patients. Absolute contraindication has already been discussed. To conclude, appropriate case selection is the primary determinant of procedural success, minimizing complications, preventing the undertreatment of malignancy, and optimizing long-term outcomes in thyroid ablation. Thank you.
Thank you, Ms. Panna. That was a very good talk. And you nicely summarized almost everything which is required for case selection. So it is very important to understand. And what I want to highlight here is that not only case selection, it is always a shared decision making. And as you rightly said multiple times, that patients should have realistic expectations about what this microwave ablation can achieve. And for majority of people who are doing microwave ablation or have published, that is more than 50% reduction in volume is considered as success of microwave ablation procedure. So patients should know that there will be, if we achieve a 50% volume reduction, so as a operating surgeon, for me, it is successful procedure, but for patient, it may not be so. So they should understand that. Thank you.
Thank you, sir.
So next, Dr. Renel, she will be speaking on operative technique and steps of procedure.
Thank you, sir. So I'll be taking the operative technique and the procedure. So what do we need when we decide that there is a patient for microwave ablation? First of all, we need a patient. And this patient needs to be correctly selected, as Dr. Spandana has already mentioned. We also need a doctor. In our case, it would be an endocrine surgeon. We need an ultrasound machine, cold saline for the hydrodissection part, and obviously a microwave ablation machine with a flexible cable. So this is the equipment that we have procured here at SGPGI. This is the microwave ablation generator and the antenna. Usually it is a 16 to 17 gauge needle. And the active portion of the antenna is about only 3 to 5 mm. The length of this needle is about 10 centimeters, and the power used is usually 30 to 50 watts. The mechanism is that it creates heat via production of an electromagnetic field. And it also has the advantages of homogeneously ablating the treatment zone, unlike RFA, and it also produces lesser microbubbles. And the duration of time is also shorter, which is only amounts to about 20 minutes to half an hour per nodule. So the procedure starts with, you can either take the patient under local anesthesia, conscious sedation, or general anesthesia. The patient is placed supine with the neck extended like any thyroid procedure. And the surgeon is in fact on the anesthetist end at the head end. The needle is inserted via the trans-isthmic approach, and the technique used is the moving shot technique, which I will be explaining later. So what are our steps? Step one is that we need to know our anatomy. And like Dr. Madhu has already mentioned in her presentation, that we need to know about the danger triangle, which houses the recurrent laryngeal nerve. The other important structures that can also be damaged during microwave ablation is the trachea, the esophagus, and the carotid artery. Step 2 is that we need to give the patient local anesthesia. We can use a 22 gauge needle or the normal needle that comes with a 10 ml syringe. We mark a 2 mm skin incision and we use the ultrasound probe in the short axis. This, I'm sure Dr. Sanjay Kumar sir and Dr. Siddharth will be explaining in their video demonstrations. So this is also an important step when prior to microwave ablation. It is called hydrodissection. We use cold saline with lignocaine, around 30 to 40 ml is used. And this creates somewhat of a liquid isolating region between the nodule and the critical structures. So it could be between the nodule and the recurrent laryngeal nerve, the nodule and the trachea, with the carotid artery and the esophagus. So our step 4 is the moving shot technique. So what is this technique? What is usually done is the antenna is inserted into the thyroid nodule at its most farthest part. As you can see in the image, number 1 is ablated first, which is further from the treating surgeon. And then each ablation unit is ablated, and then we pull the antenna backwards. And then we take it from medial to lateral, and then we take it laterally and continue doing the same thing. So this is called the moving shot technique. And in this way, we can ensure that the entire nodule is ablated. This is a small video showing how the thyroid nodules are ablated. First, we numb the area with local anesthesia. The ultrasound is placed in the short axis, and this is the moving shot technique where we take it from farthest to closest to the operating surgeon, and the nodule is ablated and at different levels. So first we can start with inferiorly and then go superiorly. Then you take the ultrasound probe and you keep it in the long axis so we can see how much of the nodule we've ablated in which plane. So if you start off inferiorly, then you can go into the middle and then you can go on to do it superiorly. So if we have a predominantly cystic lesion, in a solid cystic lesion, we try to aspirate as much fluid of the cystic component. And it takes about 5 to 10 seconds for each conceptual ablation unit. We try to see the hyperechoic texture on the ultrasound, and that's when we know that the procedure is complete. We do have to stop if the patient is under local anesthesia and they do develop voice change. So we continue to talk to the patient during the procedure, or if symptoms of Horner syndrome develops. We did our first microwave ablation session at SGPGI yesterday, courtesy Dr. Sanjay Kumar Yadav sir, who is also our alumni. We had 2 cases. We had ablated a benign thyroid nodule as well as a fibroadenoma of the breast. Step 5 is the post-procedural care, which will be covered by my colleague, Dr. Dibya. So with that, I would like to conclude this presentation. Thank you.
Thank you, Renel, for this wonderful presentation.
Thank you, sir.
Do you have any questions from the floor? Okay, we can take it later after the video presentation. So I call on the next speaker, who is Dr. Dibya Priyadarshini Bahera. She will be presenting on peri-procedural care. Over to you, Dr. Dibya.
Thank you, sir. So I'll take forward in the continuation of the previous presentations. I'm dealing with the last part of microwave ablation, which is peri-procedural care. In these will mainly I'll be dealing with post-procedural care because briefly it has been discussed already, the immediate pre-procedural cares. So the peri-procedural care is defined by ATA consistent statement as to take care of the equipments and technical considerations before starting the procedure, and also techniques to optimize the peri-procedural safety. In post-procedural, which I'll be dealing majorly in my presentations, they have given, we will discuss the criteria for safe discharge post-procedure, immediate short and long-term safety consideration, followed by follow-up safety considerations. So this is an ablation safety checklist for early and late pre-procedural workflow, which is given by ATA in their statement. Here, this is a workflow to make our job easier so that we will not be missing anything immediately before the procedure and post-procedure also. So they have given the checklist for late pre-procedural and early pre-procedural. The early one is the patient selection thing, which has already been discussed by my colleague, Dr. Spandana. For late pre-procedural, we need to check the equipments and technical considerations, which is like we have to check the active tip size if that is appropriate for the thyroid volume. Generator and pump checked, and it should be working. Optimal energy to be delivered to nodule calculated based on the nodule volume. Starting power chosen based on the active tip size. We need to check all this if these are been checked before starting the procedure. Cold saline should be available. Anxiety medication taken by the patient if the patient is more anxious. So we need to keep that thing in mind before starting the procedure. The next thing is patient and ablation approach consideration. Here, as like other surgical procedure, we need to make sure that the consent is being signed by the patient and the relatives. The nodule ablation location confirmed with the patient, as we do in our before the surgery. Patient recounseling regarding the normal versus abnormal expectations that has already been emphasized repeatedly, that the patient should be told about the realistic expectation from the procedure. All disposable equipments which are available should be available near the procedure site. Patient should be positioned appropriately, as has already been discussed by my colleague. There should the ultrasound, we should be very sure with our ultrasound finding that we should mark the danger zones which is around the nodules. And entry angle of technique applicator to skin determined based on the nodule size or location in thyroid anterior neck veins identified on the ultrasound. Coming to the post-procedure care, which I'll be dealing mainly, we have some criteria to safely discharge the patient after surgery. So this is a post-procedural checklist, which is given by multidisciplinary consensus of American Head and Neck Society, Asian Pacific Thyroid Society, BATES, and Korean Thyroid Society. So we'll be dealing this one by one. First, we'll be dealing with the general medical assessment, which is we have to observe the patient for 30 to 60 minutes following the procedure. We have to check the vital signs prior to the discharge, and we have to also see if the patient is having any respiratory distress or stridor, or to check if we were working nearly recurrent laryngeal nerve. Followed by that, we have to do a voice assessment of the patient, in which we can talk to the patient to see the nature of the voice, or we can ask the patient to swallow some liquids. Then if there is any suspicious for nerve injury, the patient will have some cough. In that case, laryngeal examination is warranted. However, it is not mandatory for every cases. So a transnasal laryngoscopy is gold standard, or also we can perform laryngeal ultrasound. The next thing is to do an ultrasound assessment before discharging the patient to see the area of ablation. This is how this is how ablative area will look post procedure. There will be hypoechoic zones with a spot of hypoechogenicity inside the nodule. Also, we can use color Doppler to detect the remnant vascularity inside the nodule. If the nodule is ablated, there will be less vascularity, which can be detected in color Doppler. Ultrasound also can help us identifying hematoma formation if at all that occurred after the procedure. The next thing, which is to to look for any additional neural integrity, which is very rare, though very rare in the procedure, like spinal accessory nerve injury, brachial plexus injury, or sympathetic chain injury. The next thing, most important, is before discharging the patient, we have to tell the patient about the warning signs, and if they are present, they need to return to our center immediately, or to contact us if any of these are present, like severe or worsening pain, voice change, new or worsening dysphagia post-procedure, cervical edema or erythema, shortness of breath, or fever. And if any of these are present, the patient needs to instruct that patient needs to contact or come back to the hospital or clinic immediately. We have to instruct the patient that they should avoid submerging the access site for submerging in the water for the next 24 hours, and also to avoid pressure and trauma if at all. The puncture site should be checked before discharge to access for hematoma or bruising, as I have already told. Routine use of antibiotics is not required in every cases if at all there is no complications. Next thing is the immediate safety consideration, which lasts up to 72 hours post-procedure. In duration of these times, the most common symptoms the patient presents is pain and soreness of the neck, which usually occurs in first week and most commonly in 3 to 5 days. The reason being the swelling of the surrounding tissue because of the thermal injury. And the treatment is conservative management with application of the ice pack and analgesia. Mostly anti-inflammatories like ibuprofen or paracetamol would also suffice. The next thing we should be worried about during this period of time is suspicious of RLN injury, where the patient can present with voice change. And initially, we can manage the patients conservatively because most of them are mostly neuropraxia. And we have to counsel the patient that after some duration of time that this might go. And also we can use steroid to prevent inflammations and to improve the voice outcome. Injury to the trachea and esophagus is very a rare complication of the procedure. However, if at all they are present, the patient can have subcutaneous emphysema and neck infection. The next thing is the short-term safety consideration, which lasts from 3 days post-procedure to 1 month. Though the benefit of ablations are not immediate during this period of time, we can do an ultrasound to check if there is a decrease in the size. During this period of time, the patient will tell there would be a significant improvement in the symptom of the patient. And also we can access the volume reduction, but that will not be that significant during this period of time, which I'll be discussing later in the long-term follow-up, how to calculate the volume reduction. In case of autonomous functioning thyroid nodule, transient hyperthyroid symptoms can occur in patients, which settles in 2 to 4 weeks, and they rarely require antithyroid medications. However, if the patient is already on antithyroid drugs, they can be advised to continue for at least 3 to 4 weeks post-procedure. The another reason why the patients can have transient hyperthyroid is because of thyroiditis due to thermal injury to the thyroid, and those symptoms can be well taken care of by using beta blockers in these patients. Another uncommon but significant complication during this period of time is nodule rupture. It can occur because of delayed bleeding or liquefating necrosis as a result of microwave ablations. The patient will present with sudden painful neck swelling at almost 2 weeks post-procedure to 3 months. They can be managed initially conservatively if the patient is not having any compressive symptoms. If the patient is having compressive symptoms or there is no decrease in the size, we can do an aspiration IND or real surgical resection or required. This long-term safety consideration, which will occur after 1 month, out of that, which is hypothyroidism, which mostly common after 1 year. The nodule regrowth can occur, which is common in between 3 to 5 years, and different studies have given that it's from 5 to 40% in incidence. It's most common in the peripheral areas where we use generally low energy. If the nodule is surrounding any vital structures, so we deliberately use low energy. So in that areas, nodule regrowth can occur. Coming to the follow-up and safety consideration, we have three areas where we have to follow up the patient, like clinical assessment, biochemical assessment, sonographic assessment, which is the objective method to know the volume reduction rate, which is basically preoperative nodule volume minus ablative zone volume into 100 divided by preoperative volume of the nodule. And there are various studies which have told that maximum it is at 12 months. So this is a follow-up flowchart given by the multidisciplinary statement, early, intermediate, and late, as projected in the slides. That each time we have to do a symptom score, nodule volume, cosmetic score. At 3 to 6 months, we have to do a biochemical test and a CT or MRI if required for benign nodules. And similarly with the non-functional nodules and if recurrent thyroid cancer has been done. So lastly, additional ablative sessions are required for those patients who are having large volume, 20 to 30 ml, and if the patient is having regrowth of the nodule, and if the patient is having persistent or new compressive symptoms. Thank you.
So I think our part is over and over to experts now.
Next, I invite Dr. Siddharth Chakravarti, who is an expert and he has been doing these cases for some time now for video demonstration of cases. Dr. Siddharth.
At the outset, I would like to thank the SCPJ for inviting me and giving me this opportunity. I'm not an expert. I'm still learning this procedure. So I have nothing to disclose. So this is the outline of my talk, introduction, then video, ethanol ablation, video of hydrodissection, then I'll show the video of a microwave ablation for benign, and then for a micropapillary thyroid carcinoma. So this is, I would say, clinician performed ultrasound is essential for every patient. If you don't have one, invest in it. It is the single most important tool to master non-surgical endocrine intervention. Yeah, I bought my ultrasound machine the moment I moved into the practice. And even when I was doing my post-graduation, I was always used to carry the ultrasound bag with me and go in the rounds and do the ultrasound for every patient. So ultrasound is must. You should be thorough with ultrasound and ultrasound guided FNAC. You should be able to do on a 3 to 5 millimeter nodule, and then you are ready for this procedure, not before that. First, I went to Turkey. Me and Barwa and Om Prakash, we went. I was there for a week. But somehow there were some doubts in my mind whether we can actually move forward. Then I went to this China-Japan Friendship Hospital. Dr. Yu, he's the man, and yeah, my favorite is Dr. V. Excellent. The way she even burns every single cell of the tumor, I would say. Excellent interventional radiologist. So I have done 62 patients, benign, and 3 micro PTC. So it's a 5 centimeter cystic lesion, the same after a month of ethanol ablation, what would have been a conventional thyroid surgery. And now after 6 months, you hardly see anything there. It's another patient, Y, who had a cyst here. You can see around 5 to 6 centimeter cyst. Ethanol ablation is essential to learn because most of these patients whom we are going to ablate, benign nodules, will have some part of cystic component in it. So थोड़ा देखिए भैया. So this ethanol ablation is essential, and after doing the ethanol ablation, first we can wait for at least 2 to 3 months. Then you will see the ethanol has acted very well, and the size of the volume will decrease by more than 50%. And then you only have the solid component which is left behind. Say a 4 centimeter nodule will become a 2 centimeter nodule, and then you can easily go and ablate it thoroughly. So you can avoid multiple sessions like that. Not this. Open name. अरे भाई. अच्छा. So I tried it. I don't have. So that's right. Yeah, I can take it from here. I hope you can. Can you show this? Yeah. So when you're giving a local anesthesia, so you can just see this is the thyroid capsule. So we just infiltrate over that thyroid capsule. And then you should decide where exactly you're going to puncture, because that is the only puncture that you can do. Don't do multiple punctures when you're doing this ethanol ablation. So now we have decided, we gave the local anesthesia. After giving the local anesthesia, the thing that we do is we aspirate the lesions. So we use a stimuplex needle, which is more, which is nightly seen on the ultrasound. And when we inject this, we also use the color Doppler to see that we are not going through any vessels. So it helps us that, okay, you are safe. And once you go inside, you have to aspirate it fully dry. So most of the times it will come very easy, very difficult to aspirate because the colloid is very thick. Here in this patient, rather the only patient whom it came out very easily, we aspirated around 50 cc of clear fluid. But most of the times it will be the colloid which is very thick. So you have to inject some saline, aspirate, inject saline, aspirate. So after we aspirate it dry, what we do is we inject some local anesthesia into it, around 5 to 10 cc of local anesthesia into the cyst wall. So the entire cyst wall is nicely anesthetized. After that, what we do is we wash with saline. We take normal saline and we wash. Don't use cold saline. When you use cold saline, it is irritating sometimes to the patient. So saline with room temperature. So we have aspirated it dry. Yeah, this is how the normal colloid looks, very thick and very difficult to inject. Then after this, what we do is we inject the ethanol. We use 95 to 99% ethanol. Yeah, when you inject the ethanol, you can see that hyperlucency, the bubbles that are coming. So that's the protein starts denaturing when you inject it. And after you inject, how much to inject ethanol? If you have aspirated, say 30 ml, you can inject up to 1/3 to half. So if 30 ml, you can inject up to 10 to 13, 14 ml, not more than that. So if you inject more, sometimes this ethanol can extravasate and it causes severe pain. So after you inject, you wait for at least 3 minutes. Wait for 3 minutes and then you aspirate, inject saline and do the same procedure for 3 times. So 3 times we inject the ethanol and then you're done. So everything happens with the single prick. So only one prick we do. And when I started, I mean, we had a learning curve. The colloid was very thick. I was trying the big needle and then the small needle. Then I realized that the ethanol extravasates from where you put it. So it causes severe pain. So you can't do that. So only one prick, everything is done. Planning is essential. So now we go to the next important topic, hydrodissection. How I learned my hydrodissection. Every patient after a surgery, when we intubate, I do hydrodissection on the patient. And I realized that it makes my surgery also very easy. When I hydrodissect near the trachea and the berries is nicely mobilized, the surgery was becoming easy. So separating the trachea, very important point. So this is a papillary thyroid carcinoma. And you can see our needle, and this is the trachea. There's the anterior part of the trachea and the posterior part. So you just have to be on the trachea, bang on the trachea, and then give this. When you do the hydrodissection, you see at least 5 to 6 millimeters, there's a separation. Only then when you get that distance, then you are confident that you go to the back of the nodule and then you can burn it. If you don't, it will be very difficult. May aap change kar rahe hain wahan se? And even when we are ablating, we don't take out this needle. The needle will always be there. When I put the microwave antenna inside, my assistant will be injecting saline simultaneously. So when I start burning it, my assistant will have this, and I'll show you it in that video. So when you do this, And this is what I learned in China. Then only you can say, okay, I have killed the tumor thoroughly. Now separating the esophagus, another important point. So that's the thyroid, that's again the trachea. So that's the needle which is coming, and you can see the esophagus here. So that's the esophagus and the nerve. This is the danger triangle where we have. But you need adequate space, at least 0.5 centimeter to 1 centimeter. So when we go enter in the right plane and inject the saline, can you see how the esophagus separates there? So we come down and we push the esophagus separately. So you get that extra 0.5 centimeter to 1 centimeter. So I can put my microwave probe confidently, go down till the posterior aspect and burn it without injuring. And when I'm burning that critical point, I keep asking the patient, please, how are you doing? What's happening? Are you comfortable? And I keep listening to the voice. So this is very important. So the other important point is separating the carotid artery. So you all can see the carotid artery and the IJV. Again, you have to switch on the color Doppler because you never know. You don't want to go into the the middle, the veins, and then the bleeding will start. So now when I'm sure, okay, I will do. See the carotid, how close it is to the thyroid gland. It's sitting on the gland. And now you can see it's being separated. So that's the right plane. And the esophagus also goes back. So you can see the distance, how much we are creating. And this needle, we are not going to take it out. The needle will be there all throughout when I'm ablating, and I must sew the needle. I'll be checking for the needle as I'm ablating, and I ask my assistant, hey man, please inject the saline. So if you see in this image after the ablation, so these are my needle. You can see one poke here, that is in the back of the nodule. There is one poke here, there is one poke here, and one poke here. So we have to take it in a zone. Systematically, you have to burn. When you burn it systematically, and you can see there is no vascularity inside the nodule. Whatever is there is dead. It was around 4 centimeter nodule, which has come to around 1.5 to 2 centimeters now. So this is a case of a micropapillary thyroid carcinoma. That's not opening. Yeah, again, this is the tumor. You can see a very small 7 millimeters FNAC proven papillary thyroid carcinoma. So that's the trachea. And I'm looking actually for my needle. So this is the needle which is in the back. You can see the space which is being created as I'm burning. So my assistant is injecting saline there, and as I burn the entire nodule. When I burn this entire nodule, I am checking whether, see, I was looking, oh, is that needle there in position? So that's very important. Otherwise, you're going to injure the recurrent laryngeal nerve. And for carcinomas, we go at least 2 to 5 millimeters beyond the hypoechoic area. Yeah, I'm not sure. I think the benign thing is missing in this presentation somehow. Colloid nodule, yeah. So this is the last video. This is a benign nodule. So you can see that there's some echo area. What you can see here, that is the saline which is being injected by our assistant. And we go almost till the bottom of the nodule and we burn it. That's the needle, the probe. So we go almost till the posterior aspect and start burning, layer by layer, layer by layer. If it's a large nodule, 4 centimeters, it takes almost 40 minutes, 30 to 40 minutes to burn the entire nodule. So that's how we burn almost till the end of the nodule. If you're too close here, here I have a thyroid as a buffer. If there is no thyroid there as a buffer, here we have to inject some saline. Put a needle there and inject saline, otherwise you'll have a superficial burn there. So again, you can see this carotid is pushed almost, you have that extra buffer there. That's why I can go down till the bottom of the nodule. Otherwise, this is not possible. If you don't separate the carotid, you won't get that extra buffer and you go down till the bottom of the nodule. So only then can you burn it properly. If you go, good hydrodissection is the key. Hydrodissection, and you should be able to do an ultrasound guided FNAC. So, yeah, so she had a 7 into 5 centimeter large colloid nodule. Initially, we did a ethanol ablation for that. And then 6 months post microwave ablation, you can see the nodule has come down. And 1 year post ablation, the nodule is still there. As Dr. Sanjay was saying, I mean, the nodule may not disappear, it will come down in size. But when I look at the vascularity, there is some vascularity, and you can see there is some hypoechoic. Though physically, yeah, the nodule has come down. So she is the right patient for reablation. So we are planning to reablate this, and I'm sure this will not grow back again. But you may have a residual 1 to 2 centimeters of the lesion. Sorry for this thing. Yeah, I don't know. My slide has. This is the papillary microcarcinoma which we had ablated. So this was the tumor, and 1 year post microwave ablation, you won't see the tumor at all. So microwave ablation for small microcancers is extremely good. And that's only the scar tissue with no vascularity in that tumor. So any complications that we can expect? Yeah, this child around 14 years had a small colloid nodule. We ablated, and after 4-5 days, you see there's a skin burn here. That was probably, I'm also not sure, maybe it was too superficial and a kid. But yeah, it settled. Within 2 months, the nodule disappeared. On the externally, there is no nodule. Even the nodule size has come down by almost 50%. To conclude, microwave ablation definitely has a role, and every endocrine surgeon must learn microwave ablation. And before you actually move into invest in the ultrasound machine and master ultrasound and ultrasound guided FNAC, hydrodissection, and then you can safely go on to microwave ablation. Thank you. Any questions?
Okay, we will have one question. Yatra.
If it's okay, I'll ask two. Okay.
Okay, go ahead.
So my first question would be about imaging-based surveillance that you're doing later on. What would be the worrisome features that you would see post-microwave ablation in both benign and PTC patients? That would be the first question. And the second question would be about ethanol ablation. Are there any long-term studies talking about malignancies in the future for ethanol ablation in patients who've had prior ethanol ablation for benign lesions?
So I answer the second question, the ethanol one first. Yeah, so patient selection is very important. As I said, yeah, when you are worried, is it a cystic papillary thyroid carcinoma that I am missing out on? So again, as I said, the ultrasound is essential. In a cystic papillary carcinoma, you have a solid component which usually is hypoechoic. We'll have a small stalk with a budding like a tree type, what do you call that? Papillary projection kind of a thing, and you have an intranodular vascularity. Whereas a benign cyst, you either be a pure cyst or it will have a flat based and obtuse angle solid component. it might have vascularity, but it will usually be isoechoic. So selection of the nodule is important. If you have a doubt, if you're not sure, you must do at least 2 fine needle aspiration cytology. Ethanol ablation is definitely a proven procedure and it stands good. Again, the patient selection is very important. And regarding the first question, what was it? It's on the benign. Worrisome features. Worrisome feature would be, I mean, is the nodule increasing in size? That's the major thing which I'm worried about. And in my initial cases, what I have seen, I was also a bit conservative. I was not going posteriorly, worried about, not sure how much I'm going to burn. So when I see my patients in the follow-up, I am seeing there's a sliver of tissue in the posterior aspect, which nicely, brightly lights up. The anterior part is hypoechoic. And the second thing worrisome about is when these patients go to another radiologist, the radiologists nor the endocrine surgeons, we are aware of how a post-ablative ultrasound nodule looks like. The moment you see that post-ablative nodule, the first thing it strikes you, hey, is it a papillary thyroid carcinoma? So it typically looks like a hypoechoic with irregular margins and those things. You'll be confusing and they call it as thyroid's 5. This has happened. So educating the radiologist is very important. So I have one radiologist whom I initially had the problem. Then I had to tell him, oh, the ablation. Then he look at the vascularity and he'll say it's all fine. So yeah, it's a learning curve. We are also still learning. But with experience, I think we will definitely refine and it will benefit a lot of patients.
Sir, can I ask if there is time? Sir, this is more practical, like for us as youngsters. Regarding, as you said, you used to take your own ultrasound machine and go around. So for us, we get an ultrasound. Any tips and tricks to overcome the colleagues who are, why are you doing, or what are all the other legal aspects we have to be aware of? Can you just brief?
See, we as surgeons or anybody with an MS degree, there is no restriction from the government for not buying an ultrasound. We can buy an ultrasound. Only thing is we should not do, of course, we won't do any gynae work. When I bought my ultrasound machine, the gynecologist wanted to come in and say, pitch in and said, she said, I'll also use it. I'll buy a curvilinear probe. I was scared. I said, no, madam, this I don't have. I'll only use for myself. Because if we are doing the gynae, then you need to maintain a record. And the machine is registered under your name. If they don't maintain, you are responsible for it. So buy your own machine, keep it to yourself, no problem. Of course, your colleagues will always be behind you as endocrine surgeons. Everybody is against us. When I started, people keep complaining about us. But we do the good work. It will definitely come forward. We are trying to do the best for our patients. So I think you will stand ahead and people will come towards you.
And sir, one more question. Just you said that you will be doing hydrodissection, use lignocaine also. So did you encounter any voice change just
Yes,
immediately
that's a good
after
thing.
this?
So we have definitely 3-4 patients. I remember when I give the local we give in the exact same places like I showed the hydrodissection. The hydrodissection we have to give on the trachea. So when you give on the trachea, some amount can spill on the nerve. And when I ask my patients, their voice is changed. But I know I haven't started the ablation and it will go within an hour or two. This has happened. Even after surgery, when we give local anesthesia in the bed, patients will have voice change. And when you come to the ward, you're surprised, hey man, what happened? So that's transient, not to worry about.
Thank you, sir.
Any more questions? Rinal, please.
My first question was, I saw when you were dissecting the plane between the trachea and the carotid, it looked like you were doing a lateral approach rather than transsystemic. So is that
and the
carotid? The
first one. That's the plane. The first video is to elevate the nodule from the trachea. So because that nodule was close to the trachea, so I put a needle, I come anteriorly on the trachea, I see both the rings. You can see the rings, anterior ring, posterior ring, and then you can see the thyroid surface. So here I just go beyond the thyroid and then I start injecting. The planes are exactly like our surgical planes. The precision is exactly like our surgery. And when esophagus, when we are dissecting, so you need two planes to dissect. One, we have to come from this direction, and the other, we have to come from this direction, esophagus being here. So when I put the saline here, the esophagus will be pushed this side. And when I come from the carotid goes laterally and the esophagus also goes laterally. Then this area, if you are clear, the chance of injuring the nerve is very, very less.
For all of us, we had been reading that transsystemic approach is the best one. So the probe needle would come from midline to lateral.
Lateral, yes.
This thing in first video, as she also
No, that was not the microwave probe.
Yeah.
That was just a stimuplex needle for hydrodissection. So that was not the microwave probe. Yeah, this is also, I mean, there is no hard and fast rule that I always do a transsystemic route. It is not possible. If you have this big nodule and you only want to come from here and go here, 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 you're going to do more damage. So in this, you can divide them into two compartments and do two picks. It can be from this side also, not a problem. The Chinese people, they do, it's common sense. So if you want to go from one and you're going this way, that way, you cause more damage. Rather, you plan in your mind and do two pricks, then this half you take first, that half you take first. And again, next we tell you how to, divide so that hyperechoic bubbles make the vision very clear, very blurred. So if you start from this end and you come here, then you're fine. And then you start this end and then you come this side. By then, this would have cleared up. So this is also, I mean, these are all there there are only 3 Chinese textbooks which are available. So I've been during my 2 months fellowship, I had an app. So I read all those books and then we got how to, they have nicely designed it.
Thank you, sir. So my second question is, how much do you charge each patient per that is
Yeah, my hospital is
versus
expensive.
surgery versus surgery?
So my hospital, I always tell the patients, these minimally invasive procedures are more expensive than surgery. And it costs me around 2.5 to 2.7 lakhs when I do a microwave ablation. But yeah, when we have poor patients, we reuse the antenna and we finish them in the same hospital for 90,000 or so. But
I just want to ask, how many patients were satisfied and how many non-satisfied?
Oh, that's a good question. So I would say 95% of my patients are all satisfied. They're very happy. And because 1 year, I only done 65 patients. We don't push any patient for any procedure. We explain them the options and the realistic expectations, and they are very much a part of the decision making, what they are expecting. Some people say, "Arey, doctor sahab, mera nodule pura nahi jayega, thoda reh jayega." So then I would say, yeah, then you go for, then he only will opt, I will go for surgery. But very few patients I had who are like, oh, one more time do I have to ablate? But now I started telling, I mean, I'm also learning. So we keep telling, you have to be realistic, what the patient really wants and what you can provide to them.
And second, why don't you take the help of radiologist, interventional radiologist? Why can't we do it together with the interventional radiologist?
I totally agree with this point.
Actually, legally also, it will be more helpful for anybody.
No, I think coming to the legal aspect, I think you should have a certification and a training, and your hospital should okay that you are certified to do this, and this should be there in your checklist, the list of procedures that you can do. That's one. And I went to my interventional radiologist when I went to Turkey, and I came back and I wanted to do it with my interventional radiologist. I realized that their area of interest is not just thyroid. My interventional radiologist is he's a world-renowned neurointerventional radiologist, and he enjoys doing that. But unless you personally go to a center, you learn and you try to do the same thing every day, then you can replicate. So I had that problem. So I can't go and tell him, sir, why don't you do this here? Why don't you do that there? So if you want to give the best, and I do only thyroids and So I rather learn it myself, and I feel we definitely can do a better job. And yeah, if any interventional radiologist, particularly there's someone in Gangavani or somebody in Mumbai who focuses only on thyroid, definitely you will have the best results. There's no doubt about it.
Thank you, Dr. Siddharth. The audience can save some questions for the next expert, who is Dr. Sanjay Kumar Yadav. And he will again be showing some of the videos of cases where he has done microwave ablation.
So, good afternoon, everyone. So, we have discussed in depth regarding procedure, regarding indications, patient selections, shared decision making. So, as surgeons, we continuously see that technologies keep evolving. And as I said in the morning, that we cannot stop evolution. So, that keeps happening. We can resist, but only for a while. So, and talking about unstoppable changes, this is Dhuandhar waterfall. It is also called as Grand Canyon of India. And here, no matter how much the stones resist, water keeps flowing and reshaping everything around it. So same thing is happening with thyroid surgery also. And sooner or later, microwave ablation is going to reshape how we are going to treat our patients. So as we had this talk that palpable thyroid nodules are quite common, and if we add ultrasonography to it, so it is kind of all-seeing eye. It will pick around the thyroid nodules in many of us. So, and standing here, I am also feeling the power of all-seeing eye, and I can see many people sleeping. so, so now I will not go into the detail, but as we all know that observation is standard for majority of our patients. Only few will require surgery, and out of those patients, now few of them could be managed with ablation. We have discussed this. So we have to be very careful while selecting patients who are fit for microwave ablation. And majority of these patients would be concerned because of cosmesis. So in those patients, this procedure fits very well. So earlier, this used to be routine care, either open thyroid surgery or endoscopic thyroid surgeries or transoral surgery. So microwave ablation is new technique. And we have discussed that there are three key points which we have to understand. First is hydrodissection. Second is trans-ischemic approach, but as Dr. Siddharth said, it is not a rule to use only this technique. And we can go by any means which is suitable for us. And third is moving shot technique. Moving shot technique is important in thyroid nodules because these are kind of oval nodules, not like liver mets which are round, where we can put the probe in the center of the nodule and it will ablate it from all around. So coming to video, this patient had a around 5 centimeter thyroid nodule, right-sided thyroid nodule, and she opted for microwave ablation. So now this is the usual setup with lots of syringes. This is the machine, and we need very chilled saline so that patient does not feel the heat from the burn. Now this recently I have started doing this procedure under superficial cervical plexus block. Patients are more comfortable and more cooperative. So now we are injecting local just in the midline near the isthmus where we will put a nick for introduction of our microwave antenna. Now we are proceeding with hydrodissection. As you can see that this nodule is slightly big and occupying almost whole of the thyroid gland. So we are doing a hydrodissection all around. So there is clear space between carotid and thyroid nodule. So this is hydrodissection was complete on the anterior and lateral side. Now we are doing hydrodissection on medial side near trachea. So what I do not use lignocaine in this area. I just use normal saline. And then now I am going through the nodule to the posterior surface of the nodule and lifting the nodule from the posterior surface. So it will this nodule kind of fully floating in the saline solution. So now the nodule is being lifted from the posterior surface as well. And once we are satisfied with hydrodissection, we will proceed with, this is the setup. I usually use 30-watt setup. So now we are introducing this microwave antenna following classical transsystemic approach. So this is the superior most part of the nodule. We'll start ablating from there, then we will come down. Now going to almost middle part of the nodule. So you can see the antenna is reaching till the posterior surface of the nodule. What is happening is someone doing something from there. So again, going to the posterior of the nodule, then coming anteriorly. Here again, anterior most part of the nodule in that plane. So we will keep moving the probe lower and lower and keep ablating the nodule in those planes. So this was a big nodule, so it took a lot of time. So this is after the ablation procedure. This is a patient after just immediately after the procedure. So this is another patient. This is follow-up after around 1 year. And another patient, this is her nodule has completely disappeared after 3 months of follow-up. So, sorry. So, and we have been discussing since like previous lecture that consent form and shared decision making is very important if we are planning to do microwave ablation. And but whatever we do, that resistance is futile against this procedure. This is going to stay. So I think all endocrine surgeons should learn at least how to do it. Then obviously we can always discuss with the patients and make a decision what is best for them and which one they are going to opt for. And so last slide. So this is from our scriptures. No surgical act without knowledge is auspicious, says Susrut Samhita. Thank you.
If you have any questions, you can ask.
So again, yes. So so like this is available under Ayushman Bharat Yojana. So there we so the antenna is like they provide 90,000 for antenna and 30,000 for the procedure. So for Ayushman beneficiary patient, it is free. And for patients who are paying, we can always reuse the antenna. So one antenna can be used in 4 to 5 patients. So the actual cost of antenna for one patient will be 25,000, and remaining can be decided based on the institute or surgeon. And yes.
Just a basic question. When you are ablating and you're also visualizing the ultrasound images, so what is better, going from below up or above down? We're talking about visualization because we know the changes will take place when going from above down. Will it not reflect on the ultrasound vision?
No, that is why we start from the posterior part, so that the needle is always visible when we are coming to anterior part. That is the advantage of starting from the posterior part of the nodule.
I thought you started from above down.
No, from posterior to anterior. Because the area will become hyper-echoic. So you will not be able to identify the needle. Yes.
How much chances of residual and recurrence?
So residual, as I said, the successful procedure is defined at 50% reduction in volume. So if 50% volume is reduced, then your procedure is successful. And obviously there is chances of recurrence. So various studies show 5%, some say 3%. So, but these are all from the East Asian countries, Taiwan, Korea, and they have very like their nodule size is very less, 1 centimeter, 2 centimeter. So I think at this point we cannot comment on our Indian.
Also about the cancer, micropapillary and all, we will miss them.
Yes, obviously. So that is why the first talk itself said that we have to be sure about benignity of the nodule.
So how can we be sure about it?
No, so
unless we biopsy it,
yeah,
we can never be sure.
Yeah. So what we do is in practice, we do FNAC twice, ultrasound guided FNAC twice. Even then we cannot be sure, but even then we are observing benign nodules, right? We do not ask surgery for each nodule. We intervene only when there are cosmetic concerns. So for those patients, this is suitable option.
Sir, my question is that what should be a duration of ablation?
Sorry?
I mean, in each setting, when we are antenna is within that, what should be exact timing? I mean, we have to ablate for how minutes, like 1, 2, or
Okay, for
each setting is having a specific timing?
Yes, at each single point, you have to wait for around 10 seconds. So that will ablate that zone. Then you move your antenna, then again start the microwave machine. Then again wait for 10 seconds, then move it.
My question again is that if any lesion is hypervascular, as we all know, thyroid was highly vascular, but sometimes it is more of late showing vascularity, prominent vessel is there. In those cases, timing will be changed for the ablation or it will be same?
No, it will be same. Timing will be same.
So I add up to this point. I mean, The timing also depends on the watts that you are using. If you are using only 25 watts, it might vary. Or if you are using 30 or 40 watts, again, the time will come down, the duration of the bus. Second thing, it depends on the consistency of the tissue. If it's a hard tissue like a papillary thyroid carcinoma, it's a solid tumor, then you may have to burn for a little longer time. It also depends on the company to company. The Canyon, it is different. For Eco, it is different. And there is another Mima, it is a different. So every company, it is different. How do you identify it? You have to see on the ultrasound that you get that hyperechoic bubble. When you get that hyperechoic bubble, it can sometimes be only 3 seconds. It can sometimes be 10 seconds. So it is not like every patient I might use the same wattage. It depends on several factors. One is the wattage that you're using, the company that you're using, and then the temperature that goes on. So there are several factors which are taken into consideration by deciding on the amount of time that you're going to bus.
Sir, any use of any modality like CT along with the ultrasound will going to help us in those cases? Any experiences you regarding this case?
Sorry,
Sir, I want to say that we are doing ultrasound guided. Apart from that CT correlation, apart from the guided ultrasound, along with the CT, is going to help in more helpful, or it is like equal to that?
No, so like the till diagnosis, you have to follow the standard protocol, right? How you evaluate a thyroid nodule, okay? By triple assessment, you have to follow that. And after that, when it comes to the procedure, that time you decide, you discuss with the patient if he or she wants microwave ablation or surgery. So CT and other things will come if you think clinically it is suspicious, or there are some other features for which you want to get a CT done, then you will obviously do it. But for this, you don't have to rely on CT.
Okay, sir. During procedure, CT guidance is not needed.
No, CT guidance is not needed.
Thank you, sir.
Have you encountered any situation when there is a very large nodule and you purposefully left behind some part and you then re-ablate it in setting CT?
Yes, ma'am. So I had a patient who had a very huge multinodular goiter, and he was not ready for surgery anyhow, and he traveled from a very long distance to get this procedure done. Then also, and he was a relative of an endocrinologist. I told him that surgery is best for him, but he said, no, he doesn't want to get operated. So let's do. So we explained everything to him, and we did. And I think in first setting, we could ablate only 30% of the total nodules because there were multiple nodules. And I used almost all approaches. I went from medial side, from lateral side, from anterior side. So, but this patient had quite reduction, and he again came after around 8 to 9 months, and we did a second ablation also. And his goiter has shrunk significantly. And he is happy with that, and he doesn't want to get third setting, or he doesn't want to get operated.
One question regarding the thyroid cyst. How large, what is the upper limit when you do the alcohol injection in that? And what volume do you inject?
So I think I have not much experience with alcohol ablation. I have done quite a few, but usually we inject around 50% of the volume, which we drain from the cyst. Siddharth can-
I have aspirated up to 7 to 8 centimeters. We can aspirate safely. 7 to 8 centimeters will come to a volume of around 40 to 50 ml that we aspirate. So I usually prefer 1/3 to half of the alcohol of the colloid that I had aspirated. So the same amount, if I have aspirated say 60 ml, I would say 20 ml of ethanol I'll inject inside. And then we have to wait for at least 3 minutes for the ethanol to act. And then we reaspirate the ethanol, wash it with saline, and then repeat the same for 3 times. When you do this for 3 times, the entire wall will die nicely, and within a month you will see significant shrinkage of the what, like we all are surgeons, like now when I go back and I think, are so many thyroid cysts I have operated, which I could have avoided the operation altogether.
So finally, you leave some inside, or you wash that also?
So you can leave 1 to 2 cc in a small thing, but it's not really required. So even when you can't always aspirate. If you invest 20 ml, you may not be able to aspirate the entire 1 or 2 cc will anyways be there inside. So not a problem. We use 95 to 99% of ethanol. So it's available in the market. We can ask the pharmacy, they'll get it for us.
Hemorrhage, suppose you are doing, we are aspirating or whatever while doing the, inserting the needle. If you have any hemorrhage or any bleeding inside, do you stop your procedure or do you continue doing it?
So there are two things. I mean, if you are using ethanol is one, and when you are doing a microwave ablation, these are two things. When you are using an ethanol ablation, the ethanol itself acts like a hemostat. So small bleedings will be controlled by the ethanol itself. You leave behind the ethanol, the next aspirate that you do, it will all become clear. So that's one. But when you're doing a microwave,
we will continue the question answer session. Till then, those who are interested in doing hands-on, please go and register yourself outside on the stall. This is just to avoid the crowding. So please get yourself registered. We can continue the question answer sessions. No issues.
Thank you, sir. Thank you so much.
Thank you very much.
Thank
Just want to ask, any experience of operating on these patients after
No,
microwave or ethanol?
No,
I expect it to be very fibrotic.
So here at SGPGI, we operated on a patient who underwent ethanol ablation for parathyroid adenoma. And unfortunately, disease was persistent. He underwent somewhere else. Then when a disease was not cured, he came here. So we operated on him. And obviously, it was very challenging. So I don't have any experience of operating on microwave ablation, but Dr. Ramya has operated. She
powdery material has come out from the nodule. It's kind of tough to operate. It was a toxic nodular goiter. I don't know why they did they did radio frequency ablation actually.
Nice. Yes.
Is there any size criteria that above this, preferably it should not be done?
Yes,
Like
so as we had in one of the presentations also, so if volume is more, the best results are with volume with about 20 to 30 ml nodule. There you can have 95% reduction, even 100%, like Siddharth showed that for 1 centimeter papillary microcarcinoma, the nodule almost disappeared. So for those sizes and volume, this is kind of better procedure. But for nodules which are more than 4 centimeter, 5 centimeter, so obviously you can't expect 100% volume reduction.
because you showed most of them were quite large.
Yes. So in my practice, I don't see microcarcinomas. I see full-blown carcinomas only and big MNGs. So we are very selective in our patients, and ultimately it is patient's decision whether he or she wants to undergo surgery or microwave ablation. So over 4 years, I have done around 65 to 70 microwave ablations only, not more than that, because I am personally more comfortable with surgery, but obviously patients sometimes will say that no, I want microwave ablation.
Thank you. Thank you.
We also determine the outcome, like spongy form nodules, like I saw that majority of those were having some cystic solid
complex component. So that would also be a determinant, and I
Yes.
understand.
Yes, ma'am. So definitely a solid nodule will have more reduction in volume than a spongiform nodule.
Will not recur even if you are doing maybe 2-3 times if you need to do just an aspiration. For a smaller cyst, I don't think we need any ablation also.
Yes, so for smaller nodules also we don't need any intervention. Ultimately, it is
No, if
patient
there
who
is
wants.
a colloid or a cyst, if you just aspirate it, maybe in my practice, I have seen that it will recur maybe once or twice. It will not recur many times. Yes, a big cyst, yes. But a smaller cyst can just be aspirated without any ethanol ablation.
I think there is literature on this that only aspiration is right now not the recommended treatment for colloid cyst because chances of recurrence are very high.
But that's what, no, if you have to see and you have to
No,
put
I don't have.
the recurrence because we have not seen much recurrence.
So I don't have much experience with simple cysts.
Simple cyst, I usually aspirate it first, ma'am. Provided if it's a small cyst, most of them we leave it. We don't really do anything to it. But if the patient wants it, we aspirate, and as you rightly said, it doesn't need one more treatment. Sometimes it might recur. So these are the patients where you should consider ethanol ablation. But ethanol ablation plays an important role in the benign nodules, which most of them are solid and cystic. So you might have more than 50 to 60% cystic component. Directly, if you go for ethanol ablation, you have a 5 centimeter nodule to ablate. It becomes difficult. So 50% you are reducing by just doing ethanol ablation. That you can do it in the OPD itself. I do it in my outpatient chamber. You don't need to take them to the theater. Definitely. We all do that. I mean, I do my own FNACs. I do my own guided FNACs. We have our own pathologist, on-site pathologist. So we make sure that it is benign. So if we don't do our own ultrasounds, then you rely on somebody else. I'm not substituting the radiologist at any point. The radiologist will always do his ultrasound. He'll give his report, but ultrasound is my tool. It's my hand. I do the ultrasound. Within a week, I see the biopsy when I'm operating, and I am learning. Every day I'm learning, and with time, you definitely know which patient to select and which to operate.
Oh, so I had a couple of questions. Wonderful presentation by both the experts. Congratulations, Sanjay sir. Congratulations, Siddharth sir.
Thank you.
So now we have 3 different kids in the block: microwave, radio frequency, cryo. So how do we decide what for what patient? Your experiences, your thoughts.
Yes, so I think between microwave and radio frequency, I think the current literature supports that microwave ablation has better results than radio frequency ablation. I don't have any idea about cryoablation.
No experience with cryo assets. What I have seen in China, for a large, they were comfortable using radio frequency ablation. For a large nodule, they were comfortable using radio frequency. But when you're using a radio frequency ablation, there is something called heat sink effect. So particularly near the major, like when you have a carotid artery and there's like a blood is flowing there continuously and you're buzzing near that posterior aspect. So you can't heat up that. You can't damage that particular tissue which is close to the carotid because there's a continuous convection and that area is always cold. You can't burn that because radio frequency, the method is different. How it works is different. It works on the radio frequency waves which oscillate the ions. The oscillation of the ions close to the probe is what generates the heat. The probe does not produce the heat. Unlike in microwave ablation, the tip of the probe is the one which becomes super hot. So you have that cooling thing and everything. Of course, the radio frequency also becomes hot because the adjoining tissue it has heated up the adjoining tissue. The tip also becomes hot. So larger nodules, they prefer. Small nodules, we prefer microwave ablation, but it all depends on your availability and convenience and what you are comfortable with. At the end of the day, you have to use both radio frequency and microwave. And cryo literature also doesn't support much for thyroid at the moment.
Our IRs are more comfortable with the cryos, so I had
For thyroid or for
thyroid.
renal cell carcinoma?
Yeah, for thyroids.
Oh,
So
we will also
that
would
was because
love
I
to
had
learn from
referred
them.
one
Yeah.
benign nodule. A consultant came to me with her sister having a benign thyroid nodule. I sent my put this one. Please go ahead, get an repeat FNAC done, and go ahead with an ablation microwave. They didn't have a microwave, so they went ahead with the cryo.
Right.
So that was one of the things. The second part I had was you said that the follow-up imaging, they usually give a TIRADS 5 when they do not know. So I think we can, if you have the literature, if you can come up with these follow-up images and say what are the characteristics post-ablation, it would be a great literature from both of you.
Correct.
Yeah, thank you so much.
Thanks.
Thank you, Sanjay. You can come here and answer if there are any more questions. I cannot close the session because there is a lot of time left. I hope the questions are no more. We don't have more questions.
No, actually, the time was purposefully kept, like one batch could go and have hands-on and the thing, rest of us remain inside. So if there are any other questions or comments, those are welcome. Otherwise, we thank our chairperson and experts for having this nice, wonderful interactive session. And we learned a lot. Thank you so much. So meanwhile, you can have a tea.
Thank you.
Thank you. Thank you so much.
For those of you interested in a hands-on workshop, you can go register your names at the microwave stalls.
check, hello, check, hello. Check, 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 hello, check, hello, hello, check, hello, hello.
I request everyone to reassemble in the hall for the next workshop, latest by 4:15 p.m. That will be on neuromonitoring and indocyanine green.
Hello everyone, welcome back to our next session for today, which is a workshop on neuromonitoring and role of indocyanine green. It will consist of 2 video lectures and it will be coordinated by Dr. Gyanchand sir. And I would like to invite the chairpersons to the days, Dr. Divya Daya, Dr. Sudhi, and Dr. Shalik. Over to you, sir.
Good afternoon. Yes, Dr. Salik, sir. So we are waiting for the chairpersons, Professor Divya Daya, madam from PGI Chandigarh, and Dr. Sudhi Kamboj from Meerut. Okay. So in continuation of the technical discussion, as you know that during thyroid surgery, the identification of the nerve and parathyroid is very important. And using the adjunct to identify the nerve and parathyroids helps to prevent the complications. So for those adjuncts, we have kept this workshop, video workshop, to demonstrate both adjuncts, neuromonitoring as well as the ICG guidance parathyroid identifications. So for that, we have 2 speakers, eminent speakers, Professor Pooja Ramakant from KGMU Lucknow and Dr. Roma Pradhan from Medanta Lucknow. So both are eminent speaker with us. So I hand over to the chairperson. They invite the speakers and they will demonstrate the video demonstration of these 2 presentations. Thank you.
Good evening. I invite Dr. Pooja ma'am to deliver a lecture on ICG.
Thank you, Gaurav sir, for this opportunity. Thank you, Gyan sir. So I shall be showing the video. Can you start this? So I'm directly hitting the video of ICG for parathyroid perfusion status. So I bring greetings from King George's Medical University. And we use ICG for thyroid surgery when the lobe is there and after the thyroid nodule has been excised, both ways. So this is an example of a lady who had benign multinodular goiter. I will not be showing the steps of thyroidectomy, but just to make the base, we started off. And ICG is quite a safe, water-soluble dye. So it's quite easily, the learning curve is quite easy and ready to use and doesn't require much of the OT time. So it's quite manageable. So once the lobe is out, then you identify the parathyroids. And if you have a doubt or suspicion whether it's para or not, then you can use ICG to identify it. Second is after you identify it, you can look for the perfusion. So that's what I wanted to show. So this was a benign multinodular goiter. And there are other adjuncts also which we use. Shall be showing along with the ICG for the perfusion status. So bipolar is a very good device. So you walk between the thyroid and the parathyroid. You can see the parathyroid there. Visually also you can identify, but difficult to quantify its vascular status and to make a decision for autotransplantation if you have devascularized it. So that way ICG helps. So it's a nice, useful intraoperative adjunct. So other thing which have been added in our blog to use it is one is the loops. Once you see the magnified vision, the magnified parathyroids and the nerve, so loops really help. Along with that, you can have light also. So now the meta glasses have come, you can record it also. So I think the technology is advancing faster. Other is hydrodissection. So we have got the Arbase machine where there is a hydrodissector jet. We can use it. So that also helps a lot. So the pressure is minus 300 bars. You can increase or decrease the pressure. This is a system with the handle piece and the silicone tubing. It's disposable. And this is like a cautery. You have this pen with which you use it. And there's a paddle. When you press the paddle, the water comes out, and it has an inbuilt suction also. So once you have dissected with the water, you can suck the water which has come in your field. So this is just checking whether it's working fine or not. So it's quite useful adjunct. So I'm use this also near the parathyroid so that they get separated. Only thing is the assistant has to buzz the small microcapillary tears which happen simultaneously when we are using it. So like other case, I have just mixed two cases because the two different things were good in each of them. So this hydrodissection also helps us over the trachea. You see here, we are buzzing off simultaneously while using this. So then there's no charring and no blackening. I'll show in the other case how the charring and blackening happens when we don't do hydrodissection and we use bipolar, so that charring part happens over the trachea. So all small micro steps helps in parathyroid preservation. So then the role of ICG comes. How do you prepare the dye? So how is it available? So this is an oro green. It comes as a powder. It costs around 2,300. And this is all the ornamentarium. You have to mix it with distilled water and dilute it. It is 25 milligram in one bottle. And then you shake it for 3 minutes so that it's well mixed. And then you take it with a filter. So there's a filter which helps to avoid any particulate materials which should not come in this. So this filter helps you, and then you load it. So this can be easily injected to the antecubital vein with the anesthetist. The half-life is very short, just 3 minutes. So when you are ready to check for a parathyroid, you can just request the anesthetist to inject it, and within 2-3 minutes, you can see the bright green parathyroids. So you load it around 5 ml. You can inject either 1 or 2 ml and then see, and then use rest of the mls when you are doing the other part. So it depends on how you're using it. This is a Spy-Fi camera. So you adjust the camera. Usually the ideal distance where you keep the camera is around between 10 to 40 centimeters. So once you adjust it, you have to switch off the top lights of the theater. So that helps in better visualization. And there's a monitor in which you see what this camera is displaying. So there are two different things. Once you see here and other is this. So camera has got certain buttons. So the green one is to toggle different modes. B is the selection mode. There are a lot of modes. There are 4 modes, online modes. I shall be showing each mode and telling you the importance. The blue one is zoom in, zoom out one. And then there's a quantification software by which you can objectively say how much percentage of parathyroid have been devascularized. So based on the percentage, you can decide whether you want to auto transplant or not. So some modes are subjective, like gray one, where the gray, white, or black you have to differentiate, or you can quantify it and make it more objective. So this is what we are trying to see. I shall be showing you what we are seeing in the monitor. So this is real-time parathyroid localization when the parathyroid is on the thyroid lobe. So you see here, I had the doubt whether this parathyroid is here or this is part of the thyroid. So visually we had suspicion, we were not clear. This is a big tubercle, and then we were not very sure. So for this was a good case because we were not sure. It was totally stuck to the capsule of thyroid. It was quite lifted high up. So you see here with the onlay mode, you can see, well, this is parathyroid, not part of the thyroid. So we confirmed its localization plus its vascularity status also to make a decision if we have devascularized it fully, because it is quite high up, you can auto transplant. So that decision also is made on this. And this is the color segmentation mode. The more red it is, the more vascular. So you see here, there's a barcode, red to blue. Blue is devascularized. So thyroid has been dissected, so it is devascularized. But the parathyroid, the vascularity was from below, lower down. The red vessel you can see, so it is still vascularized, though it is quite high up. So we plan not to auto transplant it. And this is the third SPY mode, which is white means it's all vascularized. So if it takes too much of time, 5 to 10 minutes extra, then the whole gland, everything becomes white like in this. So we had to re-record it in other cases because we realized it is not well seen and everything looks all white. So white is vascular. So you see here, so because we were confirmed that the vascular status is good, So we didn't auto transplant, and with the bipolar, we just dissected it, and the blood supply was from below. So with the loops, we could see that end artery, and we could just drop it back. And this patient didn't had hypocalcemia, didn't needed any IV infusions. So all these decisions are critical. Other is doing post-hyadectomy. Once the specimen is out, you have the parathyroids and you want to see whether they are devascularized or they are vascularized status. So in that also here you see the trachea is charred because we didn't do the hydrodissection in one of the cases. So this part is better if you use hydrodissector. So this is a quantification mode where you see this parathyroid has more than 100% in the onlay mode. So it is a vascularized parathyroid. It is very high because we didn't fix it with the IJV. If you had fixed it with some point, then it is relative to the flow. If IJV is 100%, then how much is the parathyroid vascularity? Because we didn't give a big incision, it was a benign MNG. So we just directly put it without fixing it with the IJV. But the all superior inferior had quite high percentage. And I shall show you some partially devascularized part also. Like in gray mode, you can see this is white. So the parathyroid was quite vascular, it is vascularized. And here also you can see white, but you can appreciate the difference, which is more vascularized. So here now looking with the percentage in this mode, you can see here it was around 50-60%, went maximum I think up to 70%. So single parathyroid less than 30% vascularity, then there's chance that patient may develop hypocalcemia and may need IV infusion. So all those decisions can be made on this quantification mode. So this is a good mode. You just need an extra software and that gets added in the machine also, that part. So we had Dr. Ashwani who did the thesis on this and we found it quite useful. So that way for each particular parathyroid, you can see the vascularity status. So if it is dark, dusky, the vascularity status may be low. But if it is like bright white here, you can see this is good example. Here it is more than 100%. So this is vascularized, which we have left it. So with this, it helps us guide in each step. So I think that's it. So with this, I thank you and I thank Dr. Arjun Raja who recorded this video and edited it and unfortunately has gone home for Onam. But he, Ashwani, Bharat, Prashant, all my team had worked hard to get it recorded. So thank you all, my team, and thank you all for the audience for seeing it. And there's a demonstration also in the stall. If anybody is interested, can go to the ICG stall and see this demonstration also. So the company people are also showing it. So any questions, any doubts, I'm happy to answer.
Thank you for nice presentation. Just I have to ask about this, your hydrojet, whether it is affecting or is facilitating the fluorescence or ICG methods for parathyroid.
No, sir, it's not, because we are not injecting inside the parathyroid. It is just between the parathyroid and thyroid. We are creating the plane with water, and this water stream, it is just dissecting.
Okay.
So that way it didn't affect.
So it does not damaging any vascularity of the
damaged.
parathyroid. Okay.
But thing is, because of the water, it damages the capillary. So we have to buzz it simultaneously. The assistant has to do that part. So that coordination has to happen. Otherwise, the capillaries bleed and then micro bloods you see, and then that damages your field.
So you do not face any difficulty to vascularity per se for the parathyroid.
But we have to use it carefully.
Okay.
And pressure also should not be very high in thyroid. So it is good over the trachea and good over the Baries ligament, the difficult structures, but with tough structures.
So can we
Not in every step, but in some steps it helps.
Can we connect any needle for in this instrument? So for the hydrodissection in the other side, like microwave ablation in other side, so we connect with the needle. Is
So
it possible?
It's quite fine. It's not very thick stream of water. It's very fine,
it's
like a
water
needle
jet
only.
only.
It's a water jet. It looks bulky, the part, but then when you use it, the water stream is very thin.
Okay.
That's not.
Thank you.
Having this machine, they can simply do it
With the syringe, yes, yes. Only thing is with syringe, you have to refill it every time. And this hydrodissection is a costly affair. So because we had part in the machine, so we are using it.
You have
Luxury.
Can be very easily used.
Yes,
for
ma'am,
hydrodissection.
rightly said. Earlier we were doing that way only. Sometimes we do it because for every patient we can't afford to use hydrojet. It adds because it's all disposable. No, thesis has got over, but not for all cases because that adds to little bit 15 minutes extra time. But for difficult cases, whenever we have doubt, then we use it, but not in 100% all cases. But that's just, I think, our choice.
Thank you very much, Pooja ma'am. That was really very insightful lecture that you did. So many demonstrations that you've done. So may I request our hall to please give her a great
Sure, thank you.
round of applause for her efforts. And with that, we move on to our next speaker. Our next speaker is Dr. Roma Pradhan, and Roma will be demonstrating how we should do the autofluorescence and intraoperative neuromonitoring. She has a very, very good hand in doing that.
The next one.
And we are looking forward for
The next
for-
video, the 8 minutes video, dusra wala. A very good evening to all. Eight minutes wala jo hai. Yes, that's fine. Stop it. A very good evening to all. It's really a pleasure to be here after so many years. I think last time I missed the meeting here. So today I'll be showing the intraoperative neuromonitoring along with the new adjunct in thyroid surgery, that is autofluorescence. It comes before what ICG, when we can use ICG. So autofluorescence actually helps us to see the parathyroids. ICG tells us the functionality of the parathyroid, whether it is functional or not. This is used to identify the parathyroids. Video on. So it's just a video, no lecture. So this is the neuromonitoring machine. This is the NIM3 machine. Here what we have is the NIM Vital. That is one step ahead. It's only you can see instead of Samsung Galaxy 23, you have 25 Ultra. So it is something like that. This one is the ground. This is the electrodes. These are the wires. So we have a dedicated technician in our OT to manage this equipment. We don't have to stress about it. We use it for all our cases. So here we have the thyroid one, and the other one is thyroid with APS. That is the continuous neuromonitoring. So once we switch on the monitor here, you'll see all the cross right now. So the electrodes are not yet connected. What I've modified a bit is to place these electrodes. What we used to do during here in PGI was we used to place it after the patient was scrubbed, and then we used to put it at sternal region. But I do it like we put it beforehand. These are the electrodes. We do it before the patient is scrubbed so that we know the circuit is functioning even before the patient is draped, and the anesthesia people can manage the neuromonitoring tube. So once the patient is intubated, we have the complete circuit. So he's a technician. He's even here to help you out with the hands-on thing. So that's our NSET is ready to, we use it for all our cases. And this is the box. This has been modified in the new one, NIM Vital. It's basically wireless, you can say, for 8-hour surgery. This is what I came to know because NIM Vital is the new one. We do not have that. So we start with thyroid. Now you see all the ticks will come for 1, 2, and then stimulus 1. And then we have the ground. All green ticks should be there. Only then your circuit is complete. So this happens before you have draped the patient. There's no worry about whether this is functioning or not. You can check the calibration also. So I focused more video on this equipment part rather than the real thyroidectomy, though I'll be showing some basic steps of that. So now you can see here. What we do is we put the current at 0.7 and then increase as we can. And so now the circuit is complete, it's ready to use. This is the cervical block, which is being put by our anesthetist. This is a routine in thyroid surgery, and patients are pretty comfortable post-operatively. They do not complain of any pain. This is the BIS that they use for, because you cannot use muscle relaxants while you are using an intraoperative neuromonitoring. Volume थोड़ा सा तेज कर देना please. Because this overhead camera doesn't require the audio, so the video will be different. This is the simple coccus incision that we have given. That's the midline. That's how we check. That's the midline. So that's the lobe. So once we lift the inferior lobe, we use the autofluorescence. That part is missing. Now we have reached the superior pole. We'll be looking for EBSLN. थोड़ा volume अभी तेज और कर देना. So so once we recognize the EBSLN, we can confirm and check with the neuromonitoring. So that's the real. Let's see. इसको expand नहीं कर सकते? It is. So that's lifting of the thyroid and separating the parathyroids. I can see it well in this, पर उसमें screen में अच्छा नहीं आ रहा है. So once we have lifted the, this is the autofluorescence machine. So you just switch on the light. Once you have exposed the part, you switch on the autofluorescence machine, and there you see two dots you'll be able to see as parathyroids. Those tiny dots there. This one and this one here. So that's that you can recognize. Sometimes, of course, we all feel that whether that is parathyroid or not, whether it is fat, of course, this makes it easier. The next steps come the palpating the nerve. So after the superior pole, I always palpate the nerve. It's the best method, I think. And then we can use neuromonitoring for that. आवाज तेज करना थोड़ा. So that's the voice that you hear. And then it's the taking out of the thyroid. So again, after removal of the lobe, we see it with autofluorescence and confirm the parathyroids. It's a simple machine, though the handle is a little bulky, so you get used to the thing. So we check both the nerves. So this is the video that we made because it was not there for the overhead camera, though audio was there. So I'll show the video after this. The superior laryngeal. So you can see the twitching and also the voice on the monitor. This is the recurrent laryngeal nerve. This is the graph that you get. इसको बंद कर दो. Next वाला video कर दो. So I'll show you some more cases video. This one. Switch on. आवाज तेज कर देना. So this is the, I think this is better. This is the EBSLN one. आवाज तेज कर दो please. So you can see the twitching as well as the audio. That means that's the nerve. Then that's the nerve, recurrent laryngeal nerve. It's very important, once you have exposed the nerve, you should always, that's the recurrent laryngeal nerve. That was the parathyroid, and we did autofluorescence. Now you can see how we see the. So those are the two dots that you see. So you can, they are stepwise when you do this autofluorescence.
Two branches.
There are two branches there that you can see. And both were motor. This is the first one. This is the second one. So this helps us when there are multiple branches and we need to know which one is actually functioning one.
Okay. Yeah. Two
This is another one.
Both are motor. Both have a signal.
So we had to preserve both the branches there. Unfortunately, I have never encountered a non-recurrent laryngeal nerve till now. So this is during robotic thyroidectomy, intraoperative neuromonitoring. So there's another set of continuous, this is another method, this is intermittent neuromonitoring. Another one is the continuous neuromonitoring, though now I am not using continuous because I didn't find it that useful. So continuous, I'm not using it, though I have an old video which is still there. If you people want, I can show you the continuous neuromonitoring, but it is actually not that feasible to use in daily, because intermittent, of course, you can use it daily in your all cases, but continuous, maybe in some selected cases you may use, but it's pretty difficult. You're not gaining anything out of it. So I have stopped using continuous neuromonitoring.
But just for demonstration, please continue. Demonstrate
Exactly.
the neuromonitoring.
Okay. So this was an old video. This was a huge multinodular goiter. So in continuous neuromonitoring, it's like they say it's the nerve is telling you that, okay, you stop if you're trying to damage the nerve. Nerve is crying. So these are the normal signals. Now what they have altered in the name vital is, instead of those lines that you can see of continuous, the red and the yellow one, they have more blocks, the colorful blocks that becomes more visualized. So it's easier to see maybe in name vital. So that's the normal graph that is happening. Continuous current is being sent from vagus to the RLN. And so whenever you manipulate the nerve, there's loss of signal. So loss of signal is usually recorded, either there's loss of amplitude or increase in latency. So that is the red one if it goes beyond that, up, or the yellow one. So these are the normal signals while you're working normally. So once you manipulate, it will be coming. So it's pretty tedious to every time isolate the vagus and put the clip there. For small cases, of course, you cannot do that. But yeah, so for some large, huge goiters, for retrosternal ones, maybe yes. So this is the alarms. Awaaz tez karna. So this is the alarm signal that you get whenever you, so the signals can be of two types, minor changes or major loss of signals. So if it is major, then of course you have to stop at that time and then allow the nerve either to recover, or you have to decide about whether you have to go ahead with the second site surgery or not.
initially it actually irritates you a lot whenever the signal is coming, even when you're not damaging the nerve or you're not even close to the nerve. So you have to get used to the signals. So that's, I was taking out the goiter. That's when the signals were there. So now what in NIM Vitals, they have put this probe with continuous monitoring. So you can directly stimulate the recurrent laryngeal nerve with continuous signals. So they say that is kind of a continuous neuromonitoring, but somebody has to keep holding that to the nerve. The idea of continuous neuromonitoring will come only if you put a probe in the vagus nerve, because the continuous signals will be there, and whenever you disrupt the nerve, the signals will break and you will get it as an alarm signal. I think that's it.
Presentation room as usual. So a couple of questions that are in my mind. Like, first of all, regarding intermittent neuromonitoring. So what we are doing in intermittent, we are exposing the nerve, and then we are confirming that nerve-like structure whether it is nerve or not. Okay, an experienced thyroid surgeon already knows, like, they very well identify that it is a nerve. Our problem arises when during difficult thyroidectomies, we are not able to identify, because once nerve is identified, it is identified, right? So this, I am not able to, maybe this question must be in other people's mind also. Then what is the exact benefit of using intermittent? Secondly, while using intermittent, it is only telling us whether the nerve is damaged or intact. If already during dissection we have already damaged the nerve, and then if we put an intermittent probe over it and it tells that there is no current and the nerve is already damaged, so we are not finding any benefit. Like, please pardon me for my
Sure.
ignorance, right? These questions are in mind. What I feel while I am operating, if I get beep, that I am near the nerve, okay, and then I become more cautious because of that beep. What I feel, I will be more cautious, and it adds on to the value. So while you said that you were doing continuous, but you withdrew doing that. So it would be really important for me to understand what were the various factors which you felt that this continuous monitoring is not helpful for, though it looks appealing, but it is not helpful. And is it really worth doing intermittent? Because there are many practitioners who are practicing in cost-constrained areas or in a private setup. So this will certainly add to the cost. So with all that much of experience that you have, would you like to share or put some light on these points?
Yes, very pertinent question. Definitely everybody questions us, why are we using neuromonitoring? But I must tell you, we do not know beforehand which case is different, which case is difficult. Thyroid, I must tell you, every case is difficult unless you have done it. Because every day, every case, you find something which is different in that and something difficult. So I know as experienced surgeons, we all know that now we can recognize, but sometimes it really helps us to see which one is actually the nerve when you are really stuck. So that time you cannot put in neuromonitoring at that time when you are stuck there. And this is an adjunct which is present, which is there for us to give it to the patient also. We inform them that yes, this technique is available to us. And it is, and according to the literature also, there are benefits. Of course, we need a lot of patients to see the real benefit, but in training also definitely it helps. In the initial stages, it helps. And coming to the continuous neuromonitoring, sometimes the beep is so many, I mean, you get the beep so many times that you get so confused that's why I have really actually stopped using it. That doesn't actually help. But yes, we have papers there supporting continuous neuromonitoring also. But wherever we go to meetings, whenever I talk to other people, none of the endocrine surgeons are actually using continuous. But neuromonitoring intermittent in Japan also they're using for every patient.
So the beep that you were hearing, was that because you were very close to the nerve, dissecting very close to the nerve? That's why.
Sometimes it's artifact. Majority of the time it is the artifact, because when you are pulling, everything is getting pulled. So maybe because that didn't turn up into actual loss of signals.
So was that as a part of some project that you put the continuous monitoring?
No project. I was doing it for myself.
So that your inner endocrine surgeon woke up ki, okay, this machine is not telling me right. So
Yes, and it was little cumbersome. You know, it wastes a lot of time also. You have to see that intermittent is pretty simple. It doesn't waste time. It helps you to confirm that yes, it is a functioning nerve, and then you get a graph also. You can put it in patient's file. So all this is definitely useful in a corporate sector. Definitely, I would say.
Okay, so now my last question, then I switch on to the forum. Like just leave it that you are working in Medanta or some corporate. Just leave it. You are a normal surgeon, like all the other surgeons. So if you are given the opportunity, with neuromonitoring, without neuromonitoring, in a normal case, with all cost constraints and other things, what would you really
See, normal case, how do we know that is a normal case? That is the exact point I'm trying to put. We do not know which case will be normal. You know, sometimes you feel that cases, now I'm sure everybody must have encountered such cases which were easy, but then you got stuck somewhere. So if you have the facility, use it. If you do not have, then it's okay. Of course, cost isn't a factor. Cost is a factor.
is a major factor.
Definitely, I agree to that.
Yeah. Thank you very much for your insights. So may I request anyone who wants to ask
Yes,
question
ma'am.
from Dr. Roma?
In nerve injury. Have
So
you?
we need
is
actually
there any data of that?
No, we need a lot of cases to prove that yes, it did benefit. Otherwise, in literature, it doesn't.
Scenario. There are not
It
many
helps
people
us.
in
It makes the surgery
not-
easy. Like you're less stressed when you have left a functioning nerve. Post-operative, of course, you're less stressed. Otherwise, you keep asking,
No,
"Awaaz
that is
theek hai?
true.
Awaaz theek hai,
No,
patient ki?"
that
So that is
absolute-
what happens.
Is there any evidence, worldwide literature? I don't know, but do you have any literature where they may tell us that yes, if we have used neuromonitoring, then our results are, in terms of nerve injuries, are much better.
Yeah, according to there's some papers which say that trainees, it does help. And you need, there are no head-on trials as such for this.
Yeah, so that I think that is needed because
It'll be like you need a lot of patience for that.
but I think there are not many people in world also are doing neuromonitoring still. Many of the people are doing, those who can afford, they are doing it. So they must be having some data at least that is it really useful? That is what.
I think, Dr. Sudhi, the real use of neuromonitoring would be when you decide for contralateral dissection. Because suppose you have damaged on one side and you are dealing with, let's say, a low risk papillary carcinoma, you can maybe stage your procedure or be more cautious on the other side, or prognosticate the patient beforehand that you may require, at least you can anticipate that if you happen to damage the other side, if it is also difficult, then you will require tracheostomy. So prophylactic. So rather than preserving the nerve on the same side, its use is in decision making for contralateral dissection.
Redo surgery.
Maybe.
So can I address this issue? I think Mukta brought out something very important about whether there is a robust data to support routine use of intraoperative neuromonitoring. The data or evidence that is there is it favors as well as equally it does not support routine use of intraoperative neuromonitoring. But as is the case with most new technology, there is a push to use it while nobody can deny there are specific cases where that will be of use, but as Roma said rightly, you cannot preempt without having the neuromonitoring tube inside and using it, which of the cases you will find it useful. So specifically going back to the evidence, now there are a number of countries which have standard practice guidelines, including use of neuromonitoring. And I was hoping to have a comment from our Australian faculty here. Unfortunately, they're not here right now. Australia is one of those countries. The two meta-analysis, you can all go back and see. One prospective randomized trial from Germany, which was negative, which did not show any benefit of use of intraoperative neuromonitoring in reducing permanent or even temporary nerve palsy rates. But one meta-analysis based on, in my mind, very sketchy data did bring out the possibility of it being useful, of reducing the nerve palsy rates. So the data is for us to judge. I don't think there's any categoric data which will help us decide one way or the other. But in selective cases, yes, it does help. It does add a lot of cost, a little bit of extra operating time. And thirdly, do not forget, it is not an infallible technology in two ways. The technology itself may fail if the tube is not in the right place, it gets displaced with manipulation. And then you'll be left with a unuseful neuromonitoring machine. And secondly, even though intraoperatively you may have demonstrated signal being there, yet patient may have postoperative hoarseness or change in voice, because change in voice is multifactorial. It's not simply recurrent nerve palsy or external branch recurrent nerve palsy which causes it. Patients with mobile vocal cord, anecdotally, I'm sure all of us have faced this, would have hoarse voice.
So,
In continuous of this, again, one comment from that most of the country where it is a compulsory, means they are using in the all patients, most of the time it is the insurance driven. So if you are not using neuromonitoring, the insurance is not going to pay. So that's why it is compulsory to use in all the patients.
So that is what actually happens in corporate also, sir. Patients do demand. They ask you, what do you... In fact, I remember one of my patient for robotic, he was asking me exact which type of robot you have. So that is one of the thing, none of the patients here in PGI ask, but they never used to ask us what technology you have. But the things are absolutely different on that side. So...
Definitely.
One last comment, because any technology, be it any machine, whenever it is in the market and it is being promoted, it is very important to see our own result. Maybe we can do some cases, or from fellow doctors, we can take the reviews, because most of them, these are corporate driven. So there's a huge lot of money that is being pumped into the studies. So there are some hidden conflict of interest or agenda, which say that this particular thing is very, very useful, but it is always important that you gain information from conferences like this and from fellow colleagues regarding the exact utility, and then you should think of investing into it.
Yeah, and first maybe you can use it, and then only you can discard some procedure that you are doing. Because first you have to have first-hand knowledge of what you are doing. Only then we can say, yeah, this is not good. Just like continuous neuromonitoring. And coming to the time management for this, we have a dedicated technician to manage the equipment. So we do not waste any time. I remember myself in RML, I was like struggling with the wires and everything, doing myself. But here it is pretty comfortable because he's there. He knows what to do. Whenever there's some troubleshooting, he comes and he corrects it. So that is one thing maybe.
Yeah, actually, like Dr. Gaurav sir said, that in our setup, most of the time that JR and first year anesthetics are
Yes.
there, so they do not able
No,
to
hi,
the
that's
exact
true.
location of the tube. So sometimes it is failure there.
Very important, but when to use is even more important. Everything doesn't fit into all patients, and
I have a few comments about the nerve monitoring. I started using for the past 3 years, and now I don't wheel in any patient unless the nerve monitoring is ready. That's first thing. Second thing, yeah, you can identify the nerve. You don't really have to dissect the nerve to actually get the stimulus. How do you do that? So you put the stimulus at 1 milliampere. So if you increase it to 2 milliamperes, you can localize it without actually dissecting.
Yes, for that purpose, NIM3 is this
Ah,
one, NIM
so that-
Vital is much better for that thing.
So that really saves in identifying it. Third thing, when I'm operating, suddenly I feel the signal which was 300, it goes down to 50. And then I know, okay, the most common cause of nerve injury is traction injury. Then I stop operating on that side. I'd go back to the other side, operate and come back. I'll get back the signal to 300. So I'd have continued operating with the same amount of traction. Maybe I would have caused damage. That's another thing. And regarding the medial and lateral branches that we were discussing, so the lateral branch will not give you the signal because it's a sensory branch. It doesn't supply, it only supplies the sensory branch, whereas the medial branch will give you the signal. So you have to be careful. Don't think lateral branch is nothing and you transect it. And it has lots of learning curve. Like 3 years I'm doing and it will fail you. So you have to be careful. And it never, I mean, you can't blindly believe it. Suddenly one fine day I was operating, the signal was all fine. That fellow was a VIP and I realized the signal went off. It was 1,000 and it disappeared. And you imagine what happens to the surgeon. And then I realized there was a new anesthetist who had come in and she gave him the relax.
Relax.
So many things can happen.
So the team should be there. Everybody should be apprised with
It's
what
not
you're
easy.
doing.
But once you learn it, it definitely decreases the time of your operation. So I felt it has decreased my time. Maybe it is personal. And as Sir has said, the data is variable.
Meantime, we are
Intermittent.
discussing, excuse me. Meantime, we are discussing just to demonstrate.
Okay.
So please. So demonstration is continuing. But 2 minutes like this.
Sir, actually, I wanted to add, if there is time.
Yeah, please.
Add
You
to
continue.
Gaurav Agarwal, sir, what he has told. So the meta-analysis basically, and also what Mukta ma'am was asking. So meta-analysis says
So
that
he's our technician. He manages the thing. सब setup यही करते हैं. हम लोग बस use करते हैं.
there has been good results for those which are recurrent, reoperative, and which have retrosternal extension. For these, there is a good result and positive this thing for IONL.
Tube, we all know about the tube. This is the electro. Yeah, so this has to be at the vocal cord. This is important. Your anesthetist should be apprised with it. They should know where to place the tube. Then we have the 2 electrodes here. Yeah. Showing the amplitude.
7th amplitude part tube in vocal cord. And
this setup is already done here. We have the simulation here. Yeah. So make sure the current you have to manage. When you have fully exposed the nerve, always keep the current around 0.7. Do not increase it to 1 because sometimes you repeatedly, when you do the stimulus, praxia does occur. So then don't blame the intermittent neuromonitoring for that. So that's the nerve there. So that's the beep you get. So there's yeah. Oh, this is the added advantage of NIM Vital. They are actually telling you audio-wise also what's the voltage and. No, this is not. No. Intermittent can be used as continuous, but that is not the real continuous one. The continuous is the vagal electrode that you have to put. 840. That's what I'm saying. It's wireless. One thing is this wireless. This one. 860. This is the one thing. And in the continuous thing, you get red blocks and blue blocks instead of the line. It's just little glorified. And it is like the audio 860, 859. This is not what we get in NIM3. The audio is not there. Only the beeps are there. She's not saying anything. Yeah, the sound is there here also. Tick. Yes. I have especially found this useful for EBSLN. This is very good. For external branch, it's pretty useful. Your majority of the times, because that is the most neglected nerve, I'm sure everybody tries to just forget the nerve. But with the external branch, this equipment works good.
First have to identify the external branch, then we have to
Yeah, so see, there are a lot of white structures going there at the pole whenever you dissect it. So of course you need to, yes. So that there definitely it becomes very helpful. With the contracture, 100%, tricothyroid. But with the signals that they give, the voice that comes, maybe 80%, yes. So in this case, I was not able to hear, the case which I showed, I was not able to hear the voice. But the other cases, for visual identification, cricothyroid contracture, that happens like 100%. The company will tell I'm not using this. No, no, no. Glorified in
Compared to the older one, one is the wireless thing, that is the non-clinical thing. But in clinical, for the documentation, it's being easy. Like for the doing the Vegas first time stimulation recording and the RLN first time, and then doing again this RLN and the Vegas. The reporting thing is being easy for you. Like it will directly save into the reports, will show like this. And in the intermittent also, you can have a real-time feedback for this intermittent monitoring also as like the continuous monitoring. So to do that, you just need to take the stimulation by your manually. For continuous, we need 3, and for intermittent, we need only 2. So once we proceed for the next, either sternum, you can put it, or you can even put it on the shoulder, like any bony landmark. You can visit the Medtronic booth also for the hands-on. We have the same model over there also.
Thank you. It was a very enriching lecture and a lot of questions that has been answered in this session. And now we have a tea break. We now break for the tea. And this neuro monitoring device is available for hands-on in the respective counter. So those who want to have tea, they can have. Those who want to have the hands-on, they can join the team in their counter. Thank you very much. So the next session will be starting at around 5:30 p.m. and there will be launch of Lucknow Endocrine and Breast Surgery Club. So I request you to please be on time to join the next session.
Thank you, Chairperson, sir. Thank you. Yes, please continue.
Hello everyone. There is hands-on at the stall and you can try the simulator there.
I request everyone to please take their seats. Welcome back. We now move on to a significant moment in today's program, that is the launch of the Lucknow Endocrine and Breast Surgery Club, an initiative that will strengthen the and kindly please take your seats.
Please settle down so that we can start the next session. Please take your seats. Okay.
Welcome back. We now move on to a significant moment in today's program, that is the launch of the Lucknow Endocrine and Breast Surgery Club. To guide us through this, it is my pleasure to invite Dr. Pooja Ramakant ma'am on the stage. Welcome, ma'am.
Thank you, and I welcome you all in this unique concept. And I hope we set the landmark for other cities also to make these informal group or clubs. We decided to have it with everybody was thinking about to have a platform to meet, interact, and have some academic discussion also, and involve everybody, be it somebody working in the institutions, government institutions, or private practitioners, their own clinics, incorporates, and discuss cases or scenarios which they want to discuss or they have issues. So we thought we will start an informal group, people who are living in and around Lucknow. So we are including people around nearby Lucknow also. So the name is Lucknow Endocrine and Breast Surgery Club. And in the short acronym, it is LEBS Club. And many people helped in designing the logo, designing the names. And every start has their own bits of hiccups. So we also had those, but I'm happy that we all are coming together for this happy occasion. And I invite Gaurav Agarwal sir to guide us through the path and introduce us with the concept and the people who will be just taking it.
So, as Pooja has just introduced to us, the concept behind or the thought behind this club is to have a formal or in rather informal banner under which we can all meet people in and around Lucknow who have interest in endocrine surgery or breast surgery or both can come together at frequent intervals to discuss some interesting cases, some literature, or some other academic or professional interactions, and equally to meet socially to foster this fellowship or friendship even further. Endocrine surgeons are all very friendly people. I don't think there'll be any challenge on that account. We'll have plenty of kinship and friendship flowing. Uh, so uh, the purpose, as I have stated, is that, and what we plan to do is at least once every 2 months we will meet informally, mostly in the evenings at a time when it is convenient for majority to join after their works. And we intend to have by rotation some institution or otherwise people presenting some interesting cases or other academic contents of their interest, and then have social interaction, a dinner together. So there is no specific structure we have thought about. We will develop that as we go. Suggestions are welcome from everyone. Participation is welcome from everyone. How we would fund it is again, I mean, we have to contribute. We cannot depend on donations and sponsorships. We will ask everyone to contribute a modest amount. And as and when required, we can also seek some sponsorships. For now, Pooja is taking the lead. Besides her, Dr. Sabaratnam from SGPGI, Dr. Abhishek Krishna. Actually, when this concept was thought about, Dr. Abhishek was at that time not in SGPGI, but now that he is part of us, welcome back. And Dr. Sara Idris from Aryabal Institute. As we go, we'll add more and more people as per the need of the club to join further. But this is a beginning. And we have the senior most endocrine surgeon of Lucknow, Dr. S.K. Mishra, today with us. And we also have the president-elect or vice president of the Association of Surgeons of India and past president of Indian Association of Endocrine Surgeons, Dr. D. Maruthupandian. So they too would do the honors to unveil the logo of the Lucknow Endocrine and Breast Surgery Club, or LEBS Club, as we are calling it. Can we have the logo? Okay. Sir, please. Has all the endocrine glands and figure in depicting breast. And I hope this is an August beginning and we'll have many happy meetings under the banner of this club.
After this unveiling, we are beginning with the first social event, and that is a Happy Teachers' Day celebration. So I request both of sirs to cut the cake. And simultaneously, Dr. Sabha and Dr. Madhu have their birthdays. So we will have the birthday celebration also. So I request sir, please come this side.
Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you.
And we have got these nice fancy tags, and I request each Lucknow group people to put on the other person. So let's stand for each other. ये जो बोल रहा है वो इधर आए अब टैग ले
कौन बोला?
कुलरंजन सर और कौन बोलेगा अभिषेक आओ
Kulranjan, you can put it down on everybody. Everybody is little. आ जाओ. तो पैटर्न बना लो, इनको rather sponsor बना लो, financer.
So yeah, agenda नहीं सर बस ये है कि we plan once in 2 months informal meeting as sir said. To make it sustainable, we may have in institutions like rotatory once in SDPGI, once in KGMU, once in Health City Vistara, once in Hind, Pratik is there. So इस तरह से we can keep rotating it and we will have the opportunity to visit centers also. कोई अपोलो में है, किसी का अपना private clinic है, we can go there and we can have different people hosting it once in 2 months. And I've talked to Medical Endocrine Club also. So they have been running for last few years. So we once in 4 months, we will invite each other. So once we will invite them in our meeting and have a common discussion like Graves' disease and medical management part. And once they will invite us where surgical part is needed and we will have discussion. So that will keep interest in the club. And if there is some need for nuclear medicine physician, radiologist, like ablation or something, we will involve those specialties. We'll invite those people also. So that way there will be some excitement whenever we plan it once in 2 months. So that makes it sustainable. Right now it is an informal group on WhatsApp and a Google group. We will make it. And I request suggestions from the members if they have or they have any comment or something to talk about. We have time to discuss.
And suggestions are welcome not only from Lucknow surgeons, people who are from outside Lucknow, you're most welcome to come and join. This is not by any means to exclude you. And more the merrier. We'll be very happy having you over. Any suggestions? Any volunteer for the next meeting of Lucknow Endocrine and Breast Surgery Club? Oh, Sabha has volunteered to hold that. Good. So would that be your birthday party? Please.
Yeah, good evening. So nice to see so many young people, especially our alumni. When I was approached to join this occasion and so-called launch or something, whatever it is, I took some time to say yes. And Pooja contacted me earlier, Dr. Gaurav contacted me, and then Pooja contacted me. I just wanted to know, actually, I told them I just want to know what is the purpose. What I understand is, in this such kind of clubs, or the local city chapters, whatever, city groups, in my almost 34 years here, at least earlier part, I know there are one club, I know very strong club, I don't want to take the name, steered by a very senior person in this city, Lucknow city chapter. So I don't want to mix up these words, chapter, club, all it's same actually. You are a group of people who intend to organize such get-together for benefit of the young people, for education mostly actually. So I found certain observations which I like to share for you people also to. My first question to you is, how to ensure sustainability? That's the first thing I asked Dr. Pooja. Second thing I said that never ever think about organizing events in hotels. Though we are very much supported by the pharma companies, equipment companies, let us not make it appear as sponsored by somebody in a hotel, because that academic ecosystem vanishes once you go to the hotel. And it is a third thing, it is a mixed population. It is from the academic institutes, also from corporate world, from private practitioners. So you have to very difficult to maintain punctuality. And you know that what happens to the hotel events. I've never gone to one event, that's my personal choice. But you find the test starts at 10 o'clock with a drink. So my only honest request to all of you is, objective is to get together young people. Whoever has joined yesterday as MCS candidate, or whoever joined in the practice after completing MCS, get together. Our main purpose is, in a large organization like Indian Association of Endocrine Surgeons, it's very difficult to get group all over the country. Such chapters, small groups will make opportunity for bringing young people, telling them about this particular specialty and hand-holding them. Many people get depressed initially, know what it is. So that is one thing I think you should know. That's the main objective. It should be involvement of the young people. It's not that we all senior people get together and present a case. I think my only suggestion is how to make it sustainable, develop mechanism. It's a club. It's not a chapter of any conference societies. A club is consist of members, and member has to contribute to make it a club actually. Even if you give them a samosa or a tea, I told Pooja the same thing. Call them to your institutes. Even one of our alumni is in Hind Medical College. Let him go there. All of us go there and we'll have a cup of tea and samosa. I think we're happy about that. Our main objective is not to eat and drink. Main objective is to education, training, and social interaction with youngsters. Take them along with you. So these are my personal views. You develop your things that you want to develop. So that's the thing actually I wanted to express to you people. Make it sustainable. Make it the young people worthy to attend these things. Many times what happens, somebody may not have a vehicle also because it's long distance. Because I have experience in my young days. I don't have a vehicle to go. Now also many people may not be having vehicle. They may be having a scooter. They cannot go far places. So how can you take them along with you? So everything surrounds whatever I say to young people. Because endocrine surgery, to ask somebody ask a question, I think, or training Google form mentioned that how to make it more attractive, how to make it more kind of thing. I mean, that starts with taking along your young people, hand-holding them. They're more important. They should feel proud of you. And Lucknow in particular, Madras, Lucknow, all these places, you have many endocrine surgeons together. So those are the regions where they can join, and other people can join virtually to these groups. Just joining is not a problem nowadays. Like in South India, they make a club. Then people from Vellore and Salem and other places, whoever are dispersed in different places, that gives a different flavor because no North Indians will go there. The South Indians will get together in this thing. So it's entirely up to you how motivate other people to do it, how you want to do it. Ultimately, result will say actually. My only prayer is it should not stop. It should continue. Instead of 2 months, you can think of every month also. That's not a problem at all. Thank you.
Thank you, sir. Anybody else has any suggestions or any thoughts to share? And Dr. Marathu Bandian, would you like to say something?
Good evening, all of you. First of all, I'm so happy to see this progress in the endocrine surgery department. So by forming a separate club, I don't know whether the Lucknow is having surgeons society or not, but endocrine is department is developing one club, especially for endocrine surgery and breast. I'm so happy. Definitely this will be a big tool to share your knowledge because you got 3 or 4 medical colleges in Lucknow itself. So all the people can become the member of this. As Sir suggested, don't worry about the funding at all. So you have to contribute and make it viable one. So hope this club will do its best, not only to the members, but also for the society. Thank you. Thank you for the opportunity given to me.
Thank you, sir, for your kind words and words of wisdom. Also, I've noted both the points and the points, sir, and you have raised. So, any other concerns? Any people want to say anything? Okay, sir. So we wrap up. So we have people from Raebareli and from Safai. Ganesh is here, and Nitesh also is part of this group. So we have people nearby Lucknow also. So that way. So I think it's a good beginning. We have launched it in this PGES, and we had done one part of the breast CME also. So in next 2 months, we will plan the next meeting. And the Sabha has volunteered, so we will plan it first in SCPGI. So that way we will keep making it move forward. Thank you all. And we move for the next session now.
So we now begin the multidisciplinary breast cancer management symposium, which will be coordinated by Professor Gaurav Agarwal, Head of Department Endocrine Surgery, SGPJ. This session will include 4 case-based discussions covering early, locally advanced and metastatic breast cancer. Starting with the early breast cancer, for our first case scenario, I invite the chairpersons, Dr. Ankur Verma, HOD and Associate Professor, Department of Surgical Oncology, Kalyan Singh Super Specialty Institute, Dr. Sharad Singh, Radiation Oncologist, Kalyan Singh Super Specialty Institute, Lucknow. Sir, please come to the dais. I also invite to the stage the panelist, Dr. Goonj Johari, consultant plastic breast surgery, Manchester, Lucknow, UK. Dr. Gitika Nanda, senior endocrine surgeon and breast surgeon, KGMU, Lucknow. Dr. Dilip, senior consultant breast and endocrine surgeon, Tata Memorial Hospital, Mumbai. Dr. Pooja Ramakant, Senior Consultant, Endocrine and Breast Surgeon, KGMU, Lucknow. Dr. Prateek Mehrotra, Senior Endocrine Surgeon and Breast Surgeon, HIMS, Barabanki. Dr. Asmita Arya, Senior Interventional and Endocrine Radiologist, SGPGI, Lucknow. Professor Vinita Agarwal, Senior Endocrine Pathologist, SGPGI, Lucknow. I also invite the presenter for the session today, Dr. Abhishek Krishna, Consultant endocrine surgeon, SGPJ, Lucknow. Over to you. Over to you, sir.
Shall we? Good evening, everyone. Shall we? Please switch on the presentation. The presentation. Yeah. Good evening, everyone. So I will be discussing the first case for the management of early breast cancer. So I welcome all my esteemed panelists and our chairperson. So let us start. So anyone would like to take this question? Which patients would you consider as an early breast cancer patients? Like Dr. Dilip, which patients would you consider? Yeah. So early breast cancer includes DCIS and stage 1, 2A, 2B cancers. So we all know that management of breast cancer is a multidisciplinary, we require a multidisciplinary team, which consists of various sister departments to provide appropriate care for the patients. So starting with the case, so we have a 52-year-old postmenopausal lady who presented to us with a right breast lump for 1 week of duration. She didn't have any other symptoms, no comorbidities, and there was no significant family history. So my first question for Geetika ma'am, what would you like to do next, ma'am? After?
So it's a 52-year-old postmenopausal lady with recent onset breast lump. Certainly, after history and clinical examination, a mammo is the first thing in my mind,
Yeah.
followed by FNAC or biopsy, whatever, depending on the report.
So we would do a triple assessment, which consists of a clinical examination and imaging and a pathological diagnosis. So on clinical examination, she has a right breast lump. Please don't change from there. We have a right breast lump of size 2 into 2 centimeter in the lower outer quadrant, around 3 centimeter from NSE, which is hard non-tender, with no skin or chest wall involvement. There's also no clinically palpable axillary or supraclavicular lymph node. And also the left breast and axilla are within normal limits. So at this stage, Dr. Gunj, what would you like to do next after clinical examination?
Core biopsy of the breast lump?
Uh,
Think you've provided us the mammo and ultrasound.
no,
Is that the
before that, yeah.
Okay.
So would you like to do just mammography alone or mammography along with ultrasound?
So where I work at, by convention, they do both.
Yeah.
So that's my practice, but it can differ from place to place.
Okay. So Dr. Asmita is the radiologist. So I want to ask her, ma'am, what would you suggest? Whether mammography alone or both?
As a radiologist, I will suggest for mammography and ultrasound both, because these both are complementary.
Yeah.
On mammography and ultrasound, it will always increase or higher chances of detection of the lesions and better characterizations.
Yeah. So both endocrine surgeon, breast surgeon, as well as the radiologist are on the same page. So this is a Cochrane review, which showed that mammography in combination with breast ultrasonography has a better
outcome, and they are both complementary to each other. So we should use a combination of ultrasound as well as mammography. So this is the mammography. Dr. Smita, can you please go through this?
Yes, here you can see an irregular hyperdense mass lesion
Yes.
with irregular, and some part is also showing microlobulation. Although this having a microcalcification, but here we are not able to see it. It is located in the central and outer quadrant. So radiologically, as this is irregular with spiculated margins, we are providing at least PIRADS 4. And apart from that, we can say here just for learning purpose, here we are seeing only spiculated margins. So we will give as a PIRADS 4 B, not C.
Okay.
Apart from that, we can see a well-defined rounded, basically oval lesions in the axilla also. So most probably this could be a lymph node.
Yeah. Okay. So we got a mammography now. Dr. Dilip, what you would like to do next? FNAC, co-biopsy, surgical excision biopsy, vacuum-assisted biopsy. What would you prefer?
You said 2 into 2 centimeter palpable lump, no cystic component. So I would do a palpation guided core needle biopsy in
Needle
a
biopsy.
financial constrained setting. Otherwise, a image guided biopsy of the more suspicious. Yeah.
Yeah. So what should be the sequence? Like we should do biopsy first or imaging first? What should be does the sequence matter really?
Yes, it does make a difference. We want to avoid any artifacts like hematoma coming in and other inflammation setting in, ecchymosis coming in. So all those things we want to avoid. So we would like to do a mammography first, followed by an ultrasound, followed by a core needle biopsy.
So imaging first, followed by a core needle biopsy. Okay. So yeah, this is a review which shows us the sensitivity and specificity on comparison of FNAC versus core needle biopsy. It consists of 12 articles and it was a pooled analysis. The sensitivity of core needle biopsy was 87% versus 74% of FNAC. Before moving on to the next question, I would like to ask Vinita ma'am. Ma'am, is it like which sample would you prefer as the initial sample, or FNAC or a core needle biopsy specimen? And the second part to this question is, can ISC status change? Like if it's a big lesion, can the ISC status be different if we take core biopsy from different part of the same lesion?
Okay. So regarding the first question regarding FNAC versus core biopsy, it depends upon the clinician who decides whether you want an FNAC or a biopsy. If you are not sure if it is a malignancy, then you may go in for a FNAC. But otherwise, as a pathologist, our sensitivity and specificity is very high for both of these procedures.
Okay.
So, of course, a core needle biopsy will be the first choice if you are certain that this is malignancy, because you can give the immunohistochemistry, you can do the immunohistochemistry also, which is reliable. Regarding your second question, either you do an FNAC or a core needle biopsy, both have their errors that they are sampling only a part of the tumor.
Yes.
So that error is generally there, but as far as the tumor is concerned, most of the times the whole of the tumor will generally be either hormone positive, HER2 negative, or TNBC type. We generally do not have very, very heterogeneous areas. You in the same tumor, you may have some areas which are a light staining, a dark staining, but overall, a lot of heterogeneity is not seen. Because when you compare it to mastectomy specimens also, you do not see so much of heterogeneity, some degree of heterogeneity, and that is why you have those scoring systems.
Okay, have you come across like pre-NACT, the IHC something else, and after NACT, the IHC changes? Have you come across any
Yes,
case?
it happens. It does happen that
Okay.
you may have change in the hormone status and other parameters, but we are not routinely doing in post-NACT specimens the receptor status and the HER2 and Ki67 in all of the cases. So we cannot give you a percentage, but that is reported in literature. There is a change. What is the clinical implication? It depends upon the clinicians if they want to get it repeated to look for more treatment options.
Okay, thank you. Pooja, would you prefer an image-guided biopsy or a palpation-guided biopsy? as Dr. Dilip had mentioned, he would go for a palpation guided biopsy.
Yeah,
So is
if the
there
lump
any?
is well palpable
Yeah.
and clear cut like this case, so I'll go for palpation. Only if
Is
it's a very small lesion or we have doubt in palpation or it's very deep seated,
Okay.
then we may go with image guided.
So palpation guided biopsy. So this is a paper which was published from All India Institute of Medical Sciences. Although the cohort of patients was very small, but they concluded that the image guided biopsy is superior to palpation guided core-needle biopsy. So we have a diagnosis of CA right breast, clinical stage T2 N0 M0, IDC grade 2, hormone receptor positive, luminal A. So Dr. Asmita, any further imaging? Would you advise for any further imaging? MRI or something? Would you like to do? Would you like us to get that?
Yes, in every cases MR is not indicated, but like certain cases, if patient is young, dense breast with family history, definitely we should go for the MR. Especially we are suspecting in contralateral breast. So MR is suggested in particular cases, not in every pre-op evaluation, MR should be done.
Dr. Dilip, would you like to do MRI in this case? Dr. Geetika ma'am wants to say something.
Yeah, I just want to comment because this breast doesn't seem to be very dense.
Yes.
Probably MR is something that we would not require as a surgeon.
Yeah, right. Dr. Dilip, you conquer? No? No MRI. No MRI. Yeah, that's what you conquer that we do not require.
As long as
Yeah.
we don't have any clinical or radiological suspicion of another lesion in the same breast,
Yes.
I wouldn't advise an MRI.
Yes, yes. So this meta-analysis
Un-
also suggested this. Yeah.
Unless it was an ILC or a pregnant lady who is okay to terminating the pregnancy, so then probably I would have asked for an MRI. Otherwise, no.
No MRI. Yeah. So this meta-analysis also showed that preoperative MRI is associated with increased risk of, odds of receiving ipsilateral mastectomy and contralateral prophylactic mastectomy. So preoperative MRI is not warranted routinely in patients who can be adequately analyzed. However, as Geetika ma'am also pointed out, they may be valuable in women with dense breasts or with lobulocarcinoma or with a positive family history. Yeah. So patient has a clinical N0 axilla. Gunj ma'am, how would you assess, what would you do for assessment of axillary lymph node routinely?
Usually a baseline ultrasound,
Ultrasound?
same time as you're scanning the breast.
Okay.
Will
If
come-
ultrasound shows a lymph node, would you go for a biopsy, guided biopsy, FNAC? Is it essential?
If it's showing a maintained fatty hilum with no cortical thickening, then no.
Not
Or
required?
even if the cortical thickness is within the normal limits, which differs from center to center.
So if imaging is not suspicious, we should not do any FNA?
No.
Geetika ma'am, you want to, you
No,
differ?
I think because for this particular patient, the lymph node was quite round.
Yeah.
Isn't it? So it was kind of suspicious. And even if clinically there's N0 axilla, but still like to get the FNA,
FNA?
prove
FNA
that
done?
it is not involved and then go ahead.
Dr. Dilip, would you like to get an FNA in all the cases in which ultrasound shows?
Here I want to just let you know ki in the breast, definitely core needle biopsy has a better outcome as
Okay.
compared to the FNAC. But in the axilla, it's still FNAC is always a option and it is a safer one to do FNAC if lymph node is suspicious rather than the biopsy.
Yeah.
Because it is a easy and everywhere available, and because in the axilla we are having a vital structure and lymph nodes are sometimes relatively quite small to target on the core
Core
needle
needle.
biopsy.
So we should go for
Yes,
an
FNAC, definitely.
USG guided FNAC. Okay. So NCCN also suggests the same thing. Yeah. Anyone would like to comment? Pooja?
I think the same, that
Yeah.
only if we have doubt imaging wise or
Yeah.
clinically feel it.
So if the axillary lymph node is suspicious, then we should go for a guided FNA. Okay. So NCCN also suggests the same thing. Okay. Pooja, any role of genetic testing?
I think not in this patient. She's not triple negative and she's 52 years of age and no
Okay.
family history as such, you said.
Okay. Dr. Dilip, what is your opinion on this?
So recent guidelines says any breast cancer less than 60 years or any TNBC. we have a policy that we only send TNBCs who are less than 60, and if they do not have a strong family history,
Yeah.
then we do not refer them for a genetic counseling. But going by the otherwise, we would be saturating our resources for genetic counseling and testing. So that's the policy we follow. Otherwise, not in all patients. Those who do not have a strong family history, not a TNBC, we can still avoid.
So would you like to comment on this?
Initially, the age was 40 years, then it was raised to 50 years
Okay.
subsequently. In all the guidelines, they have sold less than 50 years or a history of cancer in a family, in a first degree relatives, like breast, ovarian, multiple cancers. And
Less than 50 years.
Yes.
Okay. So this is the consensus guidelines on genetic testing for hereditary breast cancer. They say that it should be, as everyone agrees, if a patient has a personal history of breast cancer or a family history of breast cancer, we should go for a genetic testing. Also, NCCN guideline says that age less than 50 years or any of the following indications, like most of our panelists have pointed out, triple negative, multiple breast, primary breast cancers, lobular breast cancers, male breast cancer, family history, positive family history. These are all cases we should go for a genetic testing. Yeah. Anyone would like to do a metastatic workup in this patient? Metastatic workup, any role of FDG PET CT? Anyone would like to do that? In this patient, I am talking about this patient. No one?
I wouldn't know.
Sir, you also have no metastatic workup?
No, I wouldn't even FNA the note, so I'm like.
Yeah, so that is exactly. So these are the ESMO guidelines, which suggest that metastatic workup should be done in cases of patients who have large tumors, that is more than 5 centimeters, who have either an aggressive biology with the clinical signs and symptoms or laboratory value suggesting a metastasis. And FDG PET, in that case, CT scan should be done, and FDG PET should only be used in case instead of CT and scintigraphy in high risk patients when conventional methods are inconclusive. So surgery, as we are discussing a primary case of early breast cancer who was posted with primary surgery. So surgery is the mainstay of the multidisciplinary treatment, and we address both the breast as well as the axilla. So, Dr. Dilip, is breast conservation desirable in all patients with early breast cancer?
Yeah, I would say yes, if it is conservable. BCS feasible, do BCS.
Okay. What about mastectomy? Would you advise mastectomy in any patient?
Not in the era
If
where
the patient is
we are
unwilling?
post NSABP B06 and all of it, Milan, Danish trials, all of them have shown equivalent results.
Yeah.
And now recent reports are saying that even BCS is favorable than a mastectomy. So I wouldn't.
Yes. Anyone? Sir.
I suppose it's the patient's choice only.
Yeah, it's the patient's choice. That's right. If the patient is unwilling, then obviously we can't. If we are not able to, ma'am, please.
I'm not against mastectomy at all. And it also depends on the kind of patients you are dealing to.
Yeah.
There'll be certain set who are not going to come to your follow-ups. Why would you just do a BCS and leave them alone?
Okay.
Can I just add,
Yeah,
for early breast cancer and for a cancer of this size and a negative axilla, I think BCS should be the standard of care. But
In
you
this
can
patient,
often-
BCS, yes.
Yeah.
I'm talking about early breast cancer. If it's, keep this patient up aside.
Okay.
Is breast conservation desirable in all early breast cancers?
I don't think anything in medicine we can say it
Yeah.
applies to also.
Okay.
Never is never right.
The second
Always
question, you
there's
can take it. Is primary surgery the norm in all early breast cancers?
Sorry, say that
Is primary surgery the norm in all early breast cancers?
Depends
Primary
on the-
surgery.
yeah,
When
depends
would you go for a NAST?
Depends on the IHC.
Yeah. What are the indications of NAST? That's what I'm asking. NAST, neoadjuvant systemic therapy. When would you advise in case of early breast cancer?
So a triple negative.
Triple negative?
More than 2 centimeters or a HER2 positive.
HER2 positive, triple negative,
N1 axilla.
large N1 axilla, and luminal B patients.
Yeah, or a genetic.
Yes, sir.
High risk genetic mutation.
Genetic mutation.
Which needs reducing massive.
Yes. Yes. Agree. Point well taken, ma'am. Thank you. Yeah.
But you know, if there is an old patient, maybe 70 years old,
Yeah.
and they don't want any radiotherapy post-operative, then will you like to give her breast conservation or mastectomy?
Ma'am, if she is more than 65, falls under prime 2 or CalGB trial, so we can still omit a radiotherapy and still can do a BCS.
But
So great, the way,
therapy, is it advisable?
yeah, it is advisable.
Ma'am, that
Small
is
grade 1, grade 2 tumors, T1, T2, node negative, low Ki67, strong ERPR positive, were fitting well into the prime 2 criteria or the CalGB criteria.
Yeah.
We can still do away with radiotherapy.
Yeah, that is my second case actually. Elderly patient with early breast cancer. So if time permits, we can discuss that.
And another bed.
Yeah, for elderly, it's more conservative approach.
Yes.
We plan the simplest treatment for
Uh,
them and
PET CT also. Previously, PET CT was actually not done because mostly the cost was much higher. But now PET CT cost has become much less.
and still it is
most of the
25,000 in the
places-
private sector and 12,000 or 10,000 in the
10,000.
government.
But if you are doing a CT abdomen, chest, or whatever, it also costs the same.
Ma'am, I would like to differ here.
Yeah.
We have a T2N0 patient where the chance of metastasis is only about 3%. I think rather than first, the science should triumph rather than the cost constraints. So the science itself says it's only about 3 to 4% rate of metastasis, where we cannot be going around and doing PETs for all these patients.
Doing then metastatic. Why are you doing the metastatic workup?
We are not
also?
doing, ma'am.
Yeah, then
We are
then
not doing.
fine.
Dr. Shashi wants to say something.
I wanted to add for what ma'am asked.
Yeah.
So in elderly, BCS feasible, not feasible, yes, you can go ahead. In fact, what radiation therapy, what ma'am was pointing out, we have 25 gray in 5 fractions. That is equally effective for the standard 42.6 grays. So that is enough in elderly especially.
Okay.
5 days of radiation should not be an issue.
Even in elderlies, we can avoid radiation post BCS.
Yes, ma'am.
We
That
are
is
making
also
it
an
more
option.
conservative for
If
them.
you want to give radiation, that is another option.
Only thing is somebody's got left-sided and has comorbidity, so that adds to the risks.
We have ma'am deep inspiratory breath hold, DIBH techniques are there.
That is there, but as per the radiation oncologist, they are not very comfortable. And somebody is comorbid, diabetic, a heart patient, a CAD, maybe they would not like on the left side.
Okay, okay, okay. Ma'am, next surgical plan. Pooja, ma'am. This patient, 22 centimeter lumps, low outer quadrant, 7 to 8 o'clock, 3 centimeter for MNSE and axilla negative. What surgical plan would you?
So for lower outer quadrants, if you are planning oncoplasty, then we can go for LICAP flap.
Like a flap. Anything else? Geetika ma'am, Dilip, Dr. Gunj, anything else? Any other?
The resection volume is actually very small. We don't even need any perforated.
Can we close level 1 can level 1 oncoplasty be done in this case?
Yeah, I would give both options.
Both options?
Risks of both.
Can we decide on the table what to do? Yeah.
No, I wouldn't decide on table. You
Yes.
need to consent the patient, so you need to go with a plan.
Okay.
I would make the decision before.
So as Pooja ma'am told, we also went ahead with LICAP flap reconstruction and NSC repositioning for this patient, along with SLNB and a frozen section biopsy. So the wide local excision of the lump was done using an elliptical incision, and SLNB was also done. All margins were clear. It was a PT2 and 0 disease, 3 into 3 into 2 centimeters. Vinita ma'am, what would you suggest for what are your suggestions about intra-op margin assessment during BCS?
Yeah, I think it is a norm. You
Yeah.
do an intra-op margin assessment. So for as a pathologist, we generally have the markings which are there, which side marks what the suture is marked in the specimen, and we do a frozen section. Do you have any specific question related to the frozen?
The frozen section, yes. Before that, anyone would like to do the specimen mammography of the specimen, the mammography or radiography of the specimen?
Yes, we should do mammography in this case also.
Yeah.
That will help us to define the margins and we can correlate with the frozen section also.
Okay.
Is-
Can we do away with frozen section? Is it mandatory? If it's
Actually,
not available?
what we practice at our institute is we send the specimen mammo, but most of the time we don't understand what is there besides that opacity. We are not able to make out the margins. So this is the practical problem because now the parenchyma is not all around, it's all compressed. So when you actually do the mammo, you can only see that opacity, you can't see any margin all around. I don't know, ma'am, you have to tell me how to do it. I'll ask you.
No,
So what we do is we do the specimen ultrasound. I think
yes,
that works
specimen
better for
ultrasound
us.
is okay.
And
Even in mammography, I guess the margins are clearly
you
visible.
make
There is a standard, ma'am, for that specimen mammo. Thing is when you mark as the specimen, so you place clips, okay, so like short superior, long lateral, and so similarly you
you
place.
see the normal margin all around.
Yes,
I
if
have
you
never
are-
been able to see anything like that.
that is the mammogram issue, ma'am, or reading a mammogram issue. Otherwise, we usually see. We have a study at our own center. We have done this, and it is sufficiently equally at par with frozen, but it is not still the gold standard. Not the gold standard. That's what I want to say. Yes, we can.
For a specimen mammo, there is no need to, we have to compress, but that compression should not be such that it will distort the specimen. So here we are doing the specimen mammo, and I think we are defining the all margins. I think sir will better say.
So for this particular case, because it's a well palpable lesion and you're fairly confident about your margins before going in, it might seem that specimen mammogram is not providing additional information.
Yeah.
But when it comes to cancers which have microcalcifications, or if you're operating on non-palpable lesions, or if it's a wire-guided local excision, there is huge value of doing a specimen mammogram in those situations. Of course, here also,
Yeah.
but that is where you get the maximum benefit. of doing
Especially in post neoadjuvant chemotherapy
Yes,
patient
in-
where we have the clips.
when we have a clip.
Yeah.
And hopefully we'll get mag seeds here soon. And then-
Dr. Vishwak. Ma'am,
To practice what we follow is we do a preoperative ultrasound.
Yes.
We look at the lesion, spiculae, which are extending from here and there. And we make sure that when the post-operative specimen, it is all there with the margin all around.
Okay. Dr.
So I go with Dr. Chaitra. There's no, I don't want to add finances to the patient by adding up a specimen radiography in this case. Of course, if frozen section is available, I'll send the specimen for frozen section. If frozen section is not available, we'll send the specimen. We'll take a cavity on all the four sides. We'll take just cavity margins. We'll excise and we'll send it entire for the final histopathological examination.
Okay. Yeah.
I think it just shows that there's no right answer. There's no right or wrong.
Exactly.
Just
That's what I wanted to
God.
that's what should come out. Like we can do BCS even without if frozen section is
Frozen is
not
not
available. Although we tend to take a wider margin, we end up excising a wider area. We don't have a frozen section. That's what I feel.
So we don't have frozen section. We don't do
Okay.
frozen section. All we do is, and we do wire guided. So we don't even have Maxseed. In Manchester, we had Maxseed, but in Southampton, where I'm working now, we don't have Maxseed yet. But you are just guided by the size that the imaging tells you. You're guided by the wire and you do an X-ray, and we don't need to compress the tissue. It's an open
Yeah.
X-ray machine. It's a small
X-ray radiography,
part.
right?
So it's a
Yeah.
flexitron. You just put the specimen and you get a picture. So you can see the tissue around it. And that helps you, but you're basically guided by where the wire is, how big the lesion was. And if you can't feel anything clinically, like Dr. Chaitra said, then you're guided by that as well. And if you're in doubt or if the calcification is cutting off, you just take shaves.
Yeah.
Yeah, and you can bisect and see.
Yeah, okay. So this is a meta-analysis showing the accuracy of frozen section. Lack of time, I move out. So this patient obviously received, yeah.
I think should mention the paper presented by Swati in
Yeah.
Vienna, which actually said intraoperative margin assessment is a valuable tool whenever it is available.
Available, yes.
So in going by that, yes, there are two schools of thought. One says don't do anything. The other says it's better we have it.
So there's no right answer.
Yes.
Either way, it works. Whatever works for you, whatever works for your institute, whatever works for you. Yeah.
Abhishek, can I interrupt? You said the 2 centimeter size, by radiological imaging.
Yeah.
I just want to get from the panelists, like patient is more than 50 years, 2 centimeter lesion, clinically node negative, no suspicious lymph node, hormone receptor positive. Would you consider omitting sentinel lymph node biopsy in this case? She is 59.
Actually, if she
Yeah.
was more elderly, then
The
we would
ASCO
have
guideline
restricted.
says
Yeah,
more than
ASCO
50.
says, yes.
ASCO guideline says more than 50, postmenopausal, hormone receptor positive, 2 centimeter or less than that. And clinically, node is not suspicious, even proven by FNAC or biopsy. So, as per the ASCO guideline, in SEMA and sound trial, this patient falls under the category where we can omit. What's your take on that?
Yeah, you are right. Some people miss now. People are going forward for no axillary surgery, even no sentinel node also, for select group of patients.
I have a very clear answer. In my defense, unless it is a nice guidance, we can't do it. So even though it's there in ASCO, we wouldn't accept it. And I was saying this outside when I was talking to seniors that UK and NHS and NICE is very slow to change and very slow to adapt. So it'll happen in
So maybe
5 or
then
10 years.
when we have the next
only
panel
thing is-
discussion that we can.
Yeah.
Possible.
Even though this patient falls under this category, based on the ASCO guideline, she may be an eligible candidate. But the ASCO guideline, it pushes us to perform the oncotype DX to consider or to plan for the adjuvant systemic therapy. If the patient is affordable to undergo an oncotype DX, then only we could able to consider omitting and sentinel lymph node biopsy in such a scenario.
Actually, I wanted to discuss that in the second case, but unfortunately, I don't have time. It's good you brought it up here. So
The important is A in the ASCO, so it's American, and the disease does differ differently in your ethnicity and race. So even in UK, patients with Asian descent, Indian patients, Pakistani patients have more severe disease presentation, even at a stage comparison level. So for a 52 otherwise fit lady, I would at least do a sentinel node. If she's 70 and above or 60 and above and has comorbidities and is not, I would discuss the options. It's very collaborative, it's very open discussion. But maybe for a 70-year-old, I would omit it or give her the option. But I would say the standard of care is do a sentinel.
yeah. Okay, so the last question. Time is already up. So last question. Dr. Dilip, yes, you have the mic, please. I can't help it. You have the mic. Yeah, you have the question in front of you. Would you like to go adjuvant therapy, chemotherapy for these patients?
No, sir.
In this
I just wanted to see LVI in her
How would you decide?
Yes, oncotype DX we have not validated in our population,
Yes.
so it's out of question. Second
Any tool, predict tool or something?
predict tool was there, but
Yeah.
it is not being presently used or it is
Okay.
not validated. There was
Yeah.
one study by Dr. Neeta Nair to see if it is validated in our setting. No, that also failed to get
Okay.
validated in our population. So the usual thing which we use is strong ERPR positivity, no LVI, no PNI, node negative, K67 less than
Yeah,
10%.
this patient had all these, whatever you are telling, she
Yeah,
had
but
all this.
so in that sense, I would
So we
definitely
can do away
omit
with
yes,
adjuvant chemotherapy,
yes,
right?
and if she is postmenopausal,
Postmenopausal.
52 is in that borderline zone
So
where we
even
cannot.
project says the same thing, will have just 1% additional benefit.
Yes.
If we give a adjuvant chemotherapy. So although I wanted to discuss the next case, but since the time is up, thank you.
There's a role for can assist also. So can assist also to decide to avoid.
I want to take
chemotherapy.
that
Yeah, yeah.
that thing
Since
up in the
the-
next case. Yeah, but
Just wrapping.
unfortunately, we don't have time. Thank you for the panelists. Thank you so much, the chairpersons. Thank you.
Dr. Abhishek, that was a very nice.
For our next case scenario, I would like to call to the dais the chairpersons, Dr. Punita Lal, Professor and Head Department of Radiation Oncology at SGPGIMS Lucknow, and Dr. Abhishek Pathak, Consultant Medical Oncology at Apollo Medics Hospital, Lucknow. I would also like to call on the stage the panelists, Dr. Vishwak Chantar, Chief Breast Oncosurgery and Unit Head at Rajiv Gandhi Cancer Institute and Research Center, Delhi. Dr. Kushagra Gaurav, Associate Professor, Department of General Surgery at KGMU, Lucknow. Dr. Kumari Sunaina, Assistant Professor, Department of General Surgery at ASMC, Amethi. Dr. Chaitra Suthineni, Associate Professor, Oncoplastic and Reconstruction Breast Surgery and Endocrine Surgery at Pink Breast Cancer Center, Thyroid and Parathyroid Center. Dr. Neha Nigam, Additional Professor, Department of Pathology at SGPGIMS, Lucknow. Dr. Puneet Prakash, Consultant, Department of Surgical Oncology at at KGMU. Dr. Pramod Gupta, Associate Professor at Department of Radiotherapy. And Dr. Siddharth, I already called that name. And yes, that's it. I would like to call the presenter for the session, Dr. Pushkar Sharma, to the stage. Sir is Assistant Professor in the Endocrine and Breast Surgery Unit, CMC Vellore. Over to you, sir.
Good evening, everyone. I extend a warm welcome to all the panelists. Accept my second round of greetings from Vellore. So I'll move on with my first case. I have two cases to present today, and I will also like to engage with the audience using a poll. So I have my first case is a 48-year-old lady who presented with a left breast lump for a duration of 2 months and history of left scapular pain since 2 months. There's no significant family history. She's P3L3 postmenopausal lady with no known comorbidities. On examination, she had a 1.5 centimeter hard lump in lower outer quadrant with no skin or muscle fixity and no palpable axillary node. Her opposite breast was within normal limits. We went ahead and did a mammography. Dr. Vishwak, would you help us interpret this mammogram?
Sure. So it's the mammography, it shows the left breast and craniocaudal and M-elbow view. And the breast density, she is predominantly a fatty breast with a scattered areas of fibroglandular density, basically a type B breast density. And there is a smaller hyperdense lesion with obscured shadows on obscured borders on MLV view and irregular borders as well with adjacent architectural distortion. And I couldn't see any axillary lymph node on the axilla on the MLV view. The ultrasound correlated, it shows a hypoechoic lesion with microlobulated margins.
Thank you. So that's a 1.7 centimeter primary with no significant axillary nodes. I'd like to engage with the audience. You can just scan that QR and you'd see this question show up. A part of this has already been discussed. Meanwhile, I'll ask my panelist, ma'am, would you like to do an MRI in this case?
In this case, I would not like to go for an MRI breast. As sir already pointed out, it is a type B breast, not dense fatty breast, and the mammographic findings are quite conclusive. There is no mention of any inconclusive finding, no significant family history. So in this case, I would not like to go for MRI breast.
Sure, ma'am. I'll just wait for the answers. What about, I would like to ask the radiation oncologist on the panel. When you select cases for partial breast radiation, does MRI stand a role, and also for screening the internal mammary nodes? Are you happy when your surgeon has ordered an MRI?
It is case to case basis. Routinely, we don't advise for MRI. So it's not like every case would rarely younger patient, dense breast. In those cases only, we ask for MRI.
Okay, thank you, sir.
In this particular case, I would like to note that on the ultrasound scan, there are tissue defects into the lesion, and there is another smaller hypoechoic area that is detached from the primary lesion. So probably taking a closer look would not be harmful, not necessarily by an MRI scan, but even a relook ultrasound scan, if you're planning BCS for this patient, is probably advisable. And CEDM can be done very quickly, quicker than an MRI, cheaper than an MRI. So if you're doing a contrast-based imaging, and if this is an IDC, then CEDM is as good as or even superior than an MRI, if
Sure.
you're looking to do something.
Thank you for that input, ma'am.
And you asked about the internal mammary node to find out so does it require an MRI? So this tumor is in the outer quadrant. So the tumor location, if it is in the central or on the inner quadrant, or if multiple clinically positive axillary lymph nodes, they direct the possibility, the likelihood of the internal mammary lymph node to be involved. So in this case, it's a tumor is in the outer quadrant and clinically no negative axilla. The likelihood of internal mammary node involvement is less.
Thank you. So the evidence on pre-op MRI, as discussed previously, there are median 16% chances that you will detect an additional lesion. 2 out of these 3 will be malignant, and this does increase mastectomy rates and wide local to an extensive wide local. We also pick up contralateral lesions in about 3 to 5%, but with a very less positive predictive value. Overall outcomes with BCS margin positivity does not change. However, when you talk about reoperation rates, the retrospective studies do show a decreased reoperative rates when breast MRI is performed. However, the prospective studies, apart from only one study here, no other shows reoperation rates are reduced. In terms of long-term outcomes, we believe that even with these additional lesions that are present, radiation and our adjuvant treatment would take care of them. But contralateral incidence of malignancy does increase in patients who did not have a preoperative MR. So it is highly accurate, but there are false positives. So the dictum is you should do an MR only if you have guided biopsy available. And as ma'am rightly pointed out, we did do a contrast enhanced mammography in this patient, and there was a single lesion and there was no lesion in the opposite breast. So we did a core biopsy. Core biopsy showed invasive ductal carcinoma grade 3, ER negative, PR negative, HER2 negative with a MIB1 index of 50 to 60%. Dr. Neha, would you like to tell us more about this grading? How do you standardize it? And also about the ER-PR status?
Okay, so for ER and PR status, immunohistochemistry, we grade it according to the percentage of the tumor cells, positive tumor cells, and the intensity of the staining. So based on the percentage, it is called as a proportion scoring. It is graded as a 0 to 5, and it's scored as 1, 2, 3, 4, 5, in which 1 less than 10%, 10 to 33%, 66%, more than 66%. It is the grading. And for intensity, it is negative, weak, moderate, and strong positivity. So for ER and PR, we combine the score proportion as well as the intensity. It is called as the ordinate scoring. And more than 2 is the positive scoring. So any number of percentage of tumor cells positive, even though weak positivity, is called as the ER-PR positive. And for HER2 new immunohistochemistry, there are 3 components: the percentage of tumor cells, the intensity, as well as the complete membranous or incomplete membranous. So for positive scoring, 3+, the complete membranous, strong intensity in more than 10% of the tumor cells is called as the HER2 positive status.
Thank you, ma'am. I would also like to...
The score 1, would you consider this as HER2 low? Now we have low and ultra low.
Okay, we grade it as a 0, 1+, 2+, and 3+. 3+ is a positive. 2+ is, there are in 1+, this is negative. It is completely negative, or you have the incomplete membranous staining in more than 10% of the tumor cells. It is also called as negative. But in 2+, you require the FISH. And for FISH analysis, the HER2 and CEP17 scoring for more than 2 and HER2 amplification more than 4 scoring is called as the positive status. And those remaining is called as ultra.
Now we are seeing reports. Our pathologists, they are even interpreting low and ultra low as well. They do all these 2+ and score 1. They do molecular level testing. So we are nowadays we are getting low and ultra low report as well. So
from our perspective, from medical oncology, I think this makes a lot of difference.
Yeah.
Because now that we have the newer drugs, TDXD coming up with low and even ultra low, so knowing this value is very, very important for us. Probably next year when we'll be sitting here for an adjuvant, I think it would become at the first line. So right now we have it in second line, but definitely the time is yet, we are almost there.
So my question for the audience is, what metastatic workup would you suggest here? So Dr. Vishwa, what would you like to order?
This patient has got 1.7 centimeter tumor with negative node, and she has a left scapular region pain. So I would start with doing a bone scan, and if the bone scan is positive, then that would direct me to do a CT scan chest and abdomen. If bone scan is negative, then I would go for simple chest X-ray and ultrasound abdomen pelvis.
Sure.
A lot of medical oncologists, sorry to say this, sir, definitely push for PET scan in a triple negative breast cancer. Not for this patient in particular, but if we are generally speaking about PET scan versus doing everything else, for example, in some LABC patient, everything else comes up to the same cost, maybe 2,000 or 3,000 less than doing a PET scan. If we are talking about cost wise, if we are only trying to look for one particular area of interest, then not doing a PET scan is probably what should be done. In this patient, the corporate probably mindset is to do a PET scan because it's triple negative.
In fact, I would like to add that even before doing a bone scan, I'll get an ALP done first. And then I would think about bone scan and PET scan. Actually, I would beg to differ. I would have never asked.
27%.
But in the corporate setup where I'm from, it's this lady at least has scapular pain. There are many EBC patients who are unnecessarily being put through a PET scan just because they're triple negative.
I want to add one thing. Due to logistic reasons, over 30 to 40% of the patients are having Ayushman card in government sector especially. So in PET is free in Ayushman. So if you get for other CT scan, they have to pay. So because of this logistic reason, sometime we do offer PET CT.
And institute to institute, here it's not free for us in PGI. AIMS, I think it's free. They do PET scan for everybody, irrespective of. So it's a practice. Here, our practice here, people who've been trained at SGPGI, we wouldn't do for EBC.
Yes, ma'am.
Free is not the criteria, should not be the criteria. I would agree that we would take the scapular pain with the pinchers. But other than that, I mean, one would like to evaluate, take detailed history or take ALP and then go ahead with the bone scan. But I don't think a PET should be the first.
Right, ma'am. So the incidence of metastatic disease in early breast cancer is low. Stage 1 only 0.2%, stage 2 1.2% as per the literature. And routine F18 whole body PET is not recommended. Though some studies do say T2N0 stages, PET did upgrade the stage and alter management. So we did a bone scan. Bone scan only showed degenerative changes, and there was no scintigraphic evidence of osseous metastasis. Ma'am, would you offer a genetic testing for her?
Yes.
So she's 48 TNBC. Yes. So my question to the panelists is, how do you deal with a VUS mutation? Quite often we do order and there's a lot of anxiety in the patient. What do we tell them and how do you in your management deal with that?
I've seen in certain cases that a patient has come to me with multiple genetic panels done elsewhere. Someone would say a VOS, someone would say something else. So if there is a doubt, and if there is especially family history, I think we should take family history into consideration if a VUS reports comes into place. VUS just means that there is some mutation. We do not know if this is a possible reason for the cancer. But if we are taking history, family history into account, if there's a very strong family history of breast cancer, it is possible that this VUS is actually associated with something. We see a lot of patients who have familial history of breast cancer, strong familial history, but all of their genetic panels, their hereditary breast and ovarian cancer panels, they are negative, not just BRCA, but everything else. But still, we consider those patients as sort of high risk. So we need to take the whole picture into account.
Sure.
So what we do is, like, if the germline BRCA1 and 2, if it comes as VUS, we do MLPA testing on that. So if MLPA testing is also comes as VUS, then we'll repeat the testing after 6 months. We'll recall the patient, we'll repeat the test after 6 months. So this will be repeated every 6 months for 2 years. And until the end of 2 years, if the patient is persistently VUS on MLPA testing, then we can just keep the patient on follow-up. At any point of time, this patient may turn up to be BRCA1 and 2 positive.
But for your primary management, you would consider it as negative.
Yes.
You keep repeating.
For the current management, we'll consider it as insignificant,
Unless, ma'am.
not negative, it insignificant. We would plan as per the negative patients.
Sure. So this lady did turn out to be BRCA1 positive. How would you like to proceed now? The audience can scan the QR and answer.
No, this genetic
No,
test
so this-
probably would have come
yes.
afterwards.
I was going to ask you that. For us, it takes 2 months. The logistics of BRCA are 2 months. So now we know she's BRCA1 positive. But yes, when we took that decision, we did not know that she was BRCA1 positive. For us, the turnaround time is 2 months. And usually depends on how many samples they have. So if you didn't have the BRCA, what would be your strategy? And if you have the BRCA, what would be your strategy?
So because we know that she's TNBC, it is more than 1 centimeter in size. Still EBC, there is this gray area probably, but the tendency is to start neoadjuvant anyway. So if we give her neoadjuvant while we're waiting for the BRCA results to come, if they are positive, we can directly plan for bilateral surgery in her case because it's
Upfront?
not upfront.
Okay, NACT and then wait for BRCA and then plan.
Yeah.
Right.
In patients who are triple negative and whom we are expecting something on genetic testing, that is one way to go. But because it's a 1.7 centimeter, there's no harm.
Any proponents
Yeah.
in panel for upfront surgery?
Triple negative breast cancer, C1C, closer to 2 centimeter, not early C1C. So definitely NACT. No second thoughts.
Yes, as per the guidelines, T1C N0 neoadjuvant chemotherapy has to be given. Practically, see, when we counsel the patient less than 2 centimeter to counsel them to undergo a neoadjuvant chemotherapy, next day patient will not turn back. So she'll get her lumpectomy done elsewhere. So I would counsel the patient. I would tell her the neoadjuvant chemotherapy benefit in achieving a pathological complete response rate after neoadjuvant chemo. I'll give her both the options, and likewise, if at all, if a panelist said neoadjuvant chemo is planned, I would place the clip in the core of the tumor and then I would proceed with the neoadjuvant chemotherapy.
So during counseling, will you also counsel about bilateral mastectomy at the same time? Or
No, now what we are discussing is regardless of BRCA. matlab.
Nice. And meta-analysis came in 2017 by EBCTCG, which says the outcome doesn't make a difference. You do surgery and then do chemo, or do chemo and then do surgery. But as Chaitra madam has rightly pointed out, it would give us that extra bit of time to see if she is BRCA positive. And that is a good thing. And we will also be able to prognosticate the patient. Is it a good TNBC or a bad TNBC? That we will get to know when we give them the NACT. But
Right.
outcome doesn't make a difference.
But what is also to be understood, sir, that at this time, CreateX and Olympia trial results were not out. So when we say outcomes were same, this was without this understanding of adjuvant capecitabine or
Regarding the outcome, I just want to add a point. Sorry. Regarding the outcome, the recent update in SABCS December 2024, the study presented by Dr. Amalina, it shows T1C N0 triple negative. If we start with neoadjuvant chemotherapy, it favors a better overall survival when compared to upfront surgery. That's the recent update as of December 2024 SABCS. So there is a bit of favorable outcome in overall survival. Of course, neoadjuvant chemo, that will give us a time to get the BRCA testing done and to counsel the patient for the plan of surgery later on.
Right.
This scenario, T1C N0 is not a candidate of pembrolizumab as per Keynote 522 trial, I guess. Yeah. So T1C N1, yes, patient is a candidate for pembrolizumab.
right. So what about choice of neoadjuvant therapy, since we've agreed that we'll give her NACT? Sir? Yes. Dr. Siddharth?
TNBC, we start with paclitaxel combination and also add adriamycin in the second time. So usually 4 cycles of paclitaxel weekly, and then we go to 3 weekly AC. So with good pathological response in these patients.
And you said BRCA positive? Yes, carboplatin, platinum-based chemotherapy has to be definitely given.
But doesn't studies show that adding brightness trial said that addition of platinum to non-BRCA showed more benefit than those with BRCA?
If you go with JPAR 6-2 trial and CalGB 4603 trial, the addition of carboplatin has got a higher pathological complete response rate in patients who had received even in non-BRCA as well as in BRCA mutants.
Platinum response in both TNBC versus TNBC with BRCA.
Right. So as we said, we would choose to add a platinum agent. What about immunotherapy?
Sorry, medical oncologist is there.
Sir.
Would you like to comment?
We need to understand that platinum sensitivity. If you have you are giving platinum, then the chances of you and there is a response, then that will give us some idea whether we can add on olaparib also or not. Though in this case we have an advantage of having a BRCA positivity, but a good response to platinum will add our confidence of adding olaparib in the adjuvant setting, because this is a very small tumor. So we also are not fully confident, though there are a lot of trials, but practically speaking, olaparib is not a drug which is very easily tolerated. So, but then if the patient goes into PATCR, I would be more inclined to give olaparib in this particular group of patient. Okay? In the adjuvant setting, definitely.
In spite of PATCR.
Yeah.
What about immunotherapy in this lady, Dr. Siddharth?
This is a very early stage tumor. So I think immunotherapy may have a role, but I would go with chemotherapy only in these cases.
Right. So Dr. Vishwak, SLNB prior to NACT or NACT and then SLNB? What's your take on that?
So clinically means by imaging, and if suspicious by proven by FNAC. If it is negative, I would go ahead with NACT followed by SLN.
If imaging shows no suspicion, would you routinely FNA?
No suspicion, no.
Like this lady, there's a nice
No.
platyhylum seen and
No.
no. Anybody in the panel differs?
Add to it, her cortical thickness was probably just 1 mm or 2 mm over there.
Predominantly
But
fatty
only
node.
thing is, if you're doing SLNB, needs to be dual dual agent and not single, because the practice outside of institutes, it's usually for primary SLNB. Nowadays, they're just doing single agents, but for any post NACT patient, it's mandatory to use two agents so that we have a better identification rate and lower
Right.
false negative rate.
Thank you, ma'am. So the trial in 2023 meta-analysis showed actually better overall survival in adjuvant CT versus NACT group. But I agree with Vishwak, the recent guidelines say T1C did perform better. And PAT-CR and residual cancer burden, as we like to see, is a very important prognostic marker that we need. And carboplatin addition, as per the trial from TMH, did increase the PAT-CR rates. Now in T1C, would you like to de-escalate in terms of not offering anthracyclines? Dr. Siddharth?
Basically, this is a very early stage and if we oppose for PCR. So anthracyclines usually nowadays even fading off. So usually we can avoid patients with anthracycline. But if you are going in a new adjuvant setting, I think we should always give this.
With a very high Ki67, it was I think 50 to 60%. I think we should add anthracycline.
Right, sir. So what would be your surgical plan, ma'am? Would you offer this patient BCS or plan a bilateral mastectomy?
When she's completed her family, she'll probably agree to, we explain it properly, the more beneficial thing would be to do one surgery in one setting. So a simple mastectomy with a sentinel lymph node biopsy and a contralateral prophylactic mastectomy. However, I would like to add that in places where it's available, we'd probably use MACDRES or some other super paramagnetic iron oxide for the contralateral mastectomy. We'll just inject it in there, and it stays back for a while, and later on, if something actually pops up in the contralateral prophylactic mastectomy, it's unlikely in this situation because she is post NACT, and I don't know what the situation of the primary was. I mean, we were talking about NACT. So if we are doing the surgery post NACT, it's unlikely that we'll find something. But in situations where it's possible, I think those kind of technologies will help doing a sentinel node biopsy after the mastectomy in case there is an invasive on the contralateral side.
Okay, thank you for that, ma'am. I wasn't aware of that.
I just want to add one more plan along with that, plus risk reducing bilateral salpingo-oophorectomy.
Right.
Sir,
So
I
bilocated
wanted to
SLNB was
differ whatever
breast.
little experience over here. I would, it will not be only my take in this case. I will sit with the patient. I'll discuss with the patient what she wants, what is her availability of coming for follow-ups, how much she is keen to conserve her breast. And then I would explain her the chances of having recurrence after BCS. If the report is available of BRCA test, what are the chances of not getting contralateral breast cancer if we are doing contralateral surgery. And then I would give her a choice what she wants. If the patient is keen to conserve and she is ready for follow-up, I will give her a chance of getting BCS done.
It's only a
Right.
relative contrast.
Yes. So she underwent a simple mastectomy, SLNB, and an opposite side prophylactic mastectomy. And she had a residual IDC of 0.9 centimeter and no nodes were involved, T1B and 0. So what would be your next strategy, Dr. Siddharth?
This patient has a residual disease, so we'll send the patient to radiation oncologist for further adjuvant therapy and discuss about the case. So this patient received neoadjuvant chemotherapy followed by surgery.
Yes.
So in this case, this patient underwent BCS, right?
No,
Oh,
it's
okay.
So mastectomy patients, so basically TNBC will go with adjuvant capecitabine and maintenance therapy, and with all of the patients.
What about
BRCA
capecitabine with
positive.
So in
olaparib?
this case,
patient?
BRCA positive, we can add olaparib. So the issues that olaparib with capecitabine, the toxicity is very high. So that we have to discuss, because in Indian setting, it is very important to see the toxicity and the drop-off rate.
What would be the preference? Is the preference for capecitabine or is it for olaparib?
So in my experience, olaparib is not very favorable for patients. So I will preserve olaparib and go with capecitabine, because usually what I've seen, I've not seen patients tolerating 300 milligram BD olaparib in any setting in my patients. So we have to reduce the dose. Capecitabine patients tolerate very well.
Usually because we give it in the first year post treatment if it's olaparib, whereas capecitabine we even later on also it is
Still,
used as a
capecitabine is
different.
very much tolerable.
Yeah, it is tolerable. Don't we want to see if this patient tolerates it?
Yeah.
I think the sequence should be you have to give capecitabine first. You can't ignore capecitabine. Definitely, the addition of olaparib, we might not be able to give him 300 milligram BD, but even if we can give him 150 milligram OD, that's good enough. So maybe we should try, maybe give the first cycle capecitabine for 14/21 days, and in the second cycle, start off with olaparib at 150 milligram OD. I think most of the patients do tolerate, this low combination.
You want to wait till the and then start on olaparib, or you want to give a immediate shot?
We can start immediately because TNBC high KI67, I don't think there's a point waiting. Yeah. And the patient has not responded so well.
So if possible, then we should give olaparib at front only.
Like only half of the tumor has reduced. 1.7 to 0.9.
This is
It's not yet.
This from my understanding, this case was a real case.
Yes, sir. Yes.
It's very unlikely.
Yes.
1.7 centimeter unlikely to respond.
And paclitaxel
Yes.
carboplatin with such poor response.
I can't help but make this comment regarding cervical pad. The conservation is still an option. The prospective trials, they have not shown any real oral survival benefit with bilateral stick or protective. Real world data has shown incremental increase in recurrences, local recurrences, but no incremental overall survival.
Right, sir.
This patient is 48. He's way past the age of the breast cancers. The possibility that she have a contralateral disease, it's not zero, it's not very high. So conservation should still be a possibility. Secondly, if you are deciding to do a bilateral mastectomy for a BRCA mutated patient, reconstruction has to be a discussion point on the table. I mean, if there's a malignancy, there's a life-saving procedure where you would not, I mean, you are compelled to do a life-saving procedure, potentially life-saving procedure, even at the cost of quality of life, then it is acceptable. A prophylactic procedure causing so much more mutilation without reconstruction, I think not a justified option.
Yes, I agree with that. She was offered actually option of BCS as well, and she didn't opt for it. She wanted a mastectomy. We did offer a reconstruction. She was not keen for it because they were worried about the logistics cost, and that's why she opted just for bilateral mastectomy. So, sir, any role of RT here?
No, after mastectomy, no role. If she would have gone BCS, then definitely role of radiation would have been there.
Role of contralateral radiation as a risk reduction measure if she had opted for BCS?
No. As of now, I'm not aware. No.
Yes, ma'am.
So one would be one would take it if the disease was any bigger, I would have been gentle.
Right, ma'am. She's left side, ma'am. She did not receive adjuvant RT. Right. I do have another case, but thank you. Thank you. Thank you, all the panelists and chairpersons.
Thank you everyone for that wonderful talk. We'll move on to the next session on locally advanced breast cancer. For that, I would like to invite the chairpersons, Dr. Ashok Kumar Singh, Senior Consultant, Surgical Oncology, Kalyan Singh, Super Specialty Cancer Institute, Lucknow. Dr. Shashank Nigam, Senior Consultant, Surgical Oncology and Breast Specialist, ABC Cancer Center, Lucknow. Dr. Siddharth Pant, Consultant Radiation Oncology, Lucknow Cancer Center. I would also like to invite the panelist, Dr. Goon Johari, Consultant Oncoplastic Breast Surgeon, UK. Dr. Dilip, Senior Breast and Endocrine Surgeon, Tata Memorial Center, Mumbai. Dr. Chaitra, Senior Oncoplastic Breast and Endocrine Surgeon, Vijayawada, Andhra Pradesh. Dr. Asmita Arya, Senior Interventional and Breast Radiologist, SGPGI, Lucknow. And Dr. Mrinalini Verma, Consultant Radiation Oncology, KGMU. I would also like to invite our presenter for the session, Dr. Kulranjan Singh, Additional Professor, Department of Endocrine Surgery, KGMU. Over to you, sir.
Thank you, sir. And from morning, I've been noticing very young photographs of ours has been used for PGS. Thank you, sir, for making us feel young. Yes. With that, I would like to present a case, and my learned panelists and chairpersons, all of them will be involved, and the everyone on the floor is also asked to chip in. So can I have the privilege of asking Dr. Puneet to come over? He missed the last panel discussion. Aap bhi aa jayiye.
I would also like to invite Pallavi Prasad ma'am, a pathologist, SGPGI, as a panelist.
So just start with this. Pregnancy is cherished by one and all, males and females both. And these were something that came to my mind. Carrying a baby is the most rewarding experience a woman can ever enjoy in her life. And everything grows rounder and wider and weirder. And I sit here in the middle of it all and wonder who in the world you will turn out to be. So it's a mix of pleasure, anticipation, and everybody would love to have a very nice feeling about it. And we have a secret in our culture, more so the Indian one, and it's that women are strong. That is the only, probably the point that we can make use of when we deal with such patients. Pregnancy, most desired during the lifetime, and in India, repeated pregnancies are common. The incidence of breast cancer among the young is higher than that in the Western society. So this is one subgroup of patients we often come across in our clinics. So this particular patient was a 33-year-old, 3 months pregnant with with a lump in her left breast, noticed 2 months back. So I'd just like to throw this question to the clinicians, the surgical oncologist, medical, and the radiation. How often do you come across such patients, and what are your challenges when they present to you? One by one, just a minute or two each.
I think we are encountering this more now since most women are conceiving much later in life. That is the trend that we are seeing. So it's being diagnosed more than it used to maybe when we were training. But I think there's a recent study that's come out that the incidence is also on the rise. We don't really know the reason why, as most things, but that's my.
Okay. So the incidence is rising. Next.
Often we get women who've had their pregnancy conceived through IVF also, and now they've noticed a lump. Probably that's been pushed into growing bigger.
Because of the.
But sometimes most of the times it's going to be a benign lump
Okay.
that in any scenario, out of 10 lumps, 1 or 2 will be malignancies. So there are a lot of other non-malignant scenarios in this situation, but I think probably maybe 5% of women who come with breast lumps, 5 or less than that, would be patients who are currently pregnant and coming to a doctor.
As of now, it's a common problem. It's a challenging problem.
Yeah.
Nalini ma'am, your take? Very rare.
It's not
rare. Okay, by the time they reach the radiation oncologist,
हाँ ये भी
they have
है
probably done away with the pregnancy termination or.
और आते भी आपकी ओपीडी के थ्रू हैं इसके लिए तो थैंक यू
तो तब तक हम लोग निस्तारण कर चुके रहते हैं. Dr. Asmita, what's your take?
I think
What are your challenges as a radiologist when such?
as a radiologist, these patients are pregnant and having chances of benign diseases are more common as compared to the malignant. So, on the basis of this clinical finding, we have always be look for what are the features that are more suggestive of benign or malignant. Like mostly this patient we're having breast abscess. Radiologically, there are some findings that more suggestive of malignancy on ultrasound, also on.
So if I can just
Yes,
interrupt to
yes.
cut it short, when you have a lump, let's leave aside abscess, is it technically challenging for you to differentiate between a malignant and a benign lump in a pregnant lady compared to a lady who is not pregnant?
Yes, definitely, because this patient having high granular tissues, and if clearly lesion is there, then we easily differentiate. But if subtle lesions are there, definitely it is more challenging in all modalities.
So
Yes.
So it's clinically challenging to the
Radiologically, yes, right.
So Dr. Siddharth, who is a mix of both radiation oncology and medical oncology, what's your take?
Sir, I haven't seen case in my practice, but in my residency, I've definitely seen some cases. So the main issue is that if a patient has a breast lump, so normally when they come to OPD, they're usually in advanced stage because they try to hide it and they think that, okay, we can just pass the pregnancy and then go to doctor. So in those cases, that it is very, very challenging what to offer treatment at that time because they are usually young patients with a advanced stage disease, and definitely it's challenging. And for chemotherapy point of view, we have to wait for a certain period of time to assess treatment.
So what I personally think, occasionally we clinicians are also responsible for this. Patient complains कि हमारे breast में कुछ changes हैं. Most of us tend नहीं pregnancy है. It's probably there are a lot of changes that are going on to your pregnancy. Maybe not the specialist censored, but at least periphery में बहुत सारा ऐसा expert comments दिया जाता है. You want to add to that?
Then I would agree to it, but as the surgeons who are dealing with malignancies, a patient presenting with a lump like this, with no history of fever, no redness, and I will be very suspicious. Why? Because breast cancer in a pregnant lady has a double rate of expansion. The hormones are anabolic. The cancer cells will grow like anything. So we should be very suspicious. And FNA is a very small thing, can be done it's an outpatient procedure. We can do it very often, very easily. So we should not neglect it. Definitely, it should not be neglected because sometimes they come in a very bad shape, like inflammatory or maybe that kind of a cancer.
In this particular patient, yes. I mean, we are just talking about PABC in general and lumps in general. Because this lady, her
because the
NAC is full.
doesn't look like an abscess or something.
Not this lady, but we are just talking.
Dr. Pallavi, now that you said ki FNA, so in a pregnant lady, do your samples are actually also pose a challenge for interpretation that like a FNA in a lump with a pregnant lady and in a lady who is not pregnant, are you, it is challenging or it's a routine FNAC for you? You don't take that into consideration?
So that is taken into consideration. Like in FNA, if the female is pregnant or lactating, then we get certain changes, like we get apocrine changes, and also the smears will show a background of lipid. So that is the change that we get in usually lactating females or pregnancy. And the second point, sir, regarding any worrisome features, usually we are able to interpret that if the lesion is benign or malignant, it does not pose much of a problem. Um, the other point which I would like to add here is, sir,
प्लीज सर मत बोलिए, अभी पीजीआई टीम ने मेरी उम्र 10 साल घटा दी है, so that sir is making me feel older.
okay. So the other point I would like to make is regarding the interpretation, the biopsy. Like we may get changes in the biomarker status or the immune status. So that I read somewhere that the immune status can be altered during pregnancy, especially the TIL status.
So if I had to summarize that, the matlab pregnant status of the lady can also make a pathologist's life challenging.
Yeah, it is different from the routine reporting.
Sir, can I just add two more things? There is an emotional component that would be a bit higher for a pregnant lady. So while clinically looking at that patient, the emotional component needs a prime importance. Obviously, she would have her own concerns with that. And secondly, with the challenges that ma'am has just told about pathology, I would more be inclined for such lumps to go for a biopsy. I don't do FNAs in any breast lump, but more so for a pregnant lady with a lump, I would be more inclined towards biopsy rather than FNAC.
Dr. Dilip, anything more? Yeah, add some.
I think all the panelists have covered that it is a challenging situation for all of us. So एक बार PABC patient आया OPD में तो लग गई आपकी.
पर एक बार टाटा का उस पे मुहर लग जाता है तो it's even better. So Dr. Dilip has also agreed to that. So we have the Tata stamp. Dr. Shashi, before that, can we have Ashok ka le leं फिर floor पे? Anything to add to it?
Actually, nowadays there is some change in because we are getting more and more patient in early age with very advanced breast cancer.
डॉक्टर शशि कुछ ऐड करना था. आज मुझे लगता है आपने स्टेज में से ज्यादा स्क्रीन टाइम ले लिया है. They are the direct triplets of Hongkong. So they are primarily them. And as you rightly pointed out, they don't have that, okay, most of the breast lumps are negative for many things. And they do reaches at a later stage. I think one point to extract from this is probably educating them at this point that any breast lump without any redness or any, even if it is with redness, you have to have suspicion of PABC. I think that point is well taken, but किसी gynecologist के पास जाके आप बोले कि we want to educate you, वहीं पे गर्दन दबा देंगे आपका. Okay.
Also, ultrasound, one more point I'll add, because there is going to be a lot of prominence of the terminal duct lobular units in pregnancy, it is going to be very difficult to note any multifocality or multicentricity in such patients.
So we covered most of it: diagnostic challenges, treatment complexities, limitations of RT, which we'll again come to. Are these tumors or lesions more aggressive? Anybody? Yes, it is. But stage to stage math, what all texts say is that they behave same. But do we see that in our real life practice?
It's more of a treatment delay which happens in between each modality of treatment or the way we plan it accordingly. That but this, till now the literature says that it is equivalent to a similar age
That's
patient.
exactly what I want to ask.
So
We all read it everywhere, but in our clinical practice, is that what we see? Stage matched, they behave the same. It's based on a personal experience.
Sir, in our clinical practice, we are looking that most of the patients during pregnancy are like in lactational phase. They are coming from advanced stages.
So my question is stage matched. Someone
So, sir,
pregnancy and a patient who has had same stage, same age, non-pregnant. Do they behave same in our personal experience?
So that is very difficult because we cannot offer the standard treatment for these patients, like the target therapy. We cannot offer the target therapy during pregnancy. So it is very difficult to match the outcomes because we are bound by the limited treatment which we can offer, and a lot of patients they drop off during treatment only. So it is very difficult to just compare stage wise how to behave. If suppose patient treats like we have a non-pregnant, they may have the same outcome. But in real life, it is not, we cannot compare actually, because we cannot give the standard treatment just given, which has to be given to non-pregnant lady.
You have something to add?
I'm not sure if that is the question, but in my personal experience, I think the challenge starts from diagnosis because, as someone said, the presentation itself is quite delayed. From fresh memory, I think 3 weeks back, my most recent patient is a 26-year-old, and she got diagnosed when she was almost at term. So she was 36 or 34 weeks when she picked up the lump, and it had almost covered half her breast, and she had lymph node metastasis. Because of pregnancy, it didn't really occur to her that it could be something else, and it was all labeled on pregnancy related changes by the patient. She's not even gone
So
to a
is this
doctor yet.
challenging this notion that they behave similarly?
I mean, in clinical practice, probably that's what all the surgeons at least feel
Gaurav
that
sir,
they're
if we
more.
throw this question to you or the floor, you agree to these published literature or
I,
your clinical
I
experience?
think especially in the Indian scenario, there is going to be even if the patient presents to you early in EBC, by the time she takes a decision about what she wants to do, I think a lot happens even by that point.
Gaurav sir and Dr. Vishwak, your take on this, because I think it's important.
My take is that we try to stick to the guidelines as much as possible without being practical. So the middle path is always the right path. On one hand, I've seen this happen. To accommodate the request and convenience of patients and family, we ignore science, but that cannot happen at the cost of. So we can't be ignoring the guidelines. At the same time, we can't be dogmatic about following the guidelines and being impractical.
Dr. Vishwak, just a quick comment if you wanted to add.
Cases of ABC, and out of that 3 cases are triple negative. Maybe I would say the tumor biology, more aggressive tumor biology we see in pregnancy cases, I guess.
So imaging, there's not much that we can. Mammography is contraindicated. So the commoner one would be an ultrasonography. It has its challenges, as Dr. Asmita said.
I just a few lines regarding that. Ultrasound, if lesion are smaller, then we are having not differentiate benign versus malignant. But lesion is if significantly higher, there are different clinical. I mean, ultrasound findings are there. We can easily differentiate this is the benign one and malignant. Except few entry like in TNVC tumors, mostly they used to have a abscess presentation on the ultrasound, because first line of investigation in these patients are ultrasound. So TNBC is definitely having a challenge for us in those cases to differentiate from the breast abscess. And if any lesion are having presented to us, definitely we should go for the core needle biopsy for further to confirm that.
I would just like to add one point, sir. Especially, I mean, it's true for any scenario, but especially because she's pregnancy associated, even though it's 5 centimeters, I would rather get an ultrasound guided core needle biopsy. Any situation, probably that is going to be better unless the skin is already involved. Because a lot of times I get patients referred from other hospitals कि एक biopsy negative आया clinically बहुत ज़्यादा suspicion है, because the tissue, the way the tissue feels, you might not be going. And if it's just an addition of 10 minutes or 15 minutes to a routine core biopsy procedure. I think it's the standard in the UK. If it's something is seen on a scan, they do it ultrasound guided.
पूजा मैम आप कुछ बोल रहे थे?
Ma'am, we can do, it is not relate. We can say absolute contraindication is not in mammography is not absolute contraindication. We should always avoid the radiation to the patient, specifically in the first trimester. If patient is coming to the later on, we can offer her, but at least we are having other modality like ultrasound and MR. Then we should go for the MR rather than directly going for the
If I can
mammo.
interrupt there,
Yeah.
the age bracket of
Yeah.
pregnancy, most of them anyway, routinely we don't do mammography. Let's say they're 30,
Yeah.
35.
Yes,
But if-
right, sir. Right, sir.
If this lady wasn't a pregnancy associated breast cancer, we would be doing in a lesion that looks like that.
Yeah,
We would definitely be doing even
generally
before the core
tend
biopsy.
to avoid.
Yeah.
And another thing, I think the pain is probably more during pregnancy. If we have to compress the breast,
Yeah, sir. Definitely, sir. Definitely.
And there are guidelines in a lot of places where the hospital is supposed to put up big charts. Ki pregnant ladies are not allowed here. So it sort of looks ridiculous when you're asking to get it done while the patient is walking through the doors. But with proper shielding second trimester onwards, it is sort of advocated. But again, I think it can be a decision that can be taken.
I think these are trials which are difficult to conduct also. When I was reading, I would be putting that question to Mrinalini ma'am. I think we can take that. Why is radiation contraindicated during pregnancy? All of us just keep reading about it. It is contraindicated. We all know. So much of advances in science. Why haven't we able to design some shields which can actually?
We have shields, but even the smallest doses seems to be contraindicated for the pregnant lady. Why? Because first trimester में तो we all know कि वहाँ पे malformation and all, even drugs also ना. But in the second trimester also there are chances of IUGR. We don't want that risk, and it is strongly like that कि no dose of radiation.
I was reading that there are these phantom models where they've used
हाँ
these
हाँ
lead
नहीं
sheets.
नहीं that's true कि they have tried and all, but उसके
There has been no
हाँ
randomized
अभी तक randomize तो मुझे नहीं लगता इसमें randomize हो पाएगा.
हो पाएगा.
I
That's the
don't think so.
difficulty.
I
So
don't
it is
think.
just be anticipating कि ऐसा खराब होगा इसलिए we are not doing, but actually it has not been scientifically proven. Am I right in saying that?
No, scientifically
Yes,
proven
those
by
things
the
to be-
RCT, yes, I say कि no, but there are some historical data also कि उसमें it is like that कि you should not expose lady with for the radiation.
So one thing, the amount of radiation a person is exposed to while doing a mammo is the same amount of radiation you will be exposed to in a general environment in 1 week. That is there. I'm not pushing for this person, but usually the reason why we would do a mammogram is for microcalcs. If it's a triple negative, we are not going to expect microcalcs. We can do a non-contrast MRI in this lady, and another alternative. A lot of people will push for mammo. I know that both
Those
both
points are
schools
well
are there.
taken. We'll just rush through it now. Okay, so pathology, the nodes versus
Yes, I want to add some point. When we are doing the mammography in breast, in during pregnancy, the sensitivity and specifically sensitivity of the detection of the lesion and calcification is quite reduces because of high dense fibrogranular tissue, and we are not able to differentiate the lesions and calcification. So definitely we should opt for ultrasound and MRI in during that cases in
So if it is
specifically in the
suspicious, yes,
pregnancy.
but for probably looking for microcal, I personally wouldn't 5 centimeters lump, where even we are going to say that conservation is going to be an issue because of radiation during pregnancy and all those things.
It's immaterial to do it right
Yeah,
now.
so exactly. So we should not just look at the available theory part of it, but practically how useful it would be or it would not be.
Because she's a TNPC, by the time she finishes her chemo anyway, she'll deliver and then only she'll be having her surgery. So at that point, we can look for.
So the FNAC, the lymph nodes are positive for metastasis, bone needle biopsy, triple negative, grade 2. I would just like to previous presentation, there was a thing of MIB 1 scoring. We commonly use KI67. So I'll throw this question to Dr. Pallavi. Is there any difference between the MIB 1 scoring and the KI67 that we are routinely using? Are they same or they're different?
These MIB1 and KI67, essentially they are used interchangeably. Like we assume both of them are similar, but there is a slight difference between the two in the sense that KI67, which is originally Kyle67, that is an antigen and that is expressed on the tumor cells or the proliferating cells that will indicate a tumor burden. So that is our antigen. Whereas the MIB one, it is a specific antibody which is targeting the epitope on Ki67. So the difference is just that of the antigen antibody, but for our interpretation, they have to be treated as being equivalent.
So is it easier for a pathologist when they use this MIB, the antibody, or they look for the antigen? Which is
The better one is the MIB one because it can be used on frozen sections also. Initially, we had just the Ki67 antigen that was being used, but that worked only on the frozen section. But then came this targeted antibody, so that works well on frozen as well as the paraffin embedded ones. So MIB one is.
if MIB1 is better, why aren't most centers using it? Any other pathologists in the group? So I think that was new to us also what was presented, but I think it is something which we can explore.
Possible we are prescribing Ki67 rather than they not doing them.
So, so less awareness on the side of the surgeons, but it's probably a thing we should look into. We keep cribbing about the quality of T67. When we have something like MIB1, I don't know how good it is or it will be, but that's a question to ponder over. So the extent of metastatic workup, it will be a challenge, Dr. Dilip, during pregnancy. What is the extent of your metastatic workup?
USG abdomen. That's the only thing that I can do it for her at present. With chest X-ray is out of the question again because she's just 12 weeks into pregnancy.
Any MR based imaging can be done
So do we do it?
other than contrast.
So
I'm
do
just
we
saying.
do it, or we should do it, we should not, for a lump like this, 5 centimeters, triple negative?
It might probably help her. I mean, if she is metastatic, might actually help her in taking a decision about what she wants to do with the pregnancy because it's still.
I think that issue is important. We should say this first, what she wants to do with her pregnancy. So we should see interested in
Does she have
Matlab,
one kid? Does she have
that
two
would
kids?
come next. I just wanted everyone's perspective. That's important actually. So let's assume this is her first pregnancy or second pregnancy or not. Is there any important of routinely we say कि हमें नहीं करना है, but that message should not go. कुछ न कुछ करना है, क्या कर सकते हैं, किस extent तक करना है, that needs to be actually thought of. We how many of us routinely actually think of कि हमें MRI करा लेना है breast and thorax and abdomen पर. Most of us actually don't go to that extent, but as Dr. Chatra pointed out, that is important and it can be done. Needless to say, after we ask the patient whether she really what she needs to do with this particular patient was P3, L3. She didn't want this pregnancy. That was the next slide. So, but any other difference on that, Dr. Dilip?
So at least we can do non-contrast MR thorax and abdomen in this case to rule out the metastatic disease.
So
That will not harmful to the patient, and we can easily detect the lesion in the thorax also and the liver also.
So for the clinician, let's assume she was Dr. Shashank. She was her first pregnancy. Non-contrast MRI picks up lung metastasis. What would be your treatment advice? Let's forget the patient को क्या चाहिए and then how we consider it.
So are you saying that those lung lesions are strongly suspicious?
Yeah.
So then the discussion completely is about sitting with the patient and prognosticating him about her about this kind of a disease and the kind of survival you would expect. And as Dr. Puneet said, to have a ground check reality whether she wants to continue with this pregnancy or not, that would be at the forefront. And at the same time, vis-a-vis the other part would be that when the medoncs come into picture, what kind of survival expectations she could have with the best of treatments, and then it's her call moving forward. So knowing the prognosis, if she continues the pregnancy, vis-a-vis the prognosis when she terminates the pregnancy, will kind of guide her towards decision making.
So I think most would agree during pregnancy also the metastatic workup should be given due importance. We should plan it out well so that there is the best of best outcomes for the individual and the family as a whole. Many times we may not be able to save the mother, but we can just continue the pregnancy and probably the family will have a child. So these are my personal thoughts. Nothing scientific in that. So P3, L3, all alive and healthy. She underwent medical termination of pregnancy. As was said, mammography was done after that. PET CT, it was non-metastatic, clips were placed. She received 4 AC followed by 4 PACLI. Dr. Siddharth, I think this was a part of the last discussion also. This is routine what we do. It said that PCR will, increased PCR would translate into improved survival. So 4 AC followed by PACLI should be the standard of care, or even we need to change, get PACLI and carbo. We occasionally do that, but should that become the standard of
So
care?
in the
What's your take?
TNBC stage 2, stage 3, we should add immunotherapy also in these patients to have an improved pathology complete response rate. So this is not the standard for any stage 2, stage 3 TNBC patients, non-metastatic.
So immunotherapy, yes, theoretically yes, but at least at KGMU, I don't know what the status at SGPJ. The affordability is still at question.
Yeah, but if she's affordable, yes. If she's terminated her pregnancy,
Yeah.
if she's continuing pregnancy, then again we cannot give
Yeah.
pembrolizumab.
Yeah, but no doubt about that. But again, pembrolizumab, how well tolerated is it, doc?
So it's well tolerable.
It's quite well tolerated.
Well tolerable,
We,
no issue.
as thyroid surgeons, we need to look after the TFTs very well before and not neglect that. Because
Yeah, that's true. I see another person.
And in this also, I would like to add platinum also in this case, the neoadjuvant setting.
All the many people from the corporate setup, they always say that pembrolizumab is well tolerated, while the opinion from those practicing at government hospitals is the other way around. The literature is once again varied. Okay, anyway, let's not get into that.
Also, sir, we should offer gene testing to this lady. She's 32, triple negative,
Thank you.
pregnant.
थोड़ा 5 मिनट पहले और बजा दिए होते तो और अच्छा रहता. So those things were done. Platin's, her gene testing was negative. Just a quick question: in case her gene testing was positive, neoadjuvant, would it make any difference? What apart from the platins?
Yeah,
We-
it's the same.
We would still give with pembrolizumab,
Okay.
and then
It will only change in the
surgery. Yeah.
So adjuvant thing of PARP inhibitors are there.
So
those anecdotal reports or smaller trials of neoadjuvant PARP inhibitors. What's your take on that, the medical oncologist? That was my specific
So
question.
now it's not, still now it's not a standard for using PARP inhibitors in the neoadjuvant setting. The trials are still going on phase
Right,
2 only.
Just it's a hypothetical situation, Dr. Chatra. Okay. So neoadjuvant role of PARP inhibitors as of now?
No.
Okay, I think we are. So just another last question to the surgeons. What is your take of SLNB in pregnant ladies? Had she undergone a surgery in her second trimester, would you do an SLNB or not?
Most people make
Not in this, not yet. I'll come to this case. In a pregnant lady, I just want him to address that issue. In an N0 pregnant lady who's undergoing surgery in her second trimester, would you offer SLNB or not?
I would offer a limited sampling, low auxiliary sample, no using of dye.
Yeah, so the methylene blue and isosulfan, they are contraindicated.
Contraindicated.
What about all these ICG?
ICG does not have data in pregnant patients, so I would not be comfortable using it. There's no.
Yeah, that's good enough. Yeah, that's safe. Scintigraphy is safe. There is literature for that. Yeah. So here it was more of a validation SLNB. Here the pregnancy was not taken into consideration. SGPJ team and many others, they have a lot of experience on post-neoadjuvant SLNB. We also do, but here it was done as a part of validation. So SLNB was negative and also a completion ALND were all negative. So again, she subsequently became metastatic. The next panel discussion is on metastatic breast cancer. So I think we can just leave that. Another issue I just wanted to highlight was fat necrosis. That did come up in that. The surgeons, how commonly do you see this? You have done a breast conservation surgery and then patient presents with a lump or some imaging abnormality. And then how common is it?
It's
And how difficult is
quite
it?
common, especially post neo chemo and especially after radiotherapy. They keep coming back with lumps and here and there, and they're usually fat necrosis. So it's quite common.
In every, I think, operated cases, this is a fate of that interval that patient is going to have. Fat necrosis will also And post-surgical changes will also show on the mammography, and patient may have complaint of lump. Then we have to definitely differentiate from the recurrent or recurrent lesions, and these are the recurrent lesion, and these changes are the post surgical changes. So definitely we are clearly differentiate post-operative changes versus recurrent lesions.
मैं हमेशा एक क्वेश्चन मार्क लगा के रिकरेंस भी
Sir, it is not practice in here. In
a
we
lot
are
of times it is seen as an oil cyst.
oil
not-
cyst, and basically the dystrophic calcification we can easily differentiate from the uh, residual disease or recurrent disease.
We
Yes.
understand this इसके बाद क्वेश्चन मार्क रिकरेंस वाला
In
Yes,
any
sir,
case,
I think we are here. We are doing the ultrasound correlation also.
in any case, if there is a clinical suspicion, you go ahead with a core needle biopsy, irrespective of what the imaging says.
I would like to add something to this. There is a paper by Miss PG Roy from Oxford, wherein she had studied the recall rates for patients who actually had LICAP flaps or chest wall perforator flaps. So the recall rates for those during surveillance mammograms for extra biopsies. So the rate was no significantly different from for someone who would have had a volume displacement surgery. So decently done LICAP flaps recall rates for fat necrosis and query lesions wherein a biopsy is needed are, as per that paper, as per that literature, were same vis-a-vis a volume displacement BCS.
Both BCS, the rates are as high as 20% and beyond. So it's a common thing that we actually take. With this, I'd like to end this, if it's okay with all the panelists. Thank you so much. Thank you, sir.
Moving on to our last case scenario for this session, I would like to invite to the stage the chairpersons. Dr. Pramod Gupta, Associate Professor, Department of Radiation Oncology at Kalyan Singh Super Speciality Cancer Institute, Lucknow, and Dr. Durgesh Kumar, Associate Professor, Department of Surgical Oncology, Kalyan Singh Super Speciality Cancer Institute, Lucknow. I would like to call to the stage the panelists for this session, Dr. Punita Lal, Dr. Vishwak Chandra, Dr. Farhanul Huda, Professor, Department of Breast and Endocrine Surgery and Oncoplastic Breast Surgery at AIIMS Rishikesh, Dr. Chaitra, Dr. Mukta Bakshi, Senior Consultant, Surgical Endocrinology and Oncology at Manipal Hospital, Ghaziabad, Dr. Resham Srivastav, Senior Consultant, Department of Radiation Oncology, Medanta, Lucknow, Dr. Animesh, Senior Consultant, Department of Medical Oncology, Apollo, Lucknow, and Dr. Mohammad Sohaib, Director, Department of Radiation Oncology, Medanta, Lucknow. I would like to invite the presenter for the session, Dr. Shagun Mishra, Additional Professor, Department of Radiation Oncology, SGPGIMS, Lucknow. Over to you, ma'am.
I don't have my slides here. These are not my slides. So at the outset, would like to thank the organizers, and I take this opportunity also to express my gratitude to my teachers on this Teachers' Day, Dr. Punita, who's here on stage, and Gaurav sir. I mean, it's because of them that we stand here today. Thank you very much, and for training us and investing in us. So I brought up a case of oligometastatic breast cancer. And the reason I did so was we were discussing about PET scans, and we see that PET scans are being done very indiscriminately inside and outside the hospital. And because of that, we come up with this, many times we come up with this diagnosis of oligometastasis, breast cancer. And I mean, many times we really don't know what path to take. And fortunately or unfortunately, there is very little guidance as to, how to go about treating each and every case. And most of the times when I'm in the MDT, we are individualizing on a case to case basis. So with that, I would like to welcome all the panelists on the stage and the chairpersons. These are my panelists. They have already been introduced. We don't have a radiologist and pathologist, so I'll be posing these questions to the other members. So this is the patient profile of 45-year-old postmenopausal female. She presented with a lump in the right breast upper outer quadrant. The presentation was for 3 months duration, no nipple skin changes. She had a low back pain for 8 weeks, and she was on and off analgesics, but this was not disturbing her sleep. There is no evidence of weight loss or fatigue. And on examination, she presented to us in the OPD, and on examination, there was a mass which was palpable in the upper outer quadrant at 12 o'clock position. There were no axillary lymph nodes palpable. And on a clinical examination, there was tenderness, which was present in the right hip. And when we scored the pain, the score was moderate. It was a score of 4/10. So to the panel, and because many of these patients walk in through the door of the surgeon, so to the surgeons first, Dr. Vishwak, how would you investigate this case?
Yeah, by triple assessment, physical examination, I had already mentioned. So I would go for a mammography with ultrasound scan correlation for the primary tumor. Based on that, tissue diagnosis.
And anything else besides mammography? Do you do blood tests and biopsy and a complete set of investigations?
Routine blood investigations, especially alkaline phosphatase has to be included since patient has got tenderness in the hip.
So the blood tests were done and they were all reported within normal limits. Biopsy from the mass was done. Of course, a bilateral mammogram and ultrasound of the axilla was done. Ultrasound axilla was negative. A mammogram identified the mass. And biopsy was suggestive of infiltrating ductal carcinoma. And on IHC, it was ER/PR positive and HER2/neu3 positive disease. Would you investigate her further?
Axilla, ultrasound axilla, is it normal? So I would correlate this mammography finding with the ultrasound.
Okay.
And to look for the axilla also. So once this workup is done, then metastatic workup we have to plan.
So, Dr. Punita, would you like to do a metastatic workup in this case who presents to you with bony pains?
Yeah, so because there is a 8-week history of backache, which is not getting resolved, and she needs to take analgesics, and the VAS score is something like 4 or 5, my threshold would be low, and I would like to get a bone scan done for this patient.
So, Chaitra, Abby, do you agree to it? Would you like to go ahead with a metastatic workup in this case?
If the bone scan is positive, then we'll probably look for everywhere else too. And upfront, if the finances are good and if she can afford a PET scan, we can do
So
even
you
a
would
PET scan.
directly go with a PET scan and not a bone scan first?
I would normally do a bone scan first.
And then follow it up with a PET scan.
Yeah.
Any other
It depends
comments?
on how much a bone scan costs and how much a PET scan costs in the area where we're practicing. So a bone scan would cost upwards of 9,000. A PET scan, the cheapest one would cost probably 17,000. So if you're taking those costs into consideration, probably doing a PET scan, because if a bone scan is positive, again, that's another additional expense. But in a setting like SGPGI, we definitely do a bone scan first and look for other places if this is positive. That's what I think should be the appropriate way.
Yeah, Dr. Vishwak, would you like to do a bone scan
So-
first, followed by a PET scan, or a
Yeah,
PET scan?
basically, it's dictated by the clinical examination. If clinical examination of other organs, abdomen, respiratory system, everything is fine, except for the tenderness in hip, and the liver function test is normal. The liver enzymes, OTPT and bilirubin, everything is in normal. Bone scan would suffice if patient is financially affordable.
So we don't have guidance, but yes, I mean, when you look at the guidelines, they do suggest doing a metastatic workup in an early stage breast cancer if there are symptoms. And we really don't have guidance as to whether to go ahead with a bone scan first, followed by a CT thorax, abdomen, pelvis, or a PET scan. Just for reasons of convenience and because it is a one-stop shop, people resort to doing a PET CT. I don't know how right that is as a strategy. But yes, certainly a bone scan. And if you have a abnormal finding on a bone scan, then instead of going ahead with a CT thorax, abdomen, pelvis, you can go ahead with a PET CT. So PET CT was done, and this PET CT showed a mass in the breast, and it did identify bone metastases at the L3 vertebra and S1 vertebra. There was no other sites of uptake in the body, and this is how the PET CT looked like. So the transverse process of L3 vertebra was involved, and you had uptake at the sacrum as well. So just coming back to the staging workup, I mean, in an early stage breast cancer, all the guidelines recommend against doing a routine workup. In a locally advanced setting, especially patients who are T3 or N2 and above, there you can go ahead, their staging workup is recommended. And the reason somebody had asked this question in the first panel, the reason why in early stage breast cancer, PET CT is not recommended because, of course, the yield is low, and it increases the healthcare costs because the patient is then subjected to unnecessary biopsy fears, and there are a lot of false positive results and misdiagnosis. So it should not be done in the case of early stage breast cancer unless and until there is a pressing reason, like in this case, there was bone pains. So that's why we resorted to doing a PET CT scan. Just talking more on the PET CT in stage 3 breast cancer, and there is randomized evidence from the Canadian group, which suggests that in stage 3 and above, PET CT has an upper hand over conventional staging, that is a CT thorax, abdomen, and pelvis in terms of detecting the metastases. And it is not only about detecting the metastases with a PET CT, it did change the plan. So the plan change was commonly changed in a PET CT as compared to that of conventional CT. And but what is not known is that whether this kind of upstaging and changing the treatment plan has a survival advantage versus not changing the treatment plan. And moreover, in this study, people were talking about doing PET CTs in ER negative breast cancers and HER2 positive breast cancer. But in this particular study, the impact of PET CT was less obvious in a ER negative or HER2 positive disease. This is because PET CT is more sensitive in detecting
bone metastases and lymph node metastases, which is more commonly seen in ER positive disease. So, I mean, just because you have a bad biology, that is triple negative breast cancer, that should not, provoke doing a PET CT in these cases. And these are certain editorials which were then followed up after this article as to why PET CT should not be done as an initial staging workup. So this is again guidelines from ISMO, which suggests that when you're talking about metastatic breast cancer, and here we are now, the diagnosis is oligometastasis. So there, they do suggest a CT thorax, abdomen, and pelvis, as well as a bone scan, instead of or a PET CT. If you are talking about truly metastatic breast cancer, and if you do this as an initial staging workup, for example, if you have done a PET CT as an initial staging workup, then it should be followed up as a workup for your response assessment. For example, if you have done a CT thorax, abdomen, pelvis, the response assessment should be done with a thorax, abdomen, and pelvis. But in a case of oligometastatic breast cancer, and these are living guidelines, the ISMO living guidelines that came out in April 2025, they are very clear that if there is oligometastases, then PET CT has to be done. So even if you have done a CT thorax, abdomen, and pelvis, which identifies oligometastatic disease, you need to top it up with a PET CT scan. Is the panel agreeable, or do you think that you would just stop at a CT thorax, abdomen, and pelvis when you are dealing with oligometastatic breast cancer? Yes, Chaitra.
PET scan can upgrade it into a full-blown metastasis. So whether the treatment is going to be with a curative intent or with a just a control of disease and palliation and that kind of intent, it is going to be dependent on how many metastases are there. So maybe it is a good thing to, unless there is already, if it's an oligo, then we need to definitely look for more.
So
I guess.
why do you think that they want to do a PET CT in a oligometastases, whereas in a fully blown metastatic disease, they are okay with a CT thorax, abdomen, and pelvis?
To know the exact metastatic burden of the disease. I mean, to label it as oligometastasis, the lines are still blurred. So even though we say that it should be 5 sites, 2 organs, whatever, but still to label it is a low metastatic burden. To label it properly as a low metastatic burden, you need to be more well-defined.
Especially post-COVID, the CT thorax, if we had seen, we are seeing more of ground glass opacity in majority of the patients, right? And often we see some tiny non-specific nodule in lung when patients bring the CT report. So if we have an oligometastasis in bone scan, definitely we would go ahead with a PET scan to look for what are those ground glass appearance, what are those tiny nodules, whether they are having any pickup or not. If required, we go for a biopsy of that as well.
So I would like to ask my medical oncologist, Dr. Animesh, because now we are going into the realm of metastatic breast cancer. Are you okay with a CT thorax, abdomen, pelvis, or you would insist on a PET CT?
If we have a CT thorax abdo and a bone scan in addition to that, and I already have disseminated disease, a PET doesn't really change any management decisions. I mean,
I'm talking in oligometastatic disease.
so for oligometastatic, so definitely we go ahead for PET.
Yeah. And radiation oncologist, any comments? Dr. Resham and Dr. Suhaib, anyone? Any further comments?
Ma'am, we'll go ahead with PET CT to see the exact burden of disease and to classify the disease, whether it's oligometastatic or not.
So that's what's recommended because it has implications on further management, and that I'll come to later. So this was diagnosed as carcinoma right breast T2N0M1 disease, metastatic breast cancer. It was triple positive, 2 sites of metastases in the bone. So, what's the definition of oligometastasis? Dr. Resham can take that question.
So basically for oligometastatic disease, the site is classified as up to 5 sites of disease. But from where this magic number has come, nobody knows. So up to 5, and it can involve multiple sites also. The main thing is that the disease should be amenable for cure. If it is involving more 3 sites, lesion is less than 5, but still the lesions are large and not amenable to cure, then it's not metastatic, oligometastatic disease. So basically, the disease should be amenable for cure.
Dr. Animesh, any difference in opinion from a medical oncologist perspective? Do you agree with the cutoff of 5?
Well, whether I agree or not is the moot. I mean, that agreement is broadly there. As
Yes.
Punita ma'am pointed out, the line is still a gray one, but at least the general agreement seems to be that 5 is fairly like robust cutoff.
And
for
how
now.
many sites?
Up to
5 all in one organs, 5 in different organs.
I also agree with the general consensus. 5 mets, up to 5, up to 2, up to 2 organs, not more.
Generally, they take up to 3 organ sites and a maximum of 5 metastases. What about pleural effusion? If you have just pleural effusion, that's one site, pleura involved.
Yeah, but then that's not amenable to local treatment.
So would you classify it as oligometastasis?
No, that's not oligometastatic. No.
Okay. So pleural effusion
I-
and leptomeningeal disease is not classified as oligometastatic disease, even though it's a single site of metastasis. Yes, Vishwa.
So, there are discrepancies in the number of sites, right from the Hellman originally started postulating oligometastasis. But now we have come to a conclusion by ASTRO, ESTRO, and ESMO guideline, like now up to 5 lesions, not necessarily in a, single organ, not it can be on any organ, potentially all amenable to treatment.
So that's what the definition is: up to 5 metastases, 3 organs, and you should be able to treat them safely. So that's what the definition of oligometastasis is. We don't have a pathologist here, so any one of you can take this question. Is there any role of biopsy of the metastatic site? This is an oligometastatic breast cancer. Occasionally, you will have come across cases where you find a single lung nodule on a PET scan, or 2 lung nodules, or a single met. Would you biopsy the metastatic site in oligometastatic breast cancer? So, Sohaib, you can take that question.
Yes, of course. Ideally, we have to biopsy it, as because like if we have to start with primary systemic or endocrine therapy, medical oncologist would definitely require diagnosis from the metastatic site.
See from the primary site, and you have the hormonal receptor status. Why do you need to?
Not for the hormonal receptor status, to confirm that the metastatic site is whether it is metastasis or not. As shown in this PET-CT image, if the lesion is in the vertebral body, it is well taken as a metastatic focus. If it is seen in the intervertebral disc or in the transverse process, then in that case, we would consider. So it depends on which site the lesion is there.
And of course, the radiology as to whether you are truly suspecting it to be metastatic site or not. So only in those cases. And yes, ma'am, you have a comment.
If it is two small nodules in the lung, again, there is this whole, and if it is something that needs a bronchoscopy, which again is very troublesome for the patient. And if it's not going to change what chemotherapy you're going to give to the patient, I think we should take that into consideration as well when we are deciding whether or not to do something for that. If it's not changing the treatment plan, probably it's not absolutely necessary in some situations. In some situations, yes, but in some situations, I think we can probably skip that.
I think again, when there are oligometastasis and we are dealing with a breast cancer, which is a known breast cancer patient now, but still there are metastases which we are not very sure of whether they are metastasis or not. So for any, I think some medical oncologists will agree with me that if the biopsy proves it, that it is a metastasis, it's much easier for them to give any chemotherapy. Or sometimes you may get lesions in the liver, which may not be metastasis.
I think the pragmatic way forward would be to go back to your radiologist and ask him as to how sure he is about the metastatic site. So let's not talk about legality. Let's talk about science, and let's talk about pragmatism over here. So I don't think so. I mean, we do biopsy all these sites when we come across a oligometastatic breast cancer, although there is a recommendation that probably you should, and probably there might be a change in receptor status. But if you have a radiology, which is that, like I just showed, where clearly you can see osteolytic lesion sitting in the sacrum, probably we would get.
In this case, probably not. But
I
I
don't
think
think so.
if it's a lung and if we are discussing whether to do it or not, I think that discussion should be with the patient. We need to let them know that this might not change your treatment plan, but this will be for documentation sake, especially in this patient, if she had 2 nodules without the bony metastasis, then yeah.
Okay, we move ahead, and the next. So this is a oligometastatic breast cancer. What is the intent of treatment over here? And I pose this question to a medical oncologist first.
I think this.
Would you-
I think I would like to try in the reverse. So the sequencing part is, I think, far more clear cut than the first one. Typically, what I would find is our intent of treatment would depend on the biology, as in response to systemic therapy. I mean, that is the typical approach for these patients. We start off with systemic therapy based on the receptor status. This is a triple positive, so Cleopatra. And based on the response, we take a call on local therapy.
So it is very difficult to decide upfront regarding intent of treatment. That is what you mean to say? You need more information as we go ahead and give treatments?
At least that is what I believe and do in my routine practice as well.
Okay, so initially you would start with a palliative intent or curative intent? You would treat it like a locally advanced,
So when I'm
non-metastatic.
So when I'm using Cleopatra, I'm using a single drug. So that is the one, so to speak, trade-off. But yeah, we are using dual HER2 anyway. I'm using my most effective weapons.
I think we would go with the intention of curative, but if
Yes.
things don't go our
out
way,
with,
then
we might change our plan.
So here the issue also then becomes the messaging that we give come across, the messaging that the patient gets, right?
Yes.
The patient has to be we have to be very clear that we are going ahead with treatment. We are not sure where this is going to take us. The messaging should be very clear.
You also change the bone only disease that we are dealing with. So we should probably be looking at it more optimistically than if it was a visceral
beds.
disease, and certainly if it was a brain disease.
What I have seen is that most of the medical oncologists are even we also, apart from intent and apart from what is we give the most effective regimen. That's it. And now then you see the response. You don't compromise with the regimen, and then you take a decision. That's the thing.
So I think you need more information for, I mean, in terms of response to treatment, and in terms of sequencing treatments, would anybody like to go ahead with surgery first? The reason is because you need to decide upfront, curative pathway or the palliative pathway. If you're following the curative pathway, you will have surgery, radiation, everything coming in. If you're following the palliative pathway, probably it will be only chemotherapy alone and plus minus palliative radiotherapy. So I know it's a difficult call, and most of us in the clinic with this kind of limited metastases, and as ma'am pointed out, with favorable bone metastases, we would possibly go ahead with curative intent and start with neoadjuvant treatment. So what regimen? She's a triple positive.
Taxane, platinum, and dual HER2.
Does the medical oncologist agree to this?
Cleopatra is what I am inclined to believe. What we are trying to assess is the radiobiology of the biology of the disease is what we are trying to assess. So I'm okay with Cleopatra. I do not intend to use the platinum in this setting. Uh, Also, since this is metastatic disease, now we do have the Destiny Breast 9 data.
Yes,
We know that the TDM1P combo is giving us much better responses and a much more durable response. So that is the best shot at the initial response. So, I mean, that is, I suppose, is not how the trial was intended. That is not the question that this trial was intended to answer. But probably this is the data that I can use to assess my, like, if I'm using TDM, if I'm using NHER2 upfront, then I'm using right now de facto my most potent weapon upfront.
If we use TDM1, we can't.
I meant TDXT. But this is metastatic disease.
Yeah, we can't go back to trastuzumab once we do that. So we need to keep things.
This is like I said, once we are treating oligometastatic disease with the intent to possibly cure, then I do believe that we have to be a little more flexible in terms of what we are the regimen that we use. If I'm using a TDXT per 2 backbone to begin with, and then after three, then maybe subsequently 6, then we assess and we find a good response, right? And now that's a whole new Pandora's box that I believe we will be talking about. But yeah.
But because we usually treat them as the way we would treat an LABC, and you would not do that for an LABC patient.
Yeah.
Probably we should just stick to the
That's
regular.
said that intent is very important. Intent of treatment, we were following the curative pathway, and all of a sudden we jumped to the palliative pathway and we started using TDX. So the intent of treatment, we are using the curative
But
pathway.
if I am using TDXDP, then paradoxically that is my most potent regimen.
So unfortunately, suppose if patient progresses, he will not be having any more drug, right? So that should not be, I beg to disagree with you.
And that is not
that is the last resort drug that we are having.
So,
That you
okay,
can't use at the start of the
I do
treatment.
not. This is more of a devil's advocate thing. I do believe that going forward, this is a regimen that will be coming up in this setting. I do believe that is the future. At present, yes, THP, Cleopatra. I started off with Cleopatra. That is what I'm going to be offering to this patient. But going forward, I think oligomets, TDXDP might be the more and there are de-escalation studies as well. Like they are ongoing. TDXDP induction, and then we further de-escalate down to an HP sort of maintenance.
And if you're taking finances into consideration as well, even if she can't afford pertuzumab, probably TCH should still be the first line.
First line in this case because she's HER2 positive. And initially we decided on a curative pathway where we'll follow the LABC or the early breast cancer setting rather than following the metastatic pathway. What about role of bisphosphonates? Would you like to give it?
Once every 4 weeks.
So can we extend the interval? Can we give it every 3 months? Is there evidence to it?
That is usually
I
in
think
this
that was after
situation when
1
we're
year of-
trying to cure her.
Yeah.
Probably.
And in any
So
case, the data
bisphosphonates is not for cure. Bisphosphonates is for
her bony pain and
bony pain.
and the 3 monthly data is after 1 year of monthly. So like I think the Zoom and the
Yes.
whatever data does exist is after 1 year of monthly, then we move on to 3 monthly.
Yeah, so initially for 1 year, you give it on a monthly basis, and following that, you can change it to a 3 monthly basis.
Sorry, I forgot how old she was.
She was 45, postmenopausal. And how long would you like to give bisphosphonates? 2 years, more than 2 years, 5 years.
Suppose
She's
radiology.
metastatic breast.
So once
Depending on what's happening with her
So
down the
typically,
line.
once the disease responds, lytic lesions, there is a lot of sclerosis that goes on, and maybe then we can switch to a 3 monthly approach depending on
So generally the data is up till 2 years.
at least.
So, and beyond 2 years, again, on a case-to-case basis, if there is complete sclerosis, probably you can stop the zoledronate, shift to 3 monthly. Response assessment. What imaging, would you, you have started TCHP, and we did give her TCH instead of TH. And pertuzumab, she was not affordable, so we did not give her pertuzumab, and we started her on zoledronate along with calcium and vitamin D supplementation. So response assessment on imaging. I'm sorry, it's a difficult case.
Since we've originally done a PET scan, we need to do.
And when will
another
you do
PET
it? At
once the 6 cycles.
after the 6 cycles, everybody agrees to that? And you would assess the response with a PET CT? So that is what has been recommended in the guidelines, the ISMO guidelines as well, that generally you should monitor disease with whatever initial investigation that you have done for your metastatic workup. Now, I just wanted to cover this, and after this, we'll probably stop the panel discussion. What is the role of surgery? She's received her chemotherapy. We did a PET CT, and she had a complete response. And we frequently come across these kind of scenarios. She has response at the primary. She has response to her bone disease. The questions to the surgeons are: what is the role of surgery in metastatic disease? First, let's talk about metastatic disease, and then let's go to oligometastasis. Do you offer surgery in metastatic disease?
Well, in the broader metastatic term, then if you're talking about polymetastasis, then probably for local control of disease, if it's a fungating mass, if it's for a palliation, then sure, definitely. But in other scenarios, I think the results are ambiguous. I don't think we'll.
Yes, please. Yeah.
So there are three very strong indications of surgery in an intact primary in a metastatic breast cancer. One, as Dr. Chaitra said, if it's symptomatic, ulcerating, fungating mass. The second indication is if you have a stage 4, no evidence of distal disease. That is, your distant disease has responded very well to your therapy. And the third is that the disease is progressing, the local disease is progressing. Then also you have to offer surgery, even if your metastasis is not responding.
So
rarely we can even do in cases where I think this disease is progressive, as he said already. But there was one more. I forgot.
So
that
bleeding
thing.
and progression at the primary, which is causing probably symptoms, because if the disease is progressing at the primary, you have a lot of systemic options as well. So I agree, bleeding is one indication, but routinely we would not offer surgery for a metastatic breast cancer. I think we have good evidence to suggest that offering surgery in a case of metastatic breast cancer does not offer any benefit. We have 4 to 5 randomized trials supporting this. What about oligometastatic breast cancer? The question is.
That is what I just remembered, that sometimes if you are treating the primary, it is supposed that maybe the disease progression will reduce, which is not very clear and not always evidence based that it can. So this is one rare selective indication which also can come into the indication of doing surgeries in metastatic, and especially if it is an oligometastatic.
So we really do not have evidence to guide us regarding the role of surgery in oligometastatic breast cancer. And again, initially we had decided the curative pathway. Again, that is very important. And because we have decided on a curative pathway, we are following that pathway. So according to that pathway, you would go ahead and do surgery. So that is what seems logical, but there's very little evidence to back this up.
And irrespective of the response to the metastatic.
Here in this patient, there was response to the metastatic site. So, and because we are following the curative pathway, we would go ahead and do surgery.
Irrespective of that, if there is no
If there is no evidence of progression,
if there is no evidence of progression,
probably
It is, you will have to look at the metastatic site. My understanding would be that in any metastatic disease, the aggressiveness is towards the systemic component.
Yes.
Than towards the local regional part
component of
Yeah.
treatment. So again, a lot of trials, and none of them did show a survival advantage with the use of surgery, except for this Turkish trial, and there were issues with the Turkish trial in terms of randomization. Probably favorable disease were randomized to the loco-regional therapy arm, and that was possibly responsible for favorable outcomes with loco-regional treatments in metastatic breast cancer. So I just want to bring this up. Initially, we did not have any guidance for oligometastatic disease regarding surgery, but the ESMO living guidelines, they have come up with this kind. This is the first time that they have separately addressed oligometastatic breast cancer, and they have come up with this guideline, this suggestion that it might be considered for oligometastatic cases, especially for hormone receptor positive patients and younger patients and those who have a good response. Okay, but this is not backed by any good evidence. I think I'll stop here. There were some questions on.
I'll just like to make like to share two cases of metastatic cancer. One was prostate and one was breast. And old patient told that she's having a breast cancer along with the metastasis. And later, we just found a little high calcium, and then we evaluated. It was primary hyperparathyroidism along with the breast cancer. And we treated her for HPT, and till now, for almost 20-30, she is now normal, no metastasis. We find such patients, so we should be very careful in initial evaluation whether we are really dealing with the metastatic disease. That's why maybe sometimes a biopsy can also help, and degenerative bone diseases, they can also be there.
So again, that's again a case-to-case basis, but not routinely.
Actually, every patient very initially for all these things, and then come to the diagnosis of having a metastasis or oligometastasis.
Duration of systemic therapy. Last question to the medical oncologist. Would you follow till progression, or would you stop after a year of trastuzumab? Last question, sir.
Thank you, sir.
Because I mean, this is what we face day in and day out. I mean, so Animesh, I mean, would you continue till progression or
So, ma'am, if it's a HER2 maintenance, simple HER2 maintenance, question of simple HER2 maintenance along with a CDK, I mean, this is a triple positive disease. Tolerance is not really going to be an issue. So I would tend to continue till progression, but it also depends on the kind of response I received to my initial therapy and the rapidity with which I got it. So if a patient is in CR after my initial systemic therapy and then gone on for local therapy, then maybe like 1-2 years, at some point of time, I will have that discussion with the patient. But then it will have to be a discussion. I do not have any data to stop it.
So again, this is very, very debatable. We don't have right or wrong answers. We have to sit down with the patient and discuss with her as to what to do. Thank you very much, the panelists. And this was a difficult case, but this is something that we very frequently come across in the MDT. And with every case, we are actually challenged as to what to do. Thank you very much, all the panelists. Yeah.
I want to thank you all the presenters, panelists, and chairpersons for their comprehensive and multidisciplinary perspective on the breast cancer management. Now we move on to a sponsored session by Roche titled Maximizing Chance of Cure in Early Breast Cancer Setting. It will be delivered by Dr. Sabaratnam sir. I welcome you on stage, sir.
Good evening, everyone. As an organizing secretary, I'm not preventing you, I'm not stopping you from alumni dinner, actually, but this is a necessity. So initially, okay. So I'll take very less time. I'm not going into, yes, please. So it's a sponsored talk, as I already said. The goal of EBC therapy is cure. Therefore, patients should be given the most efficacious treatment available. Up to 78% of metastatic cases are due to EBC relapse. So breast cancer recurrence has a significant impact on quality of life. And 3 trials, Neosphere phase 2 trial, then we have the Affinity 11.3-year update, and then the Fione trial. I'm not going into the details for reasons. And these 3 concluded that dual blockade is safe. And you have a molecule which has got 2 monoclonal antibodies with hyaluronidase, and it's very convenient to use actually. And the loading dose takes 8 minutes to 9 minutes to inject, and the maintenance dose 5 minutes actually, and very convenient. And and it is proved that it is as efficacious, the efficacy is as good as IV dosing. And so many of us use this molecule, so I am not batting for that molecule. And it has been proved in these kind of trials that patients who received dual blockade, both in early breast cancer setting and in metastatic setting, had different secondary objectives like disease-free survival, and this one good compared to patients who did not receive. So we come to the, so what does FESGO provide in terms of what are the benefits in terms of cost, time, and reduction of patient bar healthcare professional burden? So as I said, shorter time of administration, less invasive administration, fixed dose, not based on weight, and reduced time required for a drug preparation, and it is safe. So with this, I conclude and welcome you all for the alumni dinner, and I hope it took only 2 minutes to finish. Thank you.
Thank you. Thank you, sir, for completing the session within 2 minutes. Thank you all. With this, we conclude today's academic program. Ladies and gentlemen, you are cordially invited to join us to the alumni welcome dinner at the auditorium of SGPGIMS outside. We look forward to seeing you there. We request all the delegates to kindly join us tomorrow morning at 8 a.m. in the same hall for clinicopathological case-based discussion featuring a series of interesting and educational cases of endocrine surgery. Thank you. Good night.